in field of gastroenterology and hepatology. So without wasting any time and more speech, I would start this session. Both the days are going to be very interesting. It is a mixture of esophageal and pancreatic disorders. Along with that, we have also today thought to award few doctors who have done very well in the field of medicine. So be there during the inauguration and award ceremony in the evening. We will also distributing some books which will help the doctors as well as students how to manage your own private setup. So that is book by Dr. Shilpa Chotala. She is a good author. So go through that also. And I wish all of you that for next 2 days, this event is going to be a memorable academic event. Thank you.
Now we will start with our first session on the refractory belching, evaluation and management. I would like to invite our chairperson, Dr. Hardik Parikh, Dr. Shailesh Rawal, Dr. Vijay Maurya, Dr. Vivek Tang, Dr. Sepide Mogadam. I would like to invite our speaker, Dr. Sandeep Pai.
Hello. Now I invite Dr. Hardik Pai to give his speech on given subject, refractory belching, evaluation and management. Sandeep Pal.
So good morning, everyone. First of all, I would like to thank my dear friend Yogesh for the invitation. So my topic is belching, to understand the mechanism, causes, and management of belching. So this is a symptom which almost all of us has experienced in our lifetime. So this keeps on occurring every day. It's that only we don't realize it. When we realize it, and if it is audible, so the definition is the audible release of gas from the stomach or esophagus through the mouth. That's belching. And the other term is eructation. And it is a physiological response to vent air gas buildup in the upper GI tract. And a normal daily event becomes pathological when excessive, persistent, or distressing. That's what I said. It keeps on happening every time. That is that we don't realize it. When you realize it, it becomes a problem. So what is the source of the gas? As we all know, the gas that comes out is primarily nitrogen and oxygen. And the vast majority of gas that leads to belching is the swallowed atmospheric air and not gas produced by the stomach or intestine. Frequently the patient says that it's gas from the intestine or the abdomen that's coming out. But when belching occurs, is the vast majority of gas that leads is to the swallowed air. And the causes or whatever mechanisms that lead to increased swallowing of air that comes out as belch. So belching is primarily an air venting mechanism and it's not fermentation byproduct. So what are the key components involved? So as I will discuss as the slides will progress, you will see there are two types of belching. One is gastric belching and is supragastric belching. So the key components involved in both these mechanisms are the lower esophageal sphincter, the upper esophageal sphincter, and of course the diaphragm. So normally air is swallowed inadvertently during rapid eating or drinking, talking while eating. That's why our grandparents always will say, do not talk while eating because you swallow more and more air and that comes out. Chewing gum or sucking on hard candies, anxiety and hyperventilation or smoking. These are the reasons which leads to aerophagia. So this is the mechanism which we need to understand, like what causes belching. So the belching is primarily air is sucked into the esophagus from the esophagus into the stomach, and there is increased intragastric air. The pressure builds up in the stomach. So when pressure builds up the stomach, there is a normal physiological mechanism which is transient LES relaxation. So whenever the LES relaxes briefly, independent of swallowing to vent the gas, this comes out. So gas passes into the esophagus, and from the esophagus, again, the upper esophageal sphincter is relaxed and gas comes out through the mouth. So this is the mechanism of belch, and the same thing is depicted in the your impedance manometry only. So to diagnose belching, we don't need any investigation. This is a clinical diagnosis. In only very rare circumstances, you need to do pH impedance to diagnose belching, but most of the times it's diagnosed clinically. So it's physiological, as I said, it occurs in everyone, essential for venting swallowed air. The mechanism is transient lower esophageal sphincter relaxation. And sometimes there are associated conditions which can lead to increased belching, like if there is a gastroparesis or if there is GERD, gastroesophageal reflux disease, or physiologically, if someone consumes excessive carbonated drink, then it causes more belching. So clinical evaluation, we have to note the symptom, the duration, frequency, if there is any exacerbating or relieving factors, as I have stated, like the stress, sleep distraction, paying attention, all these things, they tend to exacerbate this condition. And of course, when it occurs very frequently, it has got an effect on the quality of life, like social disruption, embarrassment. It can lead to embarrassment, workplace disruption, and all. So similarly, the other type of belching, which you will come to, like the supragastric belching, is very often associated with psychiatric symptoms. It's mostly associated with psychiatric symptoms like anxiety, depression, or OCD. And if we examine the patient, as I said, the diagnosis is mainly clinical observation of belching, and you can just do a general examination of the patient. No investigations are required to diagnose these conditions. In very rare uh, circumstances or for research purpose, sometimes you might need to do a pH impedance metry that can help in distinguishing the between gastric and supragastric belching. So as I have discussed the mechanism of gastric belching, what is supragastric belching? So almost always this supragastric belching is purely psychological. It's behavioral. It's not physiological. It is a learned habit reflex. Most of the time you will see these type of patients we very often see in our OPD. The patients come, typically a patient will come and they will keep on burping. Continuously they will keep on burping 4 or 5 times and they will say, you press here, burps comes out. You press in the back of the hand, belching or burp comes out. So that is supragastric belching. Here the mechanism is air is quickly sucked into the esophagus and immediately expelled before reaching the stomach. Like in gastric belching, the air reaches the stomach, then there is relaxation of the lower esophageal sphincter, then the gas comes out. That is gastric belching. Whereas in supragastric belching, there is no, the gas does not reach the stomach. It is just sucked in by the negative pressure of the esophagus and then it comes out. That is supragastric belching. And this involves immediate voluntary contraction of the diaphragm and the abdominal muscles. And sometimes this leads to sounds, also massive sound. And a repetitive cycle of air in and out of the esophagus. And this is the cause of most chronic excessive belching complaints. If you remember the impedance graph, which I showed in the gastric belching, and if you compare with this here, the air comes out with lot of force because here the lower esophageal sphincter does not open. So how to differentiate between gastric and supragastric belching? Because this is clinically very important, like in terms of therapy. So gastric belching, as I said, the origin is in the stomach, whereas supragastric belching, the origin is in the esophagus. Trigger of gastric belching is stomach distension, and supragastric belching is almost always behavioral. And frequency is low. If someone belches and if it's origin in the stomach, gastric belching, that's between 5 to 20 times per day maximum. Whereas supragastric belching, it's very high. It can reach up to 100 times. It's a mostly psychological behavioral problem. And this gastric belching, there is not much sound, whereas supragastric belching will often cause very loud, repetitive, and bothersome sounds. So you need to distinguish this clinically. And why differentiation? Why you need to differentiate between gastric and supragastric belching? The reason is because the treatment matters. Treatment focuses on reducing gastric pressure. If someone has got a gastric belching, so you may change the dietary habit or you can give some medicines to decrease the gas in the stomach, whereas supragastric belching is exclusively behavioral. The treatment medications are ineffective. We don't have any medications for supragastric belching. So this is the reason why you need to differentiate between gastric and supragastric belching. So there is a Rome 4 criteria as for all functional diseases. There is a criteria. So for this also there is a Rome 4 criteria. The diagnostic criteria is bothersome belching from the esophagus or stomach more than 3 days a week. Excessive supragastric belching, that is from esophagus, or gastric belching from the stomach. And there should be some supportive criteria, like supragastric belching is supported by observing frequent repetitive belching. Gastric belching has no established clinical correlate. And all these symptoms, they should be fulfilled for the last 3 months, with symptom onset at least 6 months prior to diagnosis, as in all Rome 4 criteria. Just you need to remember this. So as I said, etiology of gastric belching is mainly aerophagia. If you consume food very rapidly, then due to some habits like chewing gum, smoking, ill-fitting dentures, and in patients who are continuously on CPAP, that can also lead to gastric belching. And common triggers for gastric belchings are increased carbon dioxide into the stomach due to intake of carbonated beverages, gas-producing foods like high fiber foods, legumes, vegetables, broccoli, cabbage. It's important to know this because you can advise your patients like the lifestyle changes, because as you know, there are no medications for this. Then there are certain gas-producing foods like high fiber foods, legumes, and broccoli, cabbages, and all this. You can just advise your patients to consume this list. And as I said, gastric belching is often associated with GRD, and due to the transient relaxation of the lower esophageal sphincters. And gastric belching can also be associated with gastroparesis, which is associated very often with idiopathic, maybe idiopathic or diabetic patients, can be associated with functional dyspepsia or hiatus hernia. Psychosocial factors mainly for supragastric belching: stress, anxiety, and learned behavior. And diagnosis, as I said, diagnosis is always clinical. There are no investigations required for this. Esophageal impedance pH monitoring, very rarely, only for research purpose you can use if you find it very difficult to distinguish between the two, but more often than less it's not required. And sometimes you need to do an upper GI endoscopy and gastric emptying scan, suppose you think that gastroparesis is a cause. So coming to the management, we have to differentiate gastric from supragastric belching and treat the underlying cause. As for the problem per se, there are no medicines. If GRD is associated, we treat with PPIs or prokinetics. I'm not going to the details of this. There are a lot of talks later in the day which will talk about this. And for symptomatic relief, sometimes we use simethicone and dimethicone, though there are limited evidence for that. Supragastric belching, the management is purely psychological, behavioral, and it's mainly speech therapy, diaphragmatic breathing. You can teach the patient diaphragmatic breathing, cognitive behavioral therapy, and sometimes PPI. I will just show this. There are various studies which have shown that diaphragmatic breathing is helpful, speech therapy is also helpful, and cognitive behavioral therapy is helpful. I'll show you this diaphragmatic breathing, how to teach the patients diaphragmatic breathing, because this is because as we are gastroenterologists, very often our bread and butter is the functional gastrointestinal diseases. So you need to know how to differentiate gastric from supragastric belching. So this diaphragmatic breathing can be done either in supine or sitting position. One hand should be placed over the chest and the other hand over abdomen above the navel area. The patient should be advised to inhale through the nose and exhale with mouth open, moving only the abdomen. The chest should not move. Slow inhalation and exhalation. Recommend to perform for 5 minutes thrice daily. So in this way, that supragastric belching can be treated, or you can advise your patient who comes with those large sound eructations and belching, which are predominantly supragastric belching. This is one method can teach your patient that's diaphragmatic breathing. And so the medications are, as I said, the medications are ineffective. Goal is to break the learned habit of air swallowing and expelling. And the best approach is referral for specialized behavioral therapy. Yeah, so this is the last slide. So the key takeaways from this talk is diagnosis is key. All chronic bothersome belching is likely supragastric belching. Mechanism differentiates. The gastric belching is physiologic venting, whereas supragastric belching is behavioral air swallowing. Gold standard to diagnose is esophageal impedance, but most of the centers we don't have esophageal impedance and it's not required also. And treatment must be targeted. Medications are not there, as I said, behavioral therapy and diaphragm. Thank you.
Thank you, sir, for an excellent lecture. I think we will take the question and answer at the all after the whole session.
Thank you.
So may I invite next speaker, uh, Dr. Vishwanath Reddy, sir, from Yasoda Hospital, and his topic is on approach to refractory hiccup.
Good afternoon, everyone. At the outset, I would like to thank Yogesh for the kind invitation. Greetings from Hyderabad. I'll be brief enough. My topic is on the approach to refractory hiccups. Click on. Yeah, so sorry. So my topic for today is approach to managing refractory hiccups. So before that, we just go to the basics of it. What is the hiccup? And think most of us, I mean, almost 100% of us would have experienced hiccups at some point of time. It's a very common symptom. And so basically, we'll go through the routine evaluation of hiccups first and then to the refractory thing. So hiccups, you can say, are involuntary spasmodic contractions of the diaphragm, which lead then to the sudden inspiration, and then during the inspiration time there will be sudden closure of the glottis, which will be heard to us by thick sound. So this is the classical description of the hiccup. And as you know, with the uh, normal breathing pattern, when we take inspiration and the chest diaphragm descends, and then at the same time the glottis relaxes uh, so that the air gushes inside. So when we have a hiccup, what happens is when we are taking inspiration, suddenly there will be spasm at the glottis. So the movement at the glottis, that will trigger this symptom of hiccup. So what is the pathophysiology of it? Yeah. So before that, we'll just go to another definition of it. The hiccup is actually a benign and a transient phenomenon, and generally acute episodes last less than 48 hours. And if it is more than 48 hours and to the duration of 1 month, it is called as persistent. And intractable or refractory if it lasts for more than 30 days. So coming to the pathophysiology, there is actually a reflux involved in this pathophysiology of the hiccup. And there is afferent limb, and you have the uh, basically it's the vagus nerve, and also the phrenic nerve, and then the sympathetic chain. All these things take the stimulant testing, and then centrally it is processed at the level of the brain stem, basically the medulla and the reticular formation, and you also have the central part. The temporal lobe is also involved, and then there is the efferent limb. Then once the stimulus goes in, it is processed, and then the efferent, it goes along the phrenic nerve and the diaphragm as well as the intercostal muscles, they contract. And the recurrent laryngeal nerve also is stimulated, which is responsible for the closure of the glottis. So all this is like a reflex arc. And anywhere, if you have any disruption anywhere, any irritation in any of these pathway, you will develop hiccups. There are several causes of it, and you have to look at central causes because you see the reflux arc anywhere you have pathology in the central nervous system, phrenic nerve irritation, vagus nerve irritation. So all there. So several causes have been listed. You can see central nervous system causes vagus or phrenic nerve irritation, and then GI disorders are the most common. Like 80% of the hiccups is caused due to GERD, and you have several other causes like thoracic disorders, you have pleuritis, empyema, you have pericarditis, myocardial infarction, then uremia, a lot of electrolyte deficiency. Hyponatremia is the most commonest cause, I feel, because most of the patients of hypertension receive hydrochlorothiazide combination and they generally come back with hyponatremia and hiccups as a symptom. So you have to look at history, medication history as well. And then a lot of other reasons also are there, but most foremost of them are stroke, pneumonia, pleuritis, MI, GERD, uremia, hyponatremia. These are all the foremost reasons for the hiccups. And coming to the persistent hiccups, it could be a persistence of electrolyte disturbances, encephalitis, meningitis, and then you have any interventions also like atrial pacing, and you have stents inside, post-surgery, and interventions involving the central catheter as well as the ENT surgery as well as ventilation. All these are the causes for persistent hiccups. So how do we evaluate these patients? So you have to go through the clinical things like history is the main thing. You have to look at the duration of the symptoms. You have to then look at the triggers, whether it is the large meal which is triggering it most commonly, you heavy meal, and then you have a symptom of hiccups, and then stress and excitement, over enthusiasm or anxiety also triggers the hiccups. And then associated symptoms, you have to concentrate on that history, like reflux symptoms like burning sensation, belching, and chest pain, cough, bloating, any abdominal pain, also, and neurological symptoms, anything associated like stroke or any Parkinson's or any other things which you can elicit from history. History of weight loss, you can probably point out to a malignancy which can cause hiccups. Medication history, as we discussed, like very commonly we see with many of the drugs which cause hiccups, commonly steroids, then you have chemotherapy agents, you also have some antibiotics, and these can be withdrawn or we can probably substitute them. Then history of a recent surgery, history of malignancy, all of these are known to be the triggering things which we have to take from the history. And clinical examination, you already have to evaluate in this regards, rule out a central cause, a chest, pulmonary cause, or a cardiac cause, or then abdominal, then ENT examination. All these things have to be examined on clinical this thing. And then basic things which we have to do is the CBP just to see for any anemia, leukocytosis, look for any sepsis. And then electrolytes are foremost, like sodium and calcium are very important. And then liver function test and lipase. If there is an underlying pancreatitis with some collection which is irritating the diaphragm and other things. And renal function test is very important. Uremia is one of the commonest reason for hiccups, and arterial blood gas analysis also. And then you have to evaluate in form of chest X-ray, look for any pneumonia, pleural effusion, diaphragmatic hernia, aortic aneurysm, CT, abdominal scan, as well as MRI of the brain if you don't find any findings on the regular evaluation from the chest or the abdomen. So endoscopy, I think, is we have to do in these patients with a prolonged history of hiccups because most often we will find GERD in them, and GERD can be classified into grade A, B, C, D, where the intensity of the damage to the mucosa is increases as the grade increases. And then you can have esophageal malignancy also sometimes can precipitate hiccups. So all these can be found out on endoscopy. Even gastroparesis, GOO, all these things which can cause a gastric distension, which can irritate the diaphragm and the phrenic nerve, can present to us with hiccups. So all this we can do on endoscopy. EUS, you can see if any lesion is irritating the diaphragm or the phrenic nerve, we can find out on that. So management wise, I think basically we have to identify and treat the underlying cause. Symptomatic, we have to look at symptomatic therapy. Most of the time, acute things manageable with symptomatic therapy, and refractory cases, we'll discuss what drugs which we can use, and then rescue options are also there. So non-pharmacology, which we generally suggest for an acute thing, not for a persistent thing, but for acute hiccups, we generally ask for a breath holding or a Valsalva maneuver, supramaxillary inspiration, cold swallows, eating sugar, tongue pulling, pressing the eyeballs and gagging, carotid massage, rebreathing into a mask, and smelling of vinegar. A lot of things have been given, anecdotes, and digital rectal massage, sexual stimulation, and chiropractic, acupuncture. A lot of options are there, non-pharmacological, but they are all like for temporary or an acute episode of hiccups, not for a persistent or a refractory thing. So the pharmacological therapy, I think, as we discussed, like 80% of the hiccups is with GERD. So PPI is the first line of therapy, and you can also give antacids along with that. And then you have baclofen, which it's a muscle relaxant, which acts very well in these patients with hiccups. 5 to 10 milligrams thrice a day can be given orally. Gabapentin is a very good option. And chlorpromazine is the next line, you can say, but it is the only drug approved by the US FDA for the management of hiccups. And it's not largely available in the market, but it's very good drug which wonderfully works in these patients with hiccups. Then metoclopramide is a very good drug, but can be used as a short course, cannot be given as a long term. Oral lidocaine and other antipsychotic drugs like haloperidol, risperidone, amitriptyline, amantadine, and anti-epileptic drugs also can be given. Atropine also can be tried in these patients. Then coming to the refractory therapy, where you have the help from the intervention radiologist, where we can block the phrenic nerve, which is the main thing in the pathway, as we saw in the reflux arc. You can see the brachial plexus and the phrenic nerve is very close to the anterior scalene muscle, and they can identify the sound. The anterior scalene muscle and the phrenic nerve can be identified, and then that can we can inject the phrenic nerve with the local anesthesia for blockage. The only problem with the blockage is that can be temporary paralysis of the diaphragm, but we can manage them most of the time. It's very less actually. It's just a block. We don't cut the phrenic nerve. We just block it. Then vagus nerve stimulation also is an option, and then you have the epidural anesthesia in the cervical area can also be given because C3, C4, C5 is the main efferent area where we can target. And then acupuncture and other options are also available. Post-operative scenario, again, it may be a difficult thing, like you'll have some ileus and distension of the bowels, and so your the prokinetics may not help in such case, but we can try these patients with post-operatively with prokinetics like perinorm or levosulfuride. Mechanical ventilation, it's a problem because if they have a persistent hiccups, there can be dyssynchrony with the ventilator, and then you can have a change in the respiratory this thing. And so patient may develop changes in the CO2 and oxygen mismatch can be there. And so they can also be susceptible for barotrauma. So you have to be careful in these patients, and cancer patients, they generally have a long-term problem. So we have to probably have these GABA analogs for a long term. So if they are longer than for 48 hours, we have to take a careful history and examine them to test and abdomen and neurologically and look at the imaging and lab analysis and then proceed accordingly. So one example of a refractory hiccups, one patient of 60-year-old with CKD on maintenance dialysis came to us with 1 month duration with persistent hiccups. They were persisting even after doing dialysis regularly thrice a week and normal sodium levels. And SCOPY was done elsewhere, which showed normal study. We did the routine evaluation as we discussed, like X-ray, 2D, 2ECG, ultrasound, and they were all normal. So we had done a repeat endoscopy where we found diverticulum in the stomach with the pus extruding out of it. So actually there was a diverticulum, you can see a small bulge here, that a gastric diverticulum which was infected. So gastric diverticulitis, which actually was causing the gastric diaphragmatic irritation and causing hiccups. So this patient actually, we asked for surgery, but she was not candidate for surgery. So we just gave antibiotic course for 1 week and she responded well. So, my take-home message, we have to search for a treatable cause of hiccups. DRD is the most common cause, hyponatremia in the electrolyte, and then you have drugs which can cause. Intractable, you say if it is more than 48 hours, refractory if it is more than 1 month duration, You have several drugs, PPI, baclofen, gabapentin are very good, effective drugs in the management of refractory hiccups. We should not miss out on neurological causes, and then rarely we can have psychiatric causes as well. But generally, these hiccups won't be there in the sleep duration. So you have to ask in the history about whether the hiccups are persistent in the sleep time. And then you can consider phrenic nerve block if it is refractory. Just an opportunity. We are organizing a conference in the coming month. We invite you for that. Thank you all for patient hearing. If you have any questions, you can. Thank you.
Thank you very much for the place. The next speaker, Pankaj Singh, he's going to present approach to refractory vomiting. He's from Max Super Specialty Hospital, Delhi.
Good afternoon, everyone. I'm Dr. Pankaj Singh from Max Super Delhi. At the outset, I would like to thank Dr. Yogesh and team for the opportunity. I've been asked to talk on approach to refractory vomiting. I'll be presenting on approach to refractory vomiting. So I'll be starting with a case scenario. This is about a 43-year-old female without any comorbidity. She came with history of persistent vomiting lasting for more than 1 week. The frequency was around 6 to 8 episodes of vomiting per day, leading to a state of dehydration, requiring IV fluid and hospitalization. She had a similar history 6 months back, and now she had already been consulted by a physician who treated her with PPI and other standard antiemetic, but still she did not respond. There was no history of dysphagia, no reflux episodes, no weight loss, no history of recent travel, or any food intolerance. Now, what do you think she has? So if I talk about the syndromic diagnosis in this case, see the case of refractory vomiting. Refractory vomiting is defined as an ongoing or recurrent vomiting despite adequate use of conventional antiemetic drug. It often lasts more than 48 to 72 hours, leading to a state of fluid and electrolyte imbalance, nutritional imbalance, and impaired quality of life. So before moving to the approach, little bit about the pathophysiology of vomiting and the mechanism. So when I talk about pathophysiology, we need to know about two things. First is the vomiting center, and second is the stimuli. So the vomiting center consists of a complex structure in the medulla, which consists of area postrema. Area postrema is a specialized structure in the medulla oblongata. This is outside the blood-brain barrier. So they are very much easily exposed to the chemical stimuli in the blood and the CSF. Apart from this, the other structure is the nucleus tractus solitarius, which is the core structure which receives input from area postrema, cortical centrals, vestibular apparatus, and the peripheral gut stimuli. They reach up to the nucleus tractus solitarius. And this nucleus tractus solitarius gives processes these signals and send it to dorsal motor nucleus of vagus, which finally gives the efferent signal and triggers a episode of vomiting. The second thing is about the stimuli. The stimuli can be cortical stimuli, which can be like pain, fear, stress. All these can be cortical stimuli. Second stimuli can be from the vestibular apparatus like motion sickness, labyrinthitis, can all give stimuli to the vomiting center. Third can be the chemical stimuli in the blood like chemotherapy or other toxins after bacterial infection. And fourth can be stimuli from the gut. So this is all about the pathophysiology of vomiting. Now coming to the approach to a patient with refractory vomiting, first step is to identify the cause. And for this, we need to have a comprehensive history and physical examination, which is important. And with this,
we can identify more than 50% of the causes of refractory vomiting. Now, in detailed history, we need to know about the onset of the vomiting, which can be sudden onset, gradual onset. Duration, less than 4 weeks is acute vomiting, more than 1 month is chronic. Frequency can be occasional or it can be cyclic in cases of cyclic vomiting syndrome. We also need to know the content of the vomiters, which is very important. It can be bile, it can be blood, it can be food particles and equivalent, which all describes or gives us some idea about the cause. Like if it is bilious vomiting, it could be proximal gut obstruction. If there is food particle or blood, it could be from the gastric source, like peptic ulcer disease. Equivalent can be distal gut obstruction. Nature is also very important. Projectile vomiting gives us clue regarding intracranial cause. Timing, if it is an immediate vomiting after taking meal, it could be psychogenic or gastric obstruction. If it is an early morning vomiting, it again gives us clue regarding the intracranial cause. You also need to know about the relationship to food, headache, stress, history of drug, chemotherapy in the use or alcohol, association with pain, fever, weight loss. These are very important history we need to take, and we have to be very elaborate in taking the history. Next is the examination. We should examine the vitals to look at if the patient is dehydrated, whether there is any shock. General examination, weight, BMI, nutritional status. Abdominal examination, we need to see whether there is distension, tenderness, organomegaly. Neurological examinations like examination for papilloedema, focal deficit, or meningeal health. And then systemic evaluation. And then how to investigate. We should start with the basic labs, including CVC, electrolyte, kidney function tests, glucose, calcium. Imaging should include an X-ray abdomen, ultrasound, MRI, brain abdomen. Special investigations should include endoscopy, gastric emptying for gastroparesis, endocrine and ENT evaluation for vestibular cause. And then we also, in some rare situations, we also need to screen for the toxins on autoimmune tests and pregnancy to rule out causes for refractory vomiting. So with this history examination, we are, in most cases, we are about to pinpoint or suggest about the possible causes for vomiting. And broadly, this can be divided as gastrointestinal cause like gastroparesis or obstruction, neurological cause like raised ICP, meningitis, vestibular disease, migraine, metabolic cause like diabetic ketoacidosis, uremia, hypercalcemia, adrenal insufficiency, drugs like chemotherapy, dioxin toxicity, opioids or antibiotics, and then finally, psychogenic or functional cause like cyclic vomiting syndrome or eating disorder. Now, in the second step in the approach to refractory vomiting should be to understand the underlying mechanism and also to have an idea about the neurotransmitter or the receptors involved. This is important because it helps us to pick the drug with specific receptor target. Like if we have an idea that the patient is a case of chemotherapy or if there's a chemotherapy in this vomiting, we also know that the culprit neurotransmitters are either serotonin or dopamine. And this also helps us to understand and give a specific specific therapy like serotonin antagonist or dopamine receptor antagonist. Likely, if there's a vestibular cause, we can start straight away with antihistaminic or anticholinergic. Raised ICP, we can start with dopamine antagonist or steroids. And functional and GI disorder, we can start with serotonin blocker or substance P antagonist like NK1 antagonist. Now, corticosteroids are not typical antiemetic, but they have a very strong or good antiemetic property, and they are not used alone. They are mostly used in combination with other drug or other antiemetic, and they are useful in conditions like chemotherapy-induced vomiting, postoperative nausea vomiting, and in cases of raised ICP. The mechanism by which the steroid act as antiemetic is by acting or inhibiting the prostaglandin cycle, directly inhibiting the vomiting center, interacting with other neurotransmitters like serotonin and neurokinins, or regulating the HP axis directly. Now coming to certain case scenarios, these are hypothetical case. Now case scenario number one, I described about a female of 43-year-old. Supposedly this patient has come to us with a complaint of abdominal distension, colicky pain abdomen. There is no bowel movement for last 2 days. On examination, she is dehydrated. There is a high-pitched bowel sound. An X-ray is showing multiple air fluid level. So this is a very typical case of intestinal obstruction. Second case scenario can be, suppose see the case of diabetes, which is uncontrolled, associated with pain, abdomen, vomiting, dehydrated. On examination, there is Kussmaul's respiratory patterns. Blood investigations or lab shows high blood sugar, acid pH is 7.1, acidic pH, ketonuria. So this is a case of diabetic ketoacidosis. Third scenario can be severe morning vomiting, nausea, right-sided weakness, visual blurring, on examination, papilloedema, focal deficit, and MRI showing intracranial tumor. So this is because of raised ICP due to intracranial tumor. Fourth scenario can be recurrent history of vomiting in past 4 to 6 weeks. And now coming with vomiting for last 2 to 3 years, history of stress, all other examination is normal. So this is a typical case of functional or cyclic vomiting syndrome. Last is scenario is history of breast cancer with history of chemotherapy like cisplatin or paclitaxel, presenting with non-villous, non-bloody vomiting, dehydrated, abdomen is soft, lab shows high creatine, low potassium, and normal liver function test. So this is a scenario of drug-induced refractory vomiting, especially cisplatin is the culprit drug in most of the cases. So these are the different etiological attributes which we can have from the history. Now coming to the management first would be a general principle that would include stabilizing the patient with IV fluids and electrolyte management. Secondly, we need to identify the cause and treat the underlying cause. We also need to give the symptomatic treatment with antiemetics and PPI as and when required. Nutritional assessment is very important. We need to stabilize the nutritional with NG feeding, parental nutrition is severe in severe cases. Endoscopic and surgical interventions also required as and when required in cases of structural obstruction. Novel therapies like gastric pacing is required in refractory gastroparesis and palliative measures for advanced cases. Now, these are the common pharmacotherapies that are used in cases with vomiting. Most common category is the 5-HT3 antagonist. Commonly used drug is ondansetron, which we commonly use. Other drug in this category is granisetron and palonosetron. Second category is dopamine antagonist. The commonly used drug is metoclopramide. Apart from this, we also use chlorpromazine, haloperidol, other drugs. Third category is, and fourth is antihistaminic, antimuscarinic. And then neurokinin 1 antagonist. These are commonly used in the background of chemotherapy-induced refractory vomiting. As I said about the steroids, these are also anti-emetic property. And lastly, cannabinoids are one group of drugs which are agonist. They have agonistic property to the receptors, and they also have anti-emetic property. Now, coming to a case of refractory vomiting, in this case, we need to ensure that the anti-emetics are given in an adequate dose and they're given round the clock. Second, we can change to the alternate route, like we can switch over from oral to IV or maybe IM, replacing the patient are not responding. Third, we can combine anti-emetic combination therapy helps in blocking different receptors. And lastly, we can switch to alternate medicines like olanzapine or NK1 neurokinin receptor antagonist, which might also be helpful. Now, coming to the principle of combination pharmacotherapy for refractory vomiting, the principle is that we should be targeting different receptors and neurotransmitters, not the same receptors. And like in chemotherapy-induced refractory vomiting, we can start with ondansetron. No response, we can add NK1 antagonist like aprepitant or maybe dexamethasone. In post-operative nausea, vomiting, refractory cases, we can start with ondansetron with metoclopramide. If not responding, we can add steroids. In vestibular or motion sickness, we can start with antihistaminic like dimenhydrinate. Can add on metoclopramide if they are not responding. Raised ICP or metabolic cause, we can start with ondansetron. Can add metoclopramide plus minus steroid as and when required. And in GI cause or functional cause, again, ondansetron plus metoclopramide plus minus a prokinetic like domperidone. Now, this is a practical step where we can start with one agent, like ondansetron is a maximum dose of 4 to 8 milligram, 6 to 8 hourly, or metoclopramide can be the initial starting drug in the dose of 10 milligram, 6 to 8 hourly. No response, we can either combine both. And then if still no response, we can add steroid. Lastly, in severe cases like chemotherapy, we can use induce vomiting, we can use NK1 antagonists like aprepitant. So we should also be careful in combining drugs that we need to monitor the QT interval, like drugs like ondansetron and metoclopramide both can prolong the QT interval and cause ventricular tachycardia. We should avoid overlapping sedative drugs. And if all standard therapy fails, alternate drugs like olanzapine can be useful. Now coming to the specific management, these are the case scenarios we already discussed. In small bowel obstruction, we need to give IV fluid and NG decompression and surgical intervention. Ketoacidosis patient, we also need to give insulin infusion, IV fluid, electrolyte management. Raised ICP, neurosurgical intervention, steroids and mannitol. Cyclic vomiting syndrome, counseling and anti-migraine therapy can be useful. Drug-induced refractory vomiting, discontinuation of the drug or dose adjustment, along with atypical anti-emetic like NK1 receptor antagonist olanzapine can be used. Red flag signs should be seen for or looked at like hematemesis mellitus, severe abdominal pain, neurological deficit, intractable dehydration. So life-threatening causes should be ruled out early. Lastly, to summarize, refractory vomiting is not uncommon. Comprehensive history and physical examination is the key to identify possible cause in most of the cases. Understanding underlying mechanism helps us pick specific drugs, receptor-specific therapy. Stepwise approach should include symptomatic relief with antiemetic therapy and also to treat the underlying cause. Standard therapy is not useful. We can consider combining antiemetic therapy targeting different receptors. Thank you.
Pankaj, please be on stage. So now we have 3 minutes for question and answers. All this symptomatology we see each and every day, not only with general practitioners, with physicians, surgeons, even gastroenterologists. And many times it happens that gastro also doesn't have the answer because patient doesn't have anything. It is functional. So questions are invited.
All the three speakers that I think the lectures was very excellent. So my first question to sir about in a practice when patient comes with belching, I usually determine that this is a gastric belch or it is a supragastric belch. I think that we need to understand for the general physicians. And the most important, which patient should be prescribed PPI, which patient should be prescribed upfront in a first visit, because many of the times they come already with the medicine. So PPI prokinetic, or you just give a reassurance. So that is just a message.
So for treatment of belching, as I said, there are no drugs for belching. So if it is gastric belching, sometimes it might be GRD. So in those cases, you can give one PPA or sometimes prokinetics. For supragastric belching, there are no medicines because it is completely a behavioral problem because there the air is sucked in, the air is sucked, they get it out. So as like only this diaphragmatic breathing, if you can teach these patients, very rarely for belching, suppose someone has got lot of flatulence and bloating associated with that. So my personal experience is simethicone and dimethicone, this works good. So simethicone and dimethicone combination is also available. So we don't have much evidence for this, but still this does.
So I think take home for this, the diaphragmatic breathing video that sir showed, that you can incorporate in your clinical practice if you suspect a supragastric bleed. That should be the message.
Abhinav is a point.
Yeah, nice thoughts, Sandeep. So do we need to document it with end of 3% method, number one, number two, when we should decide to refer these patients to psychiatrists?
Supragastric. Yeah, as I said, see, if you can distinguish that this is a supragastric and not gastric, because it is a completely a behavioral problem. So we can, most of these problems we can treat. Suppose someone has got a very refractory symptom that you can sometimes refer to psychiatrist. I usually, to tell you frankly, I don't refer my gastric patients, even IBS patients to psychiatrists. The simple reason being the psychiatrists, they don't prescribe one or two drugs. They will prescribe 5 drugs. And ultimately, these patients will be on these drugs. So I try to explain them.
Yeah. So my question is to Dr. Vishwanath. Sir, I mean, practically, in a patient with refractory hiccups, do we have any data that in how many patients do you actually find the organic cause? Because the causes are so many, right from the brain to your neck, chest, stomach. So patient who comes with refractory hiccups, what is the basic investigation that you do? Usually, in my experience, you don't get any localizing signs in such. Yeah. So the list is very extensive. So how do you approach it?
Yeah, I think it's actually clinically difficult scenario where you find the reports and you don't find anything on clinical examination on history as well. But like as we discussed, like stepwise, we can go for evaluation from abdominal causes and then chest causes and the neurological causes. I think it's definitely an expensive thing to approach each organ evaluation. Like, it's not like a regular thing. The number of patients coming with refractory shock is always less only. But yeah, as you said, finding out the exact etiology may be little difficult in them. But we need to do a stepwise approach in all these patients. And there is no actually a comprehensive review on these refractory hiccups patients. It's only the case reports and case series which have been published as of now. So there's no exact guideline as well as of now from the major societies. So because the number of cases are very less, refractory. So as you pointed out, they are difficult to find out the exact etiology, but like stepwise evaluation is the main thing. And yeah.
In practice, what I have seen, if I have come across in a year of 10 patients of pickup, 5, 6 have esophagitis, 1, 2 have a uremic issues, and hyponatremia may be contributing factor. That is what I see in a practice of this majority of patients of hiccup. Otherwise, they have a refractory hiccup due to gastric distension or some. In that case, we usually end up with treating with baclofen or fluotromazine. That is what.
Thank you, sir, for the amazing session. Now we would have a case-based panel discussion on the approach to dysphagia. I would like to request our panelists to join the stage. Dr. Srihari Akhinindi from Sri Gangaram Hospital, New Delhi. Dr. Sandeep Shah from Gastro Plus Hospital, Ahmedabad. Dr. Saumin Shah from Gujarat Hospital, Surat. Dr. Sandeep Pal from Narayan Hospital, Kolkata. I would like to call our speaker, Dr. Naveen Polarapu, for the case discussion.
Good afternoon, everyone. At the outset, I would like to thank Yogesh for the kind invitation and also Noble Hospital for inviting us here. And it's always a pleasure to be back in Ahmedabad. This is, I think, my fourth visit, and always have some good memories of Ahmedabad with all the savories and stuff. So my topic that was given to me was about approach to dysphagia. How are you going to evaluate in a clinical practice? And with me, I have an esteemed team of colleagues with me. Srihari, Sandeep Shah, and Saumin. Sorry, I didn't put your name over there because I think finally it's changed the list a little bit. And Sandeep, I think Sandeep is busy with Sandeep is busy with taking pictures. So we'll call him it later. Okay, so what is dysphagia? So I think first at the outset, the first important thing which I want to tell you all is whenever you see a patient with dysphagia, this patient has to be referred to a gastroenterologist. So if you want to take a clear message, I think that's the first important message that we all should understand, that dysphagia, this needs to be evaluated. This cannot be ignored. That's very, very important point. Okay, so what is actually dysphagia? It's a Greek word which says that dys means difficulty and phagia means to swallow or eat. So whenever we're having any difficulty in swallowing, that is what is called as dysphagia. I'm sure you all know what is differentiation between dysphagia and dysphasia. So dysphagia is about swallowing when you're not able to swallow food properly, when that is from the mouth to the stomach, we call that as a dysphagia, right? So I'm sure we all spoke about this in our medical school days. Whenever there is any obstruction to any luminal structure, what we look at is when we evaluate a patient, we look at intraluminal cause of obstruction. Like, for example, if there is any mechanical obstruction like a malignancy or a tumor, cancer blocking the lumen, or it could be a food bolus obstruction or whatever the obstruction is. It could be luminal obstruction, or it could be the motility itself, the muscle itself is not contracting and relaxing properly. And that's why you can actually have a poor peristalsis and therefore have dysphagia also. Or it could be an extrinsic compression from outside structures like mediastinal masses. These all can cause compression to the esophagus and lead to dysphagia. So intraluminal, muscular causes and the extraluminal causes, that's what we need to evaluate whenever we see a patient with dysphagia. So often this is what patients come and say to us that food gets stuck in the food pipe, whether it is in the trichopharynx, in throat, or whether it is in the cervical area, or whether it is in the food pipe distal, the lower part of the food pipe as well. So this is what we call as dysphagia. So they say that food won't go down, gets stuck, it gets hangs, it gets stops over there. This is generally what we see as dysphagia. And again, as I mentioned there, it could be either oropharyngeal dysphagia or it could be an esophageal dysphagia based on the location. Most of the times, if you actually take a proper detailed history, we should be able to find out where exactly the blockage is, whether it's oropharyngeal or the dysphagia in the esophagus. So this question to Dr. Srihari. So when a patient comes with dysphagia, obviously as we discuss about the symptoms, but are there any other, what symptoms would you see a patient when they come with odynophagia or globus hystericus? What are these definitions, globus hystericus and odynophagia?
So I it's pretty important aspects of an patient who comes to you with dysphagia, because that is the point where you are able to narrow down on your differentials. So there is a big difference between
This and dysphagia. So pulpus is when a patient something is something is stuck in the throat, but when he does the swallowing attempts, his symptoms improve. And dysphagia is just the opposite. Dysphagia is when the patient is trying to swallow, the problem aggravates. He is not able to swallow the. So in a globus, when the patient is swallowing, it improves. So it's more psychological. Globus is usually psychological. Odynophagia, on the other hand, is when the patient is swallowing and also has a pain associated with the effort of swallowing. That is where you have odynophagia. Now, patients with dysphagia sometimes can have some atypical presentations like nasal regurgitation. This is especially common in patients with achalasia. They usually present sometimes with nasal regurgitation, or they are sleeping at night and they wet their beds because there's something dripping out of their noses. Repetitive coughing is one of the problems. Patients with oropharyngeal dysphagia can have problems with speech. They can have a nasal twang to their voice or drooling of saliva or coughing. So you have to look into these atypical symptoms also whenever a patient who comes to you with dysphagia.
Absolutely. So not just only dysphagia, odynophagia, globus hystericus, all the other atypical presentations of dysphagia are also very important to go through it. So I think we cannot stress the important point to say that location, physics, history is very, very important. History will tell you about almost 80 to 85% of the time you're able to make a diagnosis if you get a careful history about dysphagia. Location, what is it dysphagia to solids or liquids? Is it progressive, non-progressive, are the symptoms intermittent or any aggravating symptoms, which we all evaluate whenever we have any kind of a symptom. So I think it's very important that we go through that in detail. So just the one point to say that oropharyngeal dysphagia and esophageal dysphagia are two different areas that we actually, again, if you take a proper history, we should be able to differentiate them. So one just point about peristalsis. Whenever you swallow food, the wave that happens is the peristalsis, that's called primary peristalsis. And secondary peristalsis happens because local distension, and that's what we see for secondary peristalsis, the food moves forward, downwards. Tertiary contractions are non-progressive contractions, and they are disordered contractions, which doesn't actually have any clinical significance in terms of the motility or progression of the swallow. So based on the grading, so grade 0 to grade 5, based on if they have unable to swallow is grade 0 and grade 5 is if they are able to swallow normally. Okay. So next question is Sandeep. Um, so if you see a patient with oropharyngeal dysphagia, we're talking about oropharyngeal only. So in a young patient, I mean, what is a typical presentation of common scenario or a disease that we expect that in in an elderly patient and in a younger patient and then in an elderly patient?
Yes. So in a young patient, I think first thing we need to differentiate whether it's a mechanical or not. Like in mechanical, sometimes the post-before PAPE, the pharyngeal part, and sometimes even the lower symptoms like esophagitis also. Patient always complains that he's having dysphagia here or something, but we obviously think of the esophageal disorders also, like the esophageal can be done. In a elderly patient, the oropharyngeal dysphagia has a very etiology, particularly the neurological one. Like we have to think of, if it is the motor, then we have to think of Parkinsonism, motor neuron disease, even the brain stem strokes and all those etiologies, which can really, and obviously we should not forget to rule out the malignancy, which is quite common in elderly. And in young patient, many times the globus hystericus is the commonest thing where we don't have any the etiology like, but the patient have those complaints. So it's quite common in young patients. Absolutely.
Thank you. So I think in younger patients, cervical webs are common to have an oropharyngeal dysphagia. We're talking about oropharyngeal area. In the elderly patients, as Sir says, it is CNS causes, which are most common causes of dysphagia. Okay, and in fact, stroke is the most common cause of oropharyngeal dysphagia, especially in elderly patients. They do have this stroke later, and these are all the causes listed of causes of the oropharyngeal dysphagia, varying from neuromuscular to structural causes. And as I said, do not forget carcinoma is one of the differential diagnoses, even for oropharyngeal dysphagia, particularly in elderly people. Just don't label it as a neurological cause and do not ignore doing an endoscopy for these patients. And as I kept mentioning, the first and the only point which I want to remember, if you have to, is dysphagia. Any patient with dysphagia, difficulty in swallowing, it has to be referred to a gastroenterologist. Because even for us also, unless we do endoscopy, most times we may not be able to find out the reason for them. Okay, so coming to the esophageal cause of dysphagia, and again, as I said earlier, it could be mechanical obstruction because of luminal obstructions, or it could be because of the motility disorders itself. So, question to Sandeep. So, in terms of whenever we have a dysphagia because of esophageal causes, are there any clues to differentiate different types of dysphagia? And for example, certain kinds of diseases will have more problems with solids more than liquids, and vice versa. And some of them have both and progressive and non-progressive. So can you well elaborate on those points, please?
Yeah, so to differentiate between the causes of dysphagia, like if there is esophageal motility disorders, then usually the patients have dysphagia to both solids as well as liquids. Sometimes solids can go because of its weight and gravity, but they have increased problems with liquids. Whereas if there is a mechanical obstruction, so almost always the problem is to solids, and liquids usually pass through unless there is a absolute dysphagia. Sometimes, of course, there is a narrowing, and on top of that, there is a food bolus infection happens. And sometimes it might so happen that the patient, even with mechanical dysphagia, suppose due to malignancy, they may not be able to swallow liquid also. And also sometimes peptic strictures, patient have a long-standing history of GRD, reflux, heartburn. So that might help us to distinguish. And of course, the other associated symptoms like weight loss, anorexia, they can point to malignancies.
So, as Sandeep says, if we have difficulty both liquids and solids, that would be most likely motility related. If there's a mechanical obstruction, generally we see that obstruction with the solids more than liquids. And also, if there's eclasia, sometimes you have more with liquids compared to the solids. Because with eclasia, you have a gravity which actually pushes the food down. So solids go easily, but liquids have difficulty in swallowing down. And again, symptoms-wise, progressive, non-progressive. If it is progressive, obviously concerning things like malignancy has to be kept in mind. Non-progressive could be webs, Schedtke's rings, all these things can also be a cause for the non-progressive dysphagia. So, like as I mentioned, that rings and webs can also cause dysphagia, but they are non-progressive. Generally, we see that mainly with the solids, sometimes with liquids as well. So, question to Samin. So, would you treat all the webs and rings?
Usually, any ring or a web which is producing the symptoms, that needs a treatment. Okay, and it is a very simple treatment, and you can diagnose and you can treat at the same time. Okay, and if there is a multiple ring, and if you think of eosinophilic esophagitis, at that time, I think you should be a careful dilatation, or you should take a biopsy first to confirm that is it a eosinophilic esophagitis or not, and then plan dilation, because that treatment is totally different. But simple Plummer-Wilson syndrome or Schwartz's ring that is producing the intermittent dysphagia, you diagnose, and time you dilate, and matter is over. It is a therapy.
Absolutely. Symptomatic endoscopy related dilatation problem most times should do the job, but please make sure that eosinophilic esophagitis is a different entity. You do not want to dilate the esophagitis unless you are very clear about it. The risk of perfection is very high with eosinophilic esophagitis. That's what someone is trying to mention there. So, question to Srihari, we'll come to Srihari. So, does all patients with dysphagia need investigations, or can they wait? Or in what cases of dysphagia can we wait without doing an endoscopy? And what are the red flag symptoms in your scenario?
So I think any patient who comes to you with dysphagia, you cannot ignore it. You cannot wait in a patient who comes with dysphagia. You have to investigate it, because dysphagia is never normal unless it's globus. So globus is different. If a patient complains to you classical dysphagia, you have to investigate it. And the first investigation of choice obviously would be an endoscopy. More often than not, that dysphagia will be associated with some red flags like weight loss, decreased appetite, or hematemesis sometimes. So I think dysphagia itself is a red flag, and there can be some associated red flags. So a patient comes with dysphagia, you have to invest, no doubt.
Again, as we all been saying from the start, dysphagia means it needs to be evaluated. It is itself is a red flag symptom, as Sri mentions clearly. So, so any dysphagia has to be investigated. Okay. Sometimes, yes, in a patient with a neurological causes of related dysphagia, we may not push and rush and do an endoscopy for them. but definitely it needs to be run by a gastroenterologist so that we understand what is the nature and what are the causes, what are the associated symptoms, so to exclude other causes of dysphagia before labeling it as a neurological causes. Physical examination, I don't want to bore you with that. Generally, if you have C. esophagus, carcinoma esophagus, you may have lymph node enlargement, scleroderma, motility disorders, you can have especially CREST syndrome, you can have physical examination findings. And surgical scars, post-anastomotic strictures, you can have these findings on the physical examination. So this is what we've been talking about. So esophageal dysphagia, if there are types of bolus with solids only, then the progressive, then it could be carcinoma, non-progressive, it could be peptic strictures. If they are solids and liquids, it's very likely going to be motility disorders. So coming to the modalities of investigation, these are all what we have investigations-wise. The barium swallow, the good old barium swallow. And we obviously have the endoscopy, which is the gold standard. We also have the manometry and also the scintigraphy scans. So question to Sandeep Shah. So does any of these modalities suffice? Only one modality does it suffice, or do we need to combine them? In what circumstance would you say only one investigation? And would you consider barium over endoscopy in any certain circumstances?
Yeah. Actually, I would say it stepwise approach. I think the first of thing we should do an endoscopy. Then, if we don't find any mechanical cause, then obviously we should do a manometry. If in a manometry, the findings are atypical, means like not sufficient to say an achalasia or EGG or flow obstruction, then definitely a timed variant is one thing that we should look into. I think we hardly need a scintigraphy for further evaluation. I think first three are sufficient.
Yeah, absolutely. So stepwise approach first will always be an endoscopy as modality of choice. The endoscopy doesn't give us the answers, then motility. Then if it doesn't give us the answers, we especially think of extraluminal obstructions, then you may want to go for imaging like a CT scan. But otherwise, endoscopy is by far the standard approach for our patients with dysphagia. So how to differentiate between benign versus malignant strictures, particularly in on a barium study, for example?
So conventional where we have the radiologist who report nicely that being a typical shouldering sign of a days we have the endoscopy available quite extensively, like even on the remote place. So I think for the per primary diagnosis we do barium, but yeah, if you say yeah, soldering typical soldering sign, we can say it's malignancy. In benign, we see more of a tertiary contraction above to diagnose things. Endoscopy. So,
yeah, as Sandeep says that we're not doing bariums that many because of the readily available endoscopes these days. But benign strictures generally are smooth strictures, whereas malignant strictures are regular shoulder strictures, as has been mentioned. So this is what we're talking about, shouldering stricture, which says that there's infiltration of the malignancy to the existing structures. And this is a benign, smooth stricture on the barium study. Okay, so barium swallow generally useful as a supplementary test after the endoscopy, generally particularly in upper esophageal or the cricopharyngeal area abnormalities, or if you're looking at motility disorders like achalasia, these are all complementary tests. So for example, if you want to diagnose achalasia cardia, you should have endoscopic findings along with that manometry and also the barium swallow study, which should say that is achalasia. I think the barium swallow probably outscores compared to the endoscopy in particularly oropharyngeal, as I said, the video fluoroscopy, which is very helpful. It's a dynamic study which tells us about how the swallowing reflexes as well. So that's the only place where probably the barium swallow outscores on the endoscopy. But however, still we need to do the endoscopy. So this is a typical Sudsky ring, how it looks like on the barium study and on the endoscopy as well. And this is the esophageal web, how it looks like on the barium and also on the endoscopic findings. Okay, so endoscopic evaluation wise, how, endoscopically, how would you differentiate between a malignancy versus a benign stricture? Does it give any clues to you as soon as you see a patient with endoscopy? This is a malignancy, this is non-malignant.
So I think the same corollary that you see on the barium. So in a benign stricture, the strictures usually appear smooth and there is a gradual taper. Whereas in a malignant stricture, they are irregular, there is associated alteration, and there is a sudden change in caliper, the same shelving that you see. Regarding your second question, do all strictures need biopsy? Yes, there's no doubt about it. If you see a stricture, it has to be biopsied. Sometimes with a conventional biopsy, you're not able to pick up the diagnosis of a stricture because the pathology lies slightly beyond the stricture. And I think in such cases, practically, a US guided FNAC of that lesion beyond the stricture is also quite useful in clinical practice.
Yeah.
And that was the third question.
How many biopsies would you do?
So how many biopsies to be taken? So one, ideally, even one single good biopsy is good enough for diagnosis. There's no convention to that. But I mean, if you talk of a specific condition like eosinophilic esophagitis, sometimes you might see pathology, sometimes you might not see anything on the endoscopy. So in a eosinophilic esophagitis, what is recommended is that you should take biopsies above the, not above the G junction, but somewhere in the mid or the upper esophagus at multiple sites.
Four quadrant biopsy. So another modality that we use is the manometry, which is basically primarily very helpful for motility disorders like eclasia. Obviously, first you need to do endoscopy to exclude any mechanical obstruction or luminal obstruction related causes before you put this patient for manometry. So do not blindly ask for a manometry in a patient with dysphagia. Dysphagia modality of investigation always is going to be first careful history taking, localizing symptoms. Then second thing is about doing an endoscopy. The endoscopy doesn't give us the answers, then go for the manometry. So this is the modality of investigations. If manometry also doesn't give us the answers, then you go with the barium swallow. So modalities wise, in terms of benign peptic stricture, so types of treatment modalities and types of dilators that we use, we have different types of dilators. So here
there are two basic type of dilators that we use. One is the bougie dilator, which is like a silicone kind of a tube which you insert, or a PVC kind of tube which you insert, and the other is a balloon dilator, which typically goes through the scope. So when you inflate the balloon, the stricture dilates. So the difference between the two is that the balloon dilator only offers you a radial dilatation, whereas with the bougie dilatation, it is both the linear as well as the radial dilatation that appears. And one of the biggest advantages of using a bougie is that you get a tactile sensation. So when you are going beyond the stricture, you get a sensation on your hand, whether you have actually negotiated that stricture and how much pressure do you need to apply. That is absolutely absent when you use a balloon dilator. So in general, I think bougie dilators are preferred over a balloon dilator. The balloon typically is for some very focal strictures or distal strictures.
Yeah. Short strictures, focal strictures, balloon dilatations. Otherwise, multiple strictures, long strictures, proximal strictures, always try to use a UG dilators. And these dilators are very safe. And as I showed you on on this picture, that the perforation rates are very, very low. We're talking about 0.5% risk of perforation with these dilators. And most of the places that we use actually fluoroscopy as part of passing the guide wire and then dilate over the guide wire. Majority, and that's what we do. But there are centers where they don't have X-rays. For example, I was recently to a country in Mozambique, Maputo. So they don't have any fluoroscopy. They dilate even the malignant strictures endoscopically as well, which does have a risk of perforation with it. But otherwise, if you have a fluoroscopy X-ray machine, always use the fluoroscopy to guide the wire so that you actually are convinced that you're actually beyond the stricture before you dilate it. So this is one case from Somalia. She's 14-year-old and she's been literally living on camel milk for the last 14 years of her life. I mean, she never had any solid food. She came to us, and then when we did it, it looks like a benign, smooth stricture, right? There is no nodularity, there is no ulceration, there is no growth. So the benign, smooth stricture, we did a barium, confirmed again as a smooth stricture. Then we dilated sequentially, and then just with endoscopy dilatation, we were able to solve her problem without going for any surgery for these patients. So this is a study which said perforation risk is very low, but of course, if you have malignant stricture, risk of perforation is going to be high. So do not dilate any malignant strictures. It is only the benign strictures. Again, whenever you see a stricture, always biopsy, please. Without biopsy, we cannot be sure what the lesion is. We may be able to be more or less confirm that it is a benign based on or malignant based on endoscopy findings, but always biopsy is mandatory before you do any kind of therapy for these patients. Okay, so coming to corrosive injuries, what are the absolute contraindications for corrosive injury, or when would you say it is not safe for a corrosive industry?
Actually, in a corrosive, 3 days to 3 weeks, we should not do an endoscopy after 3 days to before 3 weeks, because there is lot of friability, and the corrosive has involved the deeper layer by the time.
So there are high chances of perforation if you do OPs. Yeah, in an approach to a malignant structure, here esophagus. So I think the first thing is take a biopsy. Then obviously to do a staging, whether by an a CT scan or a PET scan, whether it is the which stage it is. Then if it is inoperable, then definitely refer to a surgeon. But if a palliative, then obviously we can put a self-expanding metal stent. And many a time neoadjuvant we refer to an onco for the radiation.
So stage biopsy, stage, and then based on the stage, then decide on the treatment, whether you do radiotherapy, chemotherapy, or curative surgeries, or combination therapies, putting palliative stents for these patients. There are different types of stents, as we know. These self-expandable metal stents, we have partially covered, fully covered, different modalities, different types of stents are there, which we use. Even biodegradable stents are also being used at certain places, particularly for benign strictures for these patients with the strictures. So adjuvant therapy, sometimes we use corticosteroid injections, mitomycin, particularly for benign strictures. We do use these kind of therapies for our patients. So question for Samin. So your approach for a refractory benign stricture. Hello.
First of all, refractory was despite of and a patient comes to you frequently, then you go with intrathecal steroid, in which you can particularly use and try to inject all the part. Uh, Essentially into the stricture wall, not above the stricture, and it helps to decrease the fibrosis, decreases the recurrence rate, and at least it prolongs the time between the dilatation. That is the one up. And go for the star-shaped incision. Growth, chances of perforation. So unless and until you are very sure about your skill, don't attempt the star-shaped incision. Sometimes we go for the star-shaped incision followed by intralesional steroid to go to decrease the recurrence rate of stitch. And for malignant stricture, if it is for the first time, you just take a biopsy. If it is too tight, you just put a rice tube till the staging happens. And once staging already happens, then it is for the palliative standing. You just do a SAM placement.
Yeah, that's right. So if you have benign strictures, dilatation is the standard treatment, and keep doing dilatations recurrent. If that fails, then you can give steroid injections, and still refractory, you can still consider doing dilatation. Sometimes we do put, as I said, biodegradable stents or fully covered stents for these patients. And then if they're still persistent, if they're very short stricture, we may consider for surgery, but very, very rarely benign strictures go for surgery. Most times we're able to manage with endoscopy and also high dose PPI. You know, high dose, don't forget that, high dose PPI twice daily, and also antacids probably work for them. Malignant strictures, as we said, staging stems, if they are palliative, if they're curative, then you go for the surgical resections. Benign strictures obviously have good prognosis, whereas malignant strictures depend upon the stage of the disease. Just wanted to show you a couple of cases here. So this patient had a tuberculosis, and when we did an endoscopy, when they came to us with, in fact, he had a large subcarinal node. When patient presented to us with odynophagia, usually an endoscopy we picked up a large subcarinal lymph node protruding into the esophagus. So, Sandeep, how would you manage this patient if somebody has got subcarinal lymph node protruding into the?
So, this patient has got a subcarinal node which has come into the
Subcarinal node, which is eroding into the, and it's not fistillated, but actually eroded into the esophagus and presented with odynophagia.
So we need a US guided FNSC from this. So you do a US guided FNSC, and on FNSC, of course, you'll get the diagnosis and then treat with ATT. As you said, this is a tuberculosis. It might be malignant also. After tuberculosis, then the patient will respond.
Yeah, so important point is just don't do any further intervention, just give ATT treatment for these patients. Confirm the diagnosis that this is only a tuberculosis, nothing else that is eroding into the esophagus. And then you give 80 treatments. Sit tight, wait and watch. Master inactivity for these patients would help. Okay. So next case is patient who consumed methanol, and this is what it presented with corrosive injury. Okay, assuming that was ethanol, they consumed methanol, and this is what has actually happened. So, Sandeep Shah, how would you manage this patient?
Methanol injection.
Methanol
Injection.
Yeah.
This looks corrosive type of injury, quite severe, I would say. You can see those white flags and even the deeper ulcer, circumference and involvement. So I think if we are doing an endoscopy, I would also like to evaluate the stomach in this, whether the stomach is involved or not. But if it's just an esophagitis, and we can even put the H tube or an NG tube or even the feeding tracheostomy, we put the patient on meal by mouth, like no oral, and then we can proceed. But obviously, we should explain the risk of perforation in these so deep ulcers.
Yeah. Again, muscle inactivity to a certain extent, high dose PPI, and wait and watch these patients. 4 weeks later, this was the endoscopy for the same patient with the injury that they had. Okay, so muscle inactivity. Make sure that the patient is adequate in nutrition and antibiotics that will cover the infections. Infection cover and nutrition, and you wait and watch for these patients. Another case with had a complete obstruction to the esophagus, 32-year-old lady, upper third, esophageal cancer for which she had a therapy. And so this is what the endoscopy, she had a PEG placement as well. So this is from below. There's absolute complete blockage. We couldn't see any lumen at all. And this is what the retrograde from the PEG placement that we actually, the reviews of that narrowing. So this is the retrograde endoscopy. Again, there's no absolutely complete blockage. You see on the fluoroscopy on the other side, on the last picture, you see the scope at the top, the scope at the bottom. So there's this all area is completely cut off. What we did with this case was from retrograde through the PEG, we actually did a ESD guided recanalization using ESD technique. We were able to bore hole, create a tunnel, and we were able to get through. And from the top also, we were able to do the same beautiful tunnel. And then this was the picture at the end, which I want to show you. So post-procedure, this we were able to get the scope down from the top to the below. And this is after about 2 weeks post-procedure. We're able to avoid a surgery for these patients just by endoscopically. By what we call a third space, we're able to come close to between from above and below, and we're able to achieve the neo-esophagus for these patients.
Naveen, did you put a stent here?
No, we didn't put a stent. We just dilated it initially there, and then we didn't put a stent because actually we went to the third space.
So the original procedure which has been described poetry, so they do like they come through the retrograde and endocrine and they put a stent from the submucosal space.
Yeah.
Because if you don't do that, there is a high chance of recurrence of this stricture.
We did one case similar to that where we put a biliary stent in those patients rather than esophageal stent. But this time, second case is what we did was we thought that we'll try with this. And then, I mean, this is what 6 months down the line now that we did previously 6 months back.
So you did the ESD based on the transillumination?
Transillumination, yes. Okay. So two more quick questions about it. So endoscopic resection for SCA esophagus. When would you actually consider resection in esophageal endoscopically? What are the absolute contraindications of endoscopic resection for SCA esophagus?
So of course, so if it is a very early stage, if there are no lymph nodes around in the malignancy, and if it is an early esophageal malignancy, based on our NBA findings, then only we will go for an endoscopic resection. And of course, contraindication, if you find that the disease is disseminated or if there are any lymph nodes also, you won't go for endoscopic resection.
So any T4 disease and beyond, any nodal positivity will not obviously approach any endoscopic resection with curative intent. Anything below that, T3, T2, T1, definitely we can approach for the endoscopic resection. Complications wise, they can develop strictures, especially if it's a T3 disease involving the muscular layer, then you may have to do dilatations, but otherwise it's a pretty safe procedure.
Sir, due to the lack of the time, we are lagging behind the video. So please complete.
If you can, Naveen, just summarize the approach to for them basically.
me to the point. So, as I've been saying, the main point that I want all of you to take home is anybody with dysphagia, which means difficulty in swallowing, this has to be referred to a gastroenterologist, has to be assessed endoscopically. Of course, as I said, first is a careful history, localizing symptoms, and then doing endoscopy is the first modality of choice. And then if the endoscopy doesn't give us the answers, then we may actually go for a manometry, and then sometimes we go for a barium swallow, or even CT scan if there's an extension compression. So anybody with dysphagia, particularly if there is progressive dysphagia associated with red flag symptoms like weight loss or any other symptoms, they need to be referred to a gastroenterologist so that we can evaluate it. And these dysphagia could be because of the strictures, benign or malignant strictures, if it's luminal obstruction. All these patients needs biopsy. If it's a benign stricture, we can do dilatations. If it's a malignant stricture, you stage the disease, and then based on the staging disease, you titrate the treatment modalities for these patients. If it's eclasia, then yes, we can consider going for a POEM procedures. If it's a distal esophageal spasm, then there's medications. Most times should do the job. Peptic stricture, again, recurrent dilatation, repeated dilatation should do the job. So it all depends on the cause of the dysphagia. Dysphagia, difficulty in swallowing, definitely needs to be referred to a gastroenterologist. Thank you very much for the patient hearing.
So we don't take any questions. Naveen, please. Thank you, panelists, for the excellent discussion. Please be there at the stage. So now we move for lunch. Before lunch, I have some announcement that there is also award for highest attendees. Top 3 awards will be given cash prize. So especially the students who are here, PG students, they can take advantage of that. And apart from the cash prize, please listen to all these beautiful lectures. They are designed in a very basic format. This will help you in your future practice also, as well as in your exams. So being on time is a wonderful thing. So we depart for lunch now and get together again at 2 o'clock. Thank you.
Gastroenterology lessons learned by Dr. Mahesh Goenka. I would like to request chairpersons Dr. Rajiv Grover, Dr. Kapil Sharma, Dr. Naveen Polarapu, Dr. G.H. Bhagat.
Good afternoon, everyone. It is a pleasure to welcome and introduce none other than Dr. Mahesh Goenka. In the field of gastroenterology, the lecture which say four decades of GA practice is a living legend. He's a star of Northeast, but overall mentor for many doctors across India. So sir is director and chairman of Apollo Glengames. He started his career from PGI Chandigarh and he's a guru of gurus. For sir, I would like to say a Sanskrit शब्द कि कैसे लोग विद्वान बनते हैं. काग चेष्टा बको ध्यानम, काग चेष्टा बको ध्यानम, श्वान निद्रा तथैव च, ग्रहे त्यागी, अल्पहारी, विद्यार्थी पंच लक्षण. कि ऐसे गुण काग चेष्टा, चेष्टा कैसी हो? बगुले जैसी. बको ध्यानम, बगले जैसा ध्यान हो. श्वान निद्रा, नींद कैसी हो? डॉग जैसी नींद खत्म हो जाती है. अल्पहारी, कम खाना. ग्रह त्यागी, कि सोसाइटी को इतना कुछ दे देना. तो वी आर बेसिकली ब्लेस्ड टू हैव यू सर, and we would like to hear from you your experience and take home message for each and everyone. Welcome, Dr. Mahesh Goenka, sir. Thank you.
Thank you very much for those kind words. I hope that long introduction will not cut down from my duration of talk. It's always a pleasure to come to Ahmedabad, both for Dr. Harwani and Dr. Harwani's father. I think I've been coming here regularly, though today's program for me is a very short program, but I'm so happy to be here for this meeting. Now, we were discussing with Yogesh as to what should I talk about, and then we mutually discussed that rather than speaking on a particular focused topic, I'll talk about my journey of 4 decades in gastroenterology and what are the lessons which I've learned. My daughter happened to listen to this talk sometime back. And she said, Papa, you were praising yourself. It is not proper. So, when I go through this talk, my idea is to tell you that if I could achieve something in my life, each and everybody can achieve what something beyond that also. All journeys have secret destinations, of which traveler is unaware. When I was doing my schooling, and let me tell you, I have no shame in telling you that I come from a very middle class family. And my father, who was just a graduate, had 4 sons, and he wanted to give them best education, even if he could not afford it. So he went all the way, did everything possible to make us all educated people. And at that time, we knew nothing as to what my destination would be. I wanted to become an engineer because my elder brother, who is a well-known figure, is an engineer. But as the destiny would be, my school, again, a very average school in Calcutta, started a biology stream. And they wanted some of us, so-called brilliant students, to enter biology so that it can get a kick start. I had no idea that if you join biology, you become a doctor. But I joined biology and then I became a doctor. So I am an accidental doctor and I'm also an accidental gastroenterologist because when I went to PGI Chandigarh for my MD medicine, I didn't know that I have to choose cardiology or gastroenterology, but I happened to meet Dr. S.K. Mehta, who was a pioneer gastroenterologist in that time. And I was so impressed when I talked to him that in my MD first year, I decided that I should become a gastroenterologist. And I took my thesis in MD in gastroenterology. So like people talk about Manmohan Singh being accidental prime minister, I'm not only an accidental doctor, but also an accidental gastroenterologist. So when I completed my DM in 1989 in PGI Chandigarh, I had 4 options. Either to stay back as assistant professor there, to start individual private practice somewhere in India, to join a corporate hospital and to go abroad. My family members who were in Calcutta insisted as soon as I finished my DM that you come back. There's only one DM in the whole of the Eastern India, Dr. T.N. Mazumdar, who unfortunately is no more. And he said, you practice will flourish. There's only one gastroenterologist in the whole Eastern India. But I said, no, I need to stay back. And I stayed back in PGI for 7 more years. And I think whatever I little I could achieve in my life is primarily because of those 6 or 7 years, which I stayed back in PGI Chandigarh to learn the tricks of the trade. I came back to Calcutta in 1996, almost 30 years back, and joined initially AMR Hospital and then Apollo Hospital, which is now called Apollo Multi-Specialty Hospital in Kolkata. Now, so my first lesson, and those who are building up their career, is if you read this international bestseller, which says Thinking Fast and Slow, talks about 2 systems of thinking. One is based on emotions and acts quickly and intuitively. The other takes time, think logically, and doesn't act rational. So I think system 2 is a better system. Don't take fast decision without thinking of a long-term effect. So my first lesson, which I learned, and I would want everybody to learn, that in your career, don't take decision based on short-term goals. Think of goals which will come after 8 years, 10 years, rather than what will come tomorrow or the day after. So I think this is another bestseller, which is written by a Japanese guy, and he defines happiness and success. We often say that they are 2 interchangeable words. They are not. Somebody may be happy, but yet not successful in the materialistic term of success. The other guy may be success, but he may not be happy because he wants more. So happiness and success are not interchangeable words. In medical field in general, we define success as clinical success, success in the field of research, teaching, leadership, and ethics. And I think I'll touch upon all of them in reference to my career. So over the period of next few years, we started GI practice in India, in Calcutta, and this is the endoscopy suite. We have 6 similar suites in our department, which are well equipped. This was the first ESD, which I did almost about 15 years back. This is a small tumor in D1, neuroendocrine tumor. This is almost 15 years back. And this is what now we are doing. Laterally spreading tumor, we are able to remove by ESD with avoiding surgery in majority of cases. We also started POEM for the first time in Eastern India. Now we have many centers, and Dr. Sandeep Pal is sitting here, who is also very, very active in doing procedure. For those who have not been yet exposed to the technique of POEM, this is an ultimate in GI endoscopy, where you don't work inside the lumen, you don't work outside the wall, but you're working in the wall, where you're creating a submucosal tunnel to reach the G junction. And then you do a myotomy endoscopically, which is replacing almost completely Heller's myotomy technique. This is me. I'm trying to learn POEM in a remote village in China, almost about 12 to 13 years back on a pig. So the idea is to learn, you have to work. Now, we also started clip placement. This is the Borjas syndrome. This clip is not working. And this is an nitrogen perforation. I suppose the theme of this meeting today is esophagus and pancreas. So these are 2 cases of esophageal rupture, esophageal perforation, Borjas syndrome, and the other one was iatrogenic, which is caused by blind dilatation of G junction. And this resulted in large fistula, which was closed by over the scope clip-outs. Again, the bleeding can be stopped in majority of cases, as you know. This is a clip which is stopping the bleeding in stromal ulcer. And this patient required through the scope clip, and we put multiple clips, 3 or 4, to stop the bleeding. And this is the bleeding which is in gastric varices, sometimes fatal, and we are trying to stop this. I'm sure you'll be talked about all these in these 2 days. We have been removing foreign body from the esophagus. Some of these are shown here. Of course, the gold ones and silver ones, they did not leave it with us. They have taken it back, but the rest are all with us now. Now, we also started advanced ERCPs. And this is doing a laser technique for removing stones. And this is 86 years old lady who has large number of stones we removed by various techniques over 2 sessions. Of course, this is Hyler block where 2 metal stents have been placed. The endoscopic sonography has really changed our approach to a lot of diseases in the GI tract, and I'm sure you'll be listening about it in the coming 2 days. So this is a necrosectomy that's being done in a patient with wall of necrosis. And what we do now routinely is for gastric outlet obstruction, we do US-guided gastrojejunostomy, as you can see there, that stent has been placed between the stomach and the small intestine. Now, how is it possible? It is not possible by one man. You need to create a team. And I think it's very important. I was just talking to Yogesh that his team is also increasing. So we have now 11 gastroenterologists in my department who are working together. All patients belong to everybody. So, and no patient belongs to anybody in that sense. So this is me along with Uday Ghoshal, who is heading the neuromotility. We have pediatric gastroenterologists. We have EUS by Dr. Nikhil. We have endoscopy. We have intensivist. We have hardcore hepatologist, and so on. So I think each one of them have a divided area to work on, and that is to create a team. We also started liver transplantation in 2009. In 2020, we became fully independent to do liver transplant. We did transplant during COVID, and it was a big challenge because we tested almost about 100 people in the morning before the transplant was done, so that we are sure that no COVID individual comes in contact with the recipient. But to do a procedure like this, you need to develop interdisciplinary collaboration. Doing a transplant requires many, many departments to join together. So my lesson number 2 is that if you just want to walk fast, you can walk alone. But if you want to walk far, you need to walk together. I think this is very important, that you must build up a team, whether you have a small group, large group. Gone are the days of a single man private practice. I think that creates more problem, and you cannot really do very advanced work because you need to go for vacations, you need to go to conferences, and until you have a team, you cannot do good work. What are the parameters of a good clinician? Parameters of a good clinician is that you should have a skill, you should be responsible, and most important is that you should have impact. You must have impact for your patients. So learning endoscopy, basic endoscopy is not difficult. Just to give you an example, colonoscopy involves just 5 movements: push and pull, clockwise and anti-clockwise twist, up and down, knob movement, right or left movement, and insufflate or subcare. There's nothing great in this. So learning basic endoscopy is very easy, and now we have study resources, we have workshops which are being organized, and we have animal models. As I showed me myself learning poem in a small village of China. So this is my tag word which I use, and this is what I follow very strongly when I select people for my team. It's not their knowledge which is important. So what I believe is that it's your attitude and not your aptitude which will determine your altitude. So where you'll reach will depend on your attitude to life. You may not be knowledgeable at a particular time. If you have attitude to learn, I think you can achieve anything. Now let me move on. This is a case scenario of one of patient which was referred to me with septicemia because of a hilar block which was managed by a single covered pigtail stent. I think this is unjustified. So we had to replace and put 2 metal stents in this patient. So you have to take all precautions so that you do not harm the patient. Look at this endoscope. This was given to me by Olympus. If it's not properly managed, fungus grow inside the endoscope. So you need to spend money on making a good disinfection unit. And this is our disinfection unit in Apollo Hospital in Calcutta. So this is the money which is spent, it does not directly get you revenue, but this is very important. So you must do everything to prevent complications. Rectal endomethacin now is universally used to prevent post-TRCP pancreatitis. And complications will happen. You should understand that you must be confident. If you think you can, you can. If you think you cannot, you cannot. Either way, you're correct. So you should know that what you can and what you cannot. And I think you must, and this is a very important lesson, which I have learned over a period of time, that no procedure is a make or a break event for a performance. If I fail an ERCP, it doesn't make any effect on me. I would have 100 more to do. But if I cause a complication, it can be dangerous for the patient. So I think I would tell you in the initial days, I would fail in a cannulation, I would do a pre-cut, I fail, and I feel very frustrated, disappointed. But when I come back to my chamber and sit down after 10 minutes, you feel very relaxed, then at least you have not done any complication. So you will have another opportunity after 3 days to complete the procedure or refer the person to somebody else. But I think try to avoid the complication at the expense of showing that I'm successful. Complications will happen. Do not panic. This is a perforation which I caused while I was trying to remove the large stone. I twisted this scope a bit too much, and the duodenal lateral wall was damaged. But I did not lose my cool, and I went in with a Novesco clip in the same sitting. Unfortunately, though it was in the lateral wall, grasped the whole of the perforation inside the clip and could close the perforation. And then after 4 days, I could complete. So I think do not panic in terms of form. So I would say lesson number 4 for me is that most important component of medical ethics is non-maleficence, which means do not harm. So I think when we are doing the practice, I think that should be the most important component of our practice. Rest are all important. So I talked about attributes for success in the medical field. Clinical, we talked about. What about the research? Now, when I left PGI Chandigarh in 1996, believe me when I say that I had 15 days of sleepless nights. Am I doing a wrong thing? Will I be not doing any research? Will I not be involved in the training? But let me tell you today, and I know there are people from the government sector, the institutes who are sitting here, the people from private sector sitting here. It's not difficult to do clinical research in private sector. Sometimes it's easier to do research in the private sectors than in the government sectors because the movements are fast. So we could publish a lot of material in the last few years with the reach a decent H index. So just to share you some of the areas where we worked in the last few years is that we worked with a Hong Kong group to develop a tool of artificial intelligence guided esophageal gastroduodenoscopy in assessing the procedural completeness and quality. So we divided the upper GI system into 29 parts. Now we have 33 parts. And as you start the procedure, and I'll just run this video fast for you. As we start the procedure, computer goes on recording which area you're seeing. So epiglot, and there'll be a box which will tick automatically. And as you move forward, computer goes on ticking to the areas which is trained to the computer that how to look like. And so you go into the second part of duodenum, and then it will keep further, and then you come back and examine the rest of the stomach. So this way you ultimately will find out whether your examination has been complete or not so. Let me see if it moves further. Okay. Somebody help me. By that technique, we can know whether the examination has been complete or not. In the first case on the left side panel, you can see that sorry about that. So on the left side, it shows that 68% of the areas to examine. On the right panel shows that 100% of the areas we examine. It's not only important for diagnosis, but it's a very important tool, I feel, which will be used for training for upper GI endoscopy and similarly subsequently for colonoscopy. For our interest in artificial intelligence, we work with a team of people across the world to use artificial intelligence in a very challenging situation of indeterminate biliary stricture by training a large number of videos together. Another area where we work again with Johns Hopkins Hospital here, which was published in the High Impact Journal of GI Endoscopy, August 2024, where we developed an AI-based post-ERCP pancreatitis risk calculator. So by using various parameters, and we used almost 7,300 ERCPs with a PEP rate of 8.6%. We tried to find out how to do an artificial intelligence-based complicated calculation, and we developed this calculator. So just like MELD calculator or BIP4 calculator, you put various figures, and it will tell you what are the risks of post-ERCP pancreatitis, and which are the four parameters we should, four interventions we should use to prevent that. Now, this is another area of interest, and we presented and published in American College of Gastroenterology Journal. This is AI liver fibrosis. Some of you may have heard BIP4 score. We particularly use artificial intelligence using FibroScan in 25,000 FibroScan, which were done in my department. And we compared with various parameters, including some and liver biopsy, and we showed that artificial intelligence-based liver fibrosis score is much better than BIP4 score. Happy to announce that Siemens company has taken it from us, and in the next generation of their machine, they're going to incorporate this for the algorithm of liver fibrosis. And this has got also API, the first API in liver disease. So we published in Lancet various meta-analysis and network analysis about, again, post-ERCP pancreatitis. Now, I was fortunate to have the editorial role of editor-in-chief of General Digestive Endoscopy and World Gastroenterology News, and more recently, I'm being selected as the editor for GI Endoscopy. So how was this possible? This was only possible by collaborating, not only at the national level, but internationally. So I tell you that it's very important to publish. Whatever work you may be doing, you may be doing 200 endoscopies a day, you may be doing huge number of patients, but use every opportunity to publish, because until you publish, you will not be known beyond your belief. So when I was conducting APDW, I was given a list of about 1,000 possible faculty. All we did is that we went through each one's resume and tried to find out who should be finally invited for the region. So I think you are known outside your region by what you publish and not by what you do. Teaching and training, as I said, is another area which was bothering me when I left TGI Chandigarh, but have been fortunate that in private sector also we have been able to teach and train. And I would re-emphasize and I'll echo what Dr. Abdul Kalam, our ex-president, said. And I really mean it for myself as well. The teaching is a very noble profession. And that shapes the character, caliber, and future of an individual. If the people remember me as a good teacher, that will be the biggest honor for me. And I uh, sincerely mean it, that this is the best thing which is possible to remember. Now, you need to also develop leadership. Leadership can be any way. Leadership can be in the region, can be in the national level, international level. I've been fortunate to get national and international recognition. But I want to emphasize on this point that you need to develop it. Networking is important. There's nothing wrong in networking. You meet people in conferences, national conferences, international conferences, they come to our and we come to our. And whatever national and international recognition most of us have got is only because we have friends who are there to help you and who recognize your importance and can speak for you in various forums. Now, I'm just coming to my last few slides. Kapil Dev said once, and we all know Kapil Dev's stature in cricket, is work with pleasure and not under pressure. He moved from cricket to golf to various areas because he thought that he's getting pleasure from those areas. And this is a borrowed slide. Enjoy what you do. We as endoscopists want to see endoscopic pictures when we're in the work. But if you stop liking it and you want to see something else on the screen, then that's the time to possibly take a break, and then to come back or to change your profession. So I firmly believe that I'm still enjoying what I'm doing. So it's time to continue, otherwise we time to break. Last 2 or 3 slides. What is looking back? Was everything great in my life? No. I have a regret. I have a few regrets in fact. The work-life balance was missing altogether. I remember the days when I'll return home at 1:30 in the morning, being very happy that I've done 25 ERCPs today. I think the present generation is much better in that, in work-life balance. But I think it's very important that we must realize that there is a time for family, and the family time is very important. And personal health takes a toll. I think there was no concept of ergonomics when we were learning endoscopy. Nobody told us how to stand, where to stand, how to hold the scope, how to move the scope, what will create chemistry or ligaments. So I think this is something which is very, very important. We must learn. I will tell you the story of Steve Jobs, the Apple guy. He died at the age of 55 years or so because of carcinoma pancreas. And he said, I reached the pinnacle of success in the business world. In others' eye, my life is an epitome of success. However, aside from work, I have little joy. In the end, wealth is only a fact of life which I'm accustomed to. And he went on to say that you can employ someone to drive the car for you, to make money for you, but you cannot have someone to bear the sickness for you. And he was falling his dying when he was dying in his bed. I think these are important messages. And the last lesson which I've learned, and I have no hesitation to tell you, that I should have possibly used these 3 phrases more commonly than I did. Thank you to anybody who helps you in your profession. Sorry when you're not able to do to the patient what you want to do. And what do you think to your colleague to ask for their opinion? I think sometimes we are egoist to use 3 words, but these 3 words are very important. Now, to lead my life again, I'll possibly use these 3 words more than what I did. So this is the last slide for the youngsters, if there are many hall, that for young doctors, remember Shah Rukh Khan, if you've seen the movie, Chak De, the passion with which he showed the whole movie. You develop a team like Amir Khan did at Lagan. You should have friends like Jaya and Viru in Sholay, and you must care for your family as was demonstrated in Hum Aapke Hain. I think, thank you, Vedanta.
It is a 40 years of dedication to the mankind, and certificate needs 40 seconds for continuous ovation, standing ovation, sir. Please. Continuously, please.
Thank you. Thank you very much.
Thank you, sir, for the kind words of wisdom and lesson learned. Dr. Yogesh.
So, as Dr. Rajiv said, Dr. Goenka is not only a senior gastroenterologist, but he's one of the few gastroenterologists in our country who has really shaped the how gastroenterology is pursued. And it is because of him and few other gastroenterologists of our country that gastroenterology is so much advanced today in India. So for me, he's not only a senior gastroenterologist, but a teacher, mentor, and also a fatherly figure. And I thank him that whatever I am today, not only as a gastroenterologist, but as a successful gastroenterologist, is because of him. Also, he is helping us. Thank you. Also, he is helping us for last 7 years continuously to design this program by which many doctors of Gujarat have really benefited. Now, there is no way in which I can thank him or reciprocate him, but by a small felicitation, we would like to express our regards. Thank you, sir. I would like to request my father, Dr. Purushottam Harwani, and Ahmedabad President Association, Dr. Nehal Sadhu, to please come on stage, and the chairpersons to please come on stage and felicitate, sir.
Thank you, sir, for your valuable knowledge. Now we would move to our next session on high resolution esophageal manometry. I would like to welcome our chairpersons, Dr. Viral Shah, Dr. Naresh Oja, Dr. Sameer Pabnaskar. I would like to invite our speaker, Dr. Kapil Sharma.
First of all, First of all, I extend my sincere thanks to dear friend Dr. Yogesh for giving me this opportunity. I must congratulate him. Now you can see hall is completely full of the audience, even post lunch. And we have listened to the legend like Dr. Mahesh Goenka. Now he had given to me a job. I will try to make my job best. And the topic given to me is the high resolution manometry, how to interpret. Let's let's understand the esophageal manometry system. It recorded the pressure phenomena, peristalsis, and bolus transit from the esophagus in response to the swallow in order to make a diagnosis of motor disorder of esophagus. It has a two-component catheter with transducer, which has a pressure sensor, which can be intraluminal in solid-state manometry. In water-perfused manometry, it is extraluminal. It has a recording device with the software, which analyzes the information sent by the catheter. Now credit goes to this gentleman, Ray Close, who developed this close plot. Here you can see in the x-axis the time, on the y-axis the distance from the nair, and he given a different pressure by the different color. Higher pressure indicated by the higher warm color like a red color and black color. Cooler colors are the low pressure color like a blue and green color. He was a geographical student, later become a physician and developed this plot. What are the indication of esophageal manometry? Mechanical dysphagia without mechanical obstruction, non-cardiac chest pain, before you perform a pH testing, systemic disease with the esophageal involvement, suspected US dysfunction, before you perform a surgery for hiatus hernia, and if patient develop a postpartum dysphagia. Before you start a manometry, you first and foremost important is the calibration of machine. You need to calibrate the machine. Start a pump which propel sterile water into the catheter through a different channel. You should check whether any channel is blocked or not. And you should confirm the position of catheter after 30 seconds of adaptation by 3 deep inspiration. And you need to give a 5 ml swallow. And if there is no significant diagnosis, you should perform an MRS, which can be repeated 3 times if there is no abnormal response. You should analyze in the secondary position, like a standing position with the RDC and solid meat test if you are suspecting EJJ outflow obstruction. You need to understand various manometric landmarks like upper esophageal sphincter, different contractile segment of esophagus, peristalsis, which can primary, secondary, and tertiary, transition zone, and you should detect LES and EGJ by the respiratory inversion point. And most important, the different contractile segment of the esophagus, which are S1, S2, and S3. S1 is the first segment, which is the upper one-third, which is mainly striated muscle, proximal to transition zone, innervated by the vagus nerve. In the second, S2 is formed by the skeletal muscle and smooth muscle both, and distal only smooth muscle. But second and S2 and S3 form a diagonal pressure band distal to the transitional zone to have a bolus exit. What exactly happens? The contraction slope and bolus velocity decrease once this bolus reaches to the phrenic ampulla of the esophagus before it enter into the esophagus. This transition zone is very important because it lacks the contraction. It ensures the coordination. It ensures the coordination between the upper esophageal valve to have a complete bolus clearance. And this is very important to have a respiratory inversion point. It is the axial location where pressure becomes reversed during deep inspiration. During inspiration, thoracic pressure becomes lower, which can be detected by the deep blue color. And the opposite is seen in the abdominal cavity. And sometimes you detect a butterfly pattern if you are their catheter kink into the esophageal cavity. The IRP is the most important parameter in the high resolution esophageal manometry. What exactly it is? It is the lowest average EGJ pressure of 4 seconds within 10 seconds of US relaxation, which can be contiguous and non-contiguous. Let's understand simply. Once you the swallow to the patient, this LES relax. We called it this relaxation window. And you should calculate 10-second relaxation window. Here you need to calculate the 4 seconds of lowest average EGJ pressure. Normal IRP usually less than 50 millimeter of mercury. In the supine position, secondary position, it is usually less than 12 millimeter of mercury. And another important parameter is the DCI. DCI is the measure, it is the power and vigor of contraction of S2 and S3 segment, which exceeds the 20 millimeter of isobaric pressure. It is composite of the pressure amplitude, length, and duration of the contraction. Normal contraction, they are measured 450 to 8,000. If you are detecting hypercontractile esophagus, it is greater than 8,000. Ineffective contraction, if DCI is 100 to 450, they are the weak contraction. If DCI is less than 100, and it is a failed contraction. And the fragmented contraction is if you have a if you have fragmented contraction, if transition zone exceeds the 5 centimeters, then it is the fragmented contraction. And what is the contractile front velocity? The slope of diagonal bend. Now it is no longer utility because Chicago 4 doesn't allow CFE to classify motility disorder. And the important another parameter is the CDP. What is CDP? The sudden and steep decline of the contractile front velocity along the 30 millimeter mercury of isobaric contour. Usually it is where S3 segment meet the phrenic ampulla located within the 3 centimeter of LES. And you should measure distal latency from US relaxation to the CDP. It is usually greater than 4.5 seconds. And if it is less than 4.5 seconds, indicate premature contraction. And there are different pressurization pattern. Pain esophageal pressurization, if it is greater than 30 millimeter mercury, spanning from the US to LES, is suggestive of type 2 achalasia cardia. If you have a compartment like an intrabolus pressure, which spans from CD to EGJ, it suggests a bolus retention, and it found in a EGJ outflow obstruction. And sometimes you need to perform a various response to the provocative test like a MRS, particularly used in ineffective esophageal motility. You need to give a 5 to ml swallow every 2-3 seconds. And you can detect two things, either absent quantity and or peristaltic reserve. Peristaltic reserve is the MRS DCI greater than the wet swallow DCI, and the esophageal body has some kind of peristaltic reserve, and these patients can undergo complete break. And the rapid drinking challenge, you need to do a 200 of water in the sitting position as quickly as possible without any break. It detects absent contractility and ECG outflow obstruction by if IRP is greater than 12 millimeter of mercury over the first 30 seconds and presence of pain esophageal pressurization greater than 30 millimeter of mercury. What is needed in the Chicago 3 and Chicago 4? In the Chicago 3, distinct latency replaced the CFP. EGJ morphology introduced. Weak peristalsis defined by DCI, fragmented by the break, and hypertensive by the DCI. In the Chicago 4, you need to change the position or do an additional maneuver if not able to make a diagnosis. EGJ can be clinically relevant and non-relevant, and it should be confirmed by the non-metric testing. And you should also correlate with the symptoms if you are suspecting the DES and hypercontractile esophagus. And this is very important slide, but if you are analyzing the manometry, first give a 10 swallow, look at the IRP. If IRP is high, look at the peristalsis. If 100% fail peristalsis, it is a type 1 eclasia. If pain esophageal pressurization is type 2 eclasia. If premature contraction is a type 3 eclasia. If you are having high RP, but the peristalsis present, you should suspect EGD outflow obstruction. You need to perform a time barium and endoflip. If IRP is normal, if 100% fail peristalsis is absent contractility, if premature contraction, it is a distal esophageal spasm. If the 20% show the hypercontractility, it is a hypercontractile esophagus. If 70% ineffective and 50% fail swallow, it is ineffective motility. This is the way how you need to classify the various motility disorder of the esophagus. Here you can see different type of eclasia, type 1, type 2, and type 3. Sometimes we get a report which suggests you are inconclusive of eclasia, absent peristalsis, but IRP at upper limit of normal value. And you are able to detect a appreciate peristalsis in the change in the position. And sometimes it can be normal. You should be cautious once you are reporting the type 3 eclasia cardia. The only difference between the type 3 eclasia cardia and DES is the high IRP. And sometimes the opioid use can give it a picture similar to the type 3 eclasia cardia. The 20% cutoff premature in the DES is arbitrary. Confidence increase if the numbers increase. And you need to always give some kind of provocative test. In absent contractility, you should have a normal IRP in the supine position and 100% fail peristalsis. Distal esophageal spasm, patient can have a dysphagia, non-cardiac chest pain, and you have a conclusive manometric finding, which is the premature contraction detected by the distal latency less than 4.5 seconds with the normal DCI, hypercontractile esophagus, dysphagia, non-cardiac chest pain, and you have a DCI greater than 10,000 in at least 20% of swallow. Mechanical obstruction should be ruled out, and it should be not meet a criteria for eclasia cardia and diffuse esophageal spasm. Ineffective esophageal motility, at least 70% should have an ineffective peristalsis detected by the week, where the DCI vary from 100 to 450, fragment the peristalsis, and 50% fail peristalsis where DCI is less than 100. And you should always have a supportive evidence for ineffective esophageal motility and lack of contractile reserve after giving a multiple rapid swallow. HRM beyond Chicago classification, you can classify this EGJ. It's a type 1 morphology where the crural diaphragm overlap with the lower esophageal sphincter. Type 2 morphology, if the separation is only 1 to 2 centimeter. Type 3 morphology, if the separation is greater than 2 centimeter. If type 3A, if respiratory inversion point at crural diaphragm. Type 3B, if respiratory inversion at the LES. And you should always calculate this contractile integral. If hypotensive, if it is pressure is less than 25 millimeter of mercury. And so if you did Jenkins diverticulum, you have a two pressure zone double contour at the upper esophageal sphincter. To conclude, high resolution manometry is essential to diagnose esophageal motility disorder. It improves the sensitivity for diagnosis of eclasia cardia, can differentiate between the subtype of eclasia cardia, predict the treatment response according to subtype. It allows the comprehensive evaluation of impaired ECG component like LES, crural diaphragm, and intrabolus pressure. Knowing your equipment and understanding the manometry metrics and landmark is essential to correct your interpretation regarding high resolution esophageal manometry. Thank you for your patience hearing.
Thank you, Dr. Kapil, for that insightful lecture on basics of manometry. Any questions?
Only one question. You showed in one of the slides that endoflip oblique tube esophagus. We understand that the cost of endoflip is prohibitive. So what are the things which you will pick up by tube esophagus, timed esophagus compared to endoflip? I mean, what is the difference between the sensitivity and specificity?
Once you are suspecting the EDJ outflow obstruction, where the IRP is high but the peristalsis is there, then it should be confirmed with another test, which can be either time varium esophagogram or endoflip. Endoflip can be used in real time once you are performing the procedure, like if you perform a procedure and confirm its effectivity during the procedure itself, whether you have done a complete myotomy across the LES or not. And the time also should be used to have a predict the response. What are the column? It's significant fall in the 50% decrease in the height. Once you perform the procedure, it's indicate you have done good job.
So nice topic. So here are many surgeons, physicians, always students. So one or two lines in daily practice when they should go for animal.
Dysphagia, if endoscopy is normal, then definitely you need to perform a manometry. For the surgeon, is suggestion always get a manometry before you perform a surgery for the hiatus hernia. I have not shown the slide, but my colleague may be showing you. If you detect, and you should calculate this, what I shown you, the contractile reserve by the MRS. If these patients have a good contractile reserve, then you can do 360-degree wrap. Otherwise, if these patients have a high uh, ineffective esophageal motility, these patients likely to develop a dysphagia after this fundoplication. It might suggestion never go for surgery for this hiatus hernia without getting pH testing and manometry done. Particularly any cardiologist here, if you have a suspected chest pain and your cardiac evaluation is absolutely normal, this hypercontractile esophagus and the diffuse esophageal spasm can also produce the chest pain similar to the angina. Any question?
No more questions. Sir, please, there is one question from the back end.
If you have not done complete LES myotomy, you should always extend your myotomy in that 2 centimeter on gastric side apart from the LES. If you have not done completely myotomy at the LES, there are always chances you might have a recurrence even after OM. And what you need to, you should evaluate your patient with the symptoms, and you should repeat the manometry at least 6 to 8 weeks. And you should always check the time varium esophagogram, whether this patient have a response or not. Type 2 achalasia cardia, best response to this poem procedure, but you should confirm that the myotomy should be always extend 2 centimeter on gastric side, and then you should do a complete myotomy at LES and gastric side also.
Thank you, sir. Now we can move on for next lecture.
Thank you, sir, for your valuable insight. Now we will move to our next topic on the basics of 24-hour pH metry and impedance. I would like to invite our chairperson, Dr. Nehal Sadhu, Dr. Afnan Ghiwala, Dr. Nalin, Dr. Harshal Patel. I would like to call our speaker, Dr. Srihari Akhilim.
So very good afternoon to everybody. I'm extremely grateful to Dr. Yogesh Narwani and his team. I bring greetings from Gangaram Hospital, Delhi. And in the next 12 minutes or so, I shall be speaking about the basics of 24-hour pH and impedance. And I have made this talk in a simplified fashion, not going into much details. It is basically an approach, how do you use these tests in practice, primarily oriented towards surgeons and physicians. So we all know GRD is a very, very common problem, and we often think it's very easy to deal with a patient with GRD. But it's also important to understand that sometimes it's often perplexing when we are managing a patient with GRD, that whether we are on the right track, we are doing the right thing, or is there something more to it? So to simplify things, let me put up a case. So this is a 52-year-old male with no comorbidities, no addictions, has frequent heartburn and regurgitation, also has occasional dry cough. There's no significant weight loss, no alarm signs. He has been taking proton pump inhibitors for around 8 weeks with some symptom resolution. So we often face such kind of scenarios in our clinical practice, and it puts up some fundamental questions. Is this really GRD? Should I treat this patient directly, or should we test first? What is the exact role of endoscopy when you're diagnosing GRD? Do you need endoscopy in all the patients to diagnose GRD? And when do you use these tests of pH or pH impedance? In which patients, and how to do it, and when to use it? So I would recommend all of you to go through this recently published Lyon consensus. This is an update which puts things in black and white. Your approach to a patient with GRD, previously it was the Montreal, now it's the Lyon. So one important change that has come up in Lyon is they have come up with a concept called actionable GRD. So actionable GRD is basically you need to have conclusive evidence to say that it is GRD. This was not the case previously. It was all symptom based in Montreal, but now in Lyon, you have to have conclusive reflux related pathology either on endoscopy or on reflux monitoring in the presence of compatible symptoms. So for all practical reasons, they have classified or they have mentioned actionable GRD as a situation which requires long-term acid suppression or an escalation of medical management or consideration of an interventional treatment. So obviously this is the group where which appears difficult to treat. It's not the conventional GRD where you give a PT and it gets better. So one of the important things that they have mentioned is how do you approach? If a patient has typical symptoms of GRD, so what are typical symptoms of GRD? Typical symptoms are heartburn or regurgitation or esophageal kind of chest pain. You can go ahead and give an empirical treatment with anti-secretory therapy. But if the patient has atypical symptoms, by atypical symptoms is it could be belching, chronic cough, asthma, hoarseness of voice, you're not certain this is GRD. So here an empirical treatment of GRD is not recommended with PPIs. And in this case, you'll go ahead and investigate this patient with various modalities that we have. It's either the endoscopy or a 24-hour pH test, and you might add in manometry for additional information in such case. So if we go by conventional actionable GRD, so usually when this patient comes, you often start with an PPI trial. So when we start with a PPI trial, it has to be optimal. So what does optimal mean? It has to be half hour before meals. Twice daily treatment is recommended sometimes for 8 weeks at least. It is important to know that whether your patient is compliant or not, because hardly 55% of the patients are compliant with this dose of medication. So make sure that the patient has good compliance. Nearly all compounds have equal efficacy. There's slight difference only. And it is important to note that the response in erosive esophagitis is more than non-erosive esophagitis. Obviously, if the patient has some alarm symptoms, you would not go ahead with an empirical treatment. So alarm symptoms means patient has additional dysphagia, odynophagia, upper GI bleed, weight loss, etc. You'd go ahead and do an endoscopy earlier in such patients. If there's no alarm symptoms, you wait, you can give an empirical trial and then go ahead with an endoscopy. On endoscopy, you might find erosive esophagitis, which is classified according to the Los Angeles classification. But in clinical practice, the more common scenario that we get is a non-erosive disease, where the patient has symptoms which are suggestive of GRD, but there are no erosions. So this is the situation where you use these pH tests. These pH tests could be simple pH or it could be pH with impedance. So there are different ways to monitor the esophageal pH. you have the catheter-based techniques. In catheter-based techniques, you have the conventional pH catheters, which check only the pH. And you have pH with impedance, which checks pH along with all the refluxes that are happening in the esophagus. And in the West, they have now shifted to a wireless capsule-based technology where the pH can be monitored for up to 3 days and you have to implant this electrode in the esophagus. So the catheter is put in the esophagus just like a Ryle's tube. You lift this catheter into the stomach, and in a conventional pH probe, the the pH electrode is placed 5 centimeters above the manometrically derived lower esophageal sphincter. In a impedance catheter, you have a pH channel and you have other channels which are actually checking the impedance. So what is impedance? I'll come to that. You put in this catheter, and this catheter is attached to an event recorder, which the patient carries home. And this event recorder has several buttons which he presses, whether when he's erect, when he's supine, when he's taking a meal or liquid, when he finishes taking the meal or liquid, and you give him a symptom diary. So you allot 3 most important symptoms, and the patient will press those symptoms whenever he has those symptoms. Maybe it could be heartburn, chest pain, and regurgitation, so on and so forth. So if you have done a conventional pH testing, in a conventional pH testing, after 24 hours, when the patient comes back, you take up that event recorder, you hook it up to your computer, and you get a graph. In a conventional pH recording, all you see is the points where the pH has dropped in the 24 hours. And the patient is also pressed when he has taken the meals, when he has been recumbent and so on. So in a conventional pH recording, most of the metrics are based around when the pH has fallen to less than 4. So pH of less than 4 is important because those are acidic refluxes. When the pH drops down to less than 4, your pepsin becomes active, and that actually causes the erosions in the esophagus. So that's a proteolytic enzyme which activates only in acidic environment. So in a pH recording, you get these parameters, which could be the D-Mister score, which is a composite of these various pH exposure metrics. Or you see when was the percent, how much was the percentage time when the pH in the esophagus was less than 4. One important thing you also see when you do a pH study is something called symptom correlation. So what do you mean by symptom correlation? It tells us that when the patient has pressed the button, whether there was actually a reflux occurring during that time. So it tells us whether the symptom was really attributable to the reflux or it was just a functional thing. So you have 2 symptom indices. You have the symptom index and you have the symptom association probability. The symptom association probability is thought to be more specific because it is based on this conventional 4x4 table. So this is what we can do with a pH recorder. But the problem is that not all refluxes are acidic. You also have non-acidic refluxes, which can be symptomatic. A conventional pH testing cannot pick up the non-acidic refluxes. It cannot pick up the alkaline or the neutral refluxes. So this is where your impedance comes into play. So in an impedance catheter, you saw that there were different impedance channels. So what is happening is that this catheter is hooked up to the recorder. The recorder has a battery. So the battery is transmitting electricity along this catheter. So there are electrical ions which are jumping from one electrode to another. The flow of this electricity will depend on what is lying surrounding the catheter. So if you have a reflux contains ions. So it's a better conductor of electricity. So the conductivity of electricity is faster and the impedance is lower. Whereas if there is no reflux, if it is air, the conductivity would be lower and the impedance would be higher. So basically, impedance is opposite to conductance, and conductance is determined by what lies surrounding the catheter in the esophagus. So that is the principle of impedance. So when you do a pH with impedance, the lower channel tells you about the pH, how much has the pH dropped. So in this case, the pH has slightly dropped. It has not gone much below. And you see that the impedance is dropping in the lower channels first, and then it is dropping here, here, here. So basically, it's a reflux. It's a weakly acidic reflux. Here, it's an acidic reflux. Here, it's an alkaline reflux. How it also helps us is that when the patient is on the pH study, he is motivated to eat and drink everything. So basically, you're trying to replicate what is happening in real world scenario. So there are a lot of foodstuffs which are known to alter the pH. You have a lot of acidic food that the patient can take. So how do you differentiate whether this is a reflux or this is a food which has caused a change in the pH? So pH testing alone cannot help you do that. This is where impedance can help. So what happens in impedance, if the patient has swallowed, the drop in impedance will be from top to bottom, whereas if the patient has had a reflux, the drop in impedance would be from bottom up, right? So a impedance pH gives you much more vital information than a simple pH. It tells you whether it's an acidic, it's a weakly acidic or alkaline reflux. It tells you how high up the reflux has gone. This is especially useful where you are suspecting a laryngopharyngeal reflux in patients who have laryngitis, because here you would want the reflux to go all the way up to the larynx. It tells you very good symptom correlation. It also tells you whether the reflux was an acidic reflux, it was a liquid reflux, or it was a gas. So now you have done a pH impedance study. And based on this, you're able to find out whether the patient has pathological reflux and symptom correlation. So this is reflux disease. You can have a situation where the reflexes are not very significant. They are in the normal range, but the patient still has symptom correlation, which is significant. This is called esophageal hypersensitivity. And you can have a situation where there's absolutely no symptom correlation at all. And this is functional heartburn. And why this is important? Because the management of all these three conditions changes. If you have a classical reflux disease, you do everything to suppress the reflux. If you have a non-acidic reflux, you like to do something to augment the LEA, to suppress the amount of bolus that is coming up. And if you have no symptom correlation, it's functional, then you treat and with neuromodulators, not as the case of GR. So whether you do this testing on PPI or off PPI, this is a commonly asked question. So if the patient is coming to you for the first time and you want to diagnose, so here the testing is to be done off PPI. Here you can use a pH or a pH impedance. If the patient is already a diagnosed case of GRD but is not responding to PPIs, here you would like to do the test on PPIs, and here you have to use the pH with impedance only. You cannot use a simple pH. So, ladies and gentlemen, GRD is a commonly encountered situation in clinical practice. It's a spectrum of disease which ranges from frank erosive esophagitis to non-erosive disease. As most patients are already on PPIs, impedance pH actually gives you much more vital information, and impedance pH measurement has now become the gold standard for measuring reflux. Thank you so much.
Thank you, sir. Very insightful lecture. Since we are running the lesson behind the time, we'll be taking question answer after the lecture.
Thank you, sir, for sharing your insights. Now we will move to our next session on the esophageal motility disorders and its treatment. How manometry has changed the game. I would like to call our chairperson, Dr. Uvesh Parmar, Dr. Nayantara Shah, Dr. Chaiti Gandhi, Dr. Samir Pagdar, Dr. Gautam Tambolu. I would like to invite our speaker, Dr. Rajiv Grover.
Good afternoon, everyone. At the outset, I would like to thank
Coming to the last session of this motility disorders, for the management of esophageal motility disorders, especially based on manometry findings, we have our last speaker, Dr. Rajiv Grover from AGI Gastro City, Ludhiana. Please, sir, you can start.
Thank you, Chairperson. Good afternoon, everyone. Thank you, dear Dr. Yogesh, for the kind invitation. In next couple of minutes, I'll be speaking on esophageal motility disorder and its treatment. Dr. Kapil has made my work very easy with few description regarding HR manometry. In few couple of slides, I'll be discussing what is the approach to the diagnosis of esophageal motility disorders, what is the role of high resolution manometry, what are the disorders of EGJ outflow obstruction, disorders of esophageal peristalsis, what is secondary motility disorders, and few case capsules we'll be discussing. As we discussed, whenever a patient of dysphagia comes, it can be oropharyngeal dysphagia, it can be esophageal dysphagia. If some patient is having, there is a difficulty in start of deglutition, there is a post-nasal regurgitation as cough, we are dealing with oropharyngeal dysphagia. But if it is not so, then we are dealing with esophageal dysphagia. In esophageal dysphagia, if the dysphagia is starting initially with the solids, then progressing to liquids, so we are dealing with motility, that is a organic cause. But if solid and liquid are starting parallel, we are dealing with motility disorders. So we will be discussing esophageal motility disorders. So detailed history is very, very important. We should know what is the progression of dysphagia, whether it is intermittent or progressive, whether it is because of solids or it is solid and liquid simultaneously. Any history of opioid abuse is very important. Any history of connective tissue disorders like scleroderma or multiple sclerosis. Any prior history of fundoplication or pediatric surgery. So we have these diagnostic tools: upper GI endoscopy, high resolution manometry, barium esophagogram, and new on horizon is endoflip. Endoscopy is the first modality to evaluate suspected esophageal dysmotility. It is there to directly we can visualize mucosa to rule out benign disorders like peptic stricture, hiatus hernia. We can rule out malignant causes like C. esophagus. Very important is to examine G junction. Patient can be having pseudoclasia. But whenever a patient of esophageal motility comes, we may find retained saliva, foam, froth, sandpaper-like mucosal appearance of the esophagus, puckered ileus, and difficulty in passage of stool that indicates towards motor dysphagia. High resolution manometer is a gold standard to assess esophageal motor dysfunctions. We have three main metrics. First is IRP. It should be less than 15 mm in supine position. Second is DCI. It shows the contractile strength of esophagus. And third is distal latency should be more than 4.5 seconds. But if the findings are indeterminate, we need three provocative tests. First is we can shift the patient from supine to upright. Number two, multiple rapid swallows. And in this, we can assess the peristalsis result of the esophagus. And third is rapid drinking test. We give 200 ml of water that can unmask the raised IRP in these patients. Newer on the horizon is functional lumen imaging probe, which is known as endoflip. It is complementary tool to high resolution manometry. The EGJ distensive index of G junction, it is more than 2.8 is normal. In achalasia cardia, it will be very, very high. The normal diameter of EGJ on flip, it is 13 mm. And this endoflip, it is a newer modality. This helps to find out the length of myotube. And it can just tell us how the prediction of treatment outcome of poem will be there. And next is time barium esophagogram. In this, we see the height of barium at 1 minute, 2 minutes, and 5 minutes. It helps to identify structural lesions in the esophagus, maybe it is benign and malignant. So now coming to this classification, any esophageal motility disorder can be only classified on the basis of high resolution manometry, just like ECG. So in this case, we have two disorders mainly. One is disorder of EGJ outflow and disorders of peristalsis. In disorders of EGJ outflow, we have to see the IRP. If IRP is high, we are dealing with esophageal junction outflow obstruction. The achalasia cardia is a classical esophageal motility disorder. We have three types. In type 1, there is 100% failed peristalsis. In type 2, there is a more than 20% swelling. They are having pan-esophageal pressurization. In type 3, there is a more than 20% contraction. They are premature. Type 2 is considered as earlier stage of achalasia cardia and is having most favorable outcome with any treatment. And type 1 as typically later stage of disease progression. These are the treatment modalities. We have pharmacotherapy, we have botulinum toxin, pneumatic balloon dilatation. Diagnostic initially gold standard was lab Heller smartly. Now on the horizon is third space endoscopy, that is point. So in pharmacological options, we have calcium channel blockers, nitrates that can be given 10 to 30 minutes before meals, but its effectiveness varies with the significant side effects, but they are indicated only as a bridge to more effective therapy. Botulinum toxin was used since last 3 decades as a bridge to the patients who are unfit for pneumatic dilatation. It provides 80% lift within 1 month, but effect decreased to 40% at 12 months. But once the botulinum toxin is done, it causes so much of submucosal fibrosis, makes the further procedure very, very challenging. Pneumatic dilatation still be used. In this case, we dilate the achalasia with graded balloon dilatation with 30 mm, 35 mm, 40 mm balloon. Risk of perforation is very less when it is done graded, but again, it is a bridge to definitive therapy. Lab aneurysmectomy is in practice since last 2 decades. It can be performed with or without fundoplication. Efficacy is from 88 to 95% of patients. But now, latest on the horizon is third space endoscopy. This is a game changer in the management of esophageal motility disorders. The efficacy is very high. It is at 90% success rate over a period of 5 to 7 years. So this is a live case. My mentor and senior Dr. Mali is here in Punjab. The routine in all patients of point when we do. So first we have to make in the posterior point, we have to make injection. At 5 o'clock, we have to make a submucosal tunnel up to in the esophagus and 3 to 4 centimeters into the stomach. Then we do myotomy with DT9. The myotomy can be selective, it can be total myotomy. We cut the circular as well as longitudinal muscles. And after doing myotomy, we assess the G junction going into the esophagus and we close the defect with hemoglyphs. So this is the class 1 indication for eclampsia cardiac nowadays. So these are all modalities. What is the right option? The decision should be based on disease profile, patient preference, and local expertise. POEM is the first line modality in type 3 eclampsia. In type 1 and 2, Heller's myotomy and POEM both are same. But if expertise is available, then again POEM is the first modality as compared to the Heller's myotomy. In real world, POEM has replaced where expertise is available Heller's. But patients who are unfit for definitive options, we can do pneumatic dilatation, botulinum toxin, and medication can be given. So coming to whenever there is isolated EGJ outflow obstruction, it can represent, just Dr. Kapil has shared, it can represent the variant of eclampsia cardia type 3. So elevated IRP can be because of fundoplication, bariatric surgery, cancer, any infiltrative lesions. It can be because of luminal stricture. It can be because of opioids. So in doubtful cases, we should do cross-section image like CT scan. So what is the treatment? EGJ outflow obstruction is isolated. Don't always warrant treatment. 50 to 90% of patients have mild symptoms. They might have spontaneous resolution. So treatment is considered in the patients who have moderate to severe symptoms. Botulinum toxin injection can be done. Endoscopic dilatation can be done. In non-cardiac chest pain, because of this, we can give smooth positional relaxants or tricyclic antidepressants. So now we go to other segment, the disorders of esophageal peristalsis. It can be esophageal spastic disorders. It can be esophageal hypomotility disorders. In spastic disorder, first we have diffuse esophageal spasm. When more than 20% swallows are having premature contractions with normal IRP. True death is very, very rare. This can be early spectrum of type 3 eclampsia. So barium esophagogram helps in this condition. Second is hypercontractile esophagus. When more than 20% swallows are having hypercontractile, the DCI is more than 8,000. So this again supportive test can be done with barium esophagus. What is the treatment? In mild symptom monitoring is the reasonable alternative. Evaluation of reflux should be done, pH impedance should be done, and these patients should be given anti-reflux treatment. But if patient is not responding, smooth muscle relaxants, calcium channel blockers, even phosphodiesterase inhibitors like sildenafil can be given. If there is dysphagia, we can inject with botulinum. We can dilate if there is strictures. If there is chest pain, again, neuromodulation will be of great help. Ineffective esophageal motility. If more than 70% contractions are ineffective or more than 50% peristalsis, they are failed. DC is less than 100. The clinical relevance of this entity is still not known, but it is very important when we're contemplating any anti-reflux surgery. We should do high resolution manometry to find out what is the peristaltic reserve of these patients. Absent contractility, when there is 100% failed peristalsis, esophagus is not moving. It is basically known as scleroderma esophagus. So in hypometabolic disorders, treatment is very challenging. In these patients, management should be focused on predominantly symptoms of these patients. So second motility disorders, we see these defects in eosinophilic esophagitis because eosinophilic causes transiently reversible esophageal dysmotility. We see this in connective tissue disorder in scleroderma as well as Sjogren syndrome. Same is that the patients who are on opioid, these patients spastic esophagus because of drugs. Any patient with fundoplication, post-fundoplication pain patient can esophageal dysmotility. Again, patient who are doing any bariatric surgery, patient will be having certain motility defects. So dear friends, with this, I have only 3 clinical scenarios. First patient, 39-year-old male, dysphagia 2, solid and liquid since last 3 years, weight loss is there, endoscopy is showing achalasia cardia, manometry is showing type 2 achalasia cardia. What should be the plan? So again, type 2 achalasia cardia in this patient, which is when patient has complete symptomatic response. Type 2 profile is different. 76-year-old male, diabetic, hypertensive, CAD, ejection fraction very less, endoscopy, achalasia cardia, HRM, type 1 achalasia cardia. The plan is pneumatic dilatation. Patient is in symptomatic partially. Third is very interesting, the latest patient of 2025. He was having hiatus hernia. We did fundoplication. Patient was very happy. Now in August, patient started having dysphagia as well as atypical chest pain. Nothing was possible. We did HR manometry. Patient was having post-fundoplication hypercontractile esophagus. So in this case, we did balloon dilatation. Patient is on follow-up. After 2 months, patient is clinically symptomatically better. So dear friends, to summarize, the spectrum of esophageal motility disorders is expanding because of increasing awareness and availability of high resolution manometry. Detailed history is very important regarding the onset of dysphagia, medication, systemic disorders, and surgery. High resolution manometry is a gold standard to diagnose. It is complemented by barium esophagus graph and endoclip. Achalasia cardia, which is the first time modality in type 3 achalasia, esophageal, spastic, and motility disorders. The management should be focused towards improving symptoms and indeterminate motility disorders. We should follow these patients with symptom correlation and we should repeat manometry at regular interval to find out what is the natural history of these patients. Thank you everyone for the patience.
Thank you, Dr. Rajiv. Due to time constraints, we can have only one question from the audience. Any question from the audience?
Yeah.
Repeating manometry after the procedure. When do you repeat manometry after doing the procedure?
Absolutely fine. Because nowadays we repeat manometry at 6 to 8 weeks after all points. Because in center, courtesy Dr. Mani said, we have used endoclip on trial basis. But it is very, very costly. So routinely we keep, if the IRP is less than 10, 6 weeks to after weeks, probably we've done the work very well.
Thank you, sir. Now we can close this segment.
Now we'll be starting with very interesting session on acute pancreatitis. We have seen that most of the physicians, surgeons, and general practitioners, when they have pancreatitis, they panic and they refer the patient, but always it is not so. So now for next 2-3 hours, it will be very interesting session on acute pancreatitis.
Now we will have a case-based panel discussion on the recurrent acute pancreatitis. I would like to invite our panelists, Dr. Challapati Rao from KIMS Hospital, Vizag, Dr. Deepak Gunjan from AIMS, New Delhi, Dr. Naresh Bhatt from Esther CMI Hospital, Bangalore, Dr. Chirayu Chokshi from Adikura Hospital, Vadodara, Dr. Ravindra Gade from GASTRO Plus Hospital, Ahmedabad. I would like to invite our speaker, Dr. Supreet Sood.
So, at the outset, I'd like to thank Dr. Yogesh Sarvani for his kind invitation. It's my fourth time here, and he never ceases to amaze me with how many physicians he gets on board. Hopefully, we make a dent in your knowledge as well. And please make it bilateral, the entire conversation, not just restricting ourselves to the panelists, but I would like to open some questions to the house as well. To start off, we know this is quite a conundrum in most GI units, how to deal with recurrent acute pancreatitis patients. They come in the OPD and emergencies, but some of the questions become very hard to answer for the family as well. So we know what is acute pancreatitis. We still stick to the revised Atlanta classification more than a decade ago. So at least two out of three features should be present to define acute pancreatitis. Abdominal pain consistent with the diagnosis, which means that acute in onset, usually moderate to severe epigastric pain, often radiating to the back. Serum lipase or amylase activity of at least 3 times the upper limit of normal for the lab, and characteristic findings of acute pancreatitis on contrast enhanced CT, and sometimes we do an MRI ultrasound for the same. So these are the broad causes of acute pancreatitis. Mostly we did in younger patients, we did idiopathic acute pancreatitis, and gallstones still are extremely common. Alcohol, always be thorough with the history. Trauma in younger patients, especially bicycle-related accidents in young children, they can need to complete disconnect of the pancreas as well. Steroids and a lot of other drugs can also induce acute pancreatitis. Viruses like mumps and even COVID can cause it. Autoimmune pancreatitis, something we should not overlook when you're doing a thorough workup. And hypertriglyceridemia, hypercalcemia triggered by primary or secondary hyperparathyroidism. And nitrogenic pancreatitis after ERCP or pancreatic surgery, like post ripples, and a lot of drugs can, like anti-epileptic agents, can induce acute pancreatitis. So what is recurrent acute pancreatitis? We feel is still on the spectrum between what was acute pancreatitis to begin with, and more often than not, in more than 70% of the patients will lead to chronic pancreatitis, especially in the idiopathic variety, or even ethanol-related acute pancreatitis if the inciting agent or repeated triggers are not avoided. So it's a journey from acute to chronic usually. So these are the points I'll be discussing with my panelists. Definition of recurrent acute pancreatitis, differentials of the cause of pain after such an episode, etiology, diagnostic algorithm, and broad treatment. So the first case, a young male comes to our emergency with the first episode of acute pancreatitis in 2017. He has history of significant alcohol abuse. Severity is moderately severe acute pancreatitis as per his imaging and clinical scenario. Was managed conservatively and discharged 8 years ago. Remained well for a year or so. Then came back after a year with a similar second episode, had restarted alcohol intake about last 3 months, had a recent alcoholic binge at a party, and severity at this time was milder. Between 2020 and 21, he continued to take alcohol, had multiple hospitalizations for similar pain. CTs did not show any definite features of chronicity, even though mild to moderate trophy was getting noted in 2021. In the end of that year, he was readmitted with mild pain, and CT showed onset of effects of calcification in the pancreas. So the first question is this recurrent acute pancreatitis? To Dr. Challapati Rao, was this a case of recurrent acute pancreatitis or chronic pancreatitis, and how do you define this entity?
Syndromic wise, yes, this is recurrent acute pancreatitis. And there are actually multiple definitions, but at least if two episodes which are spaced at least 3 months apart, with the documented evidence of pancreatitis as we have defined with pain, radiological evidence, and is lipase. So, and in between, there should be a normal episodes which can be documented. Sometimes it may not be possible. But here, actually, there are some specks of calcifications that we have actually, shown. So probably it is going into some kind of chronic calcific kind of disease as well.
So rightly answered. So the 3 month gap is essential, but at the same time, be sure that on any cross-sectional imaging or even just an ultrasound, there's no collection from the first episode, because that will never let the amylase and lipase settle down to a normal value. So normalization of biochemistry and normalization of imaging, if available between the two episodes, is a must as well. And there should be no definite evidence of underlying chronic pancreatitis or any such fluid collection, as I've mentioned. The 3 month timeline, an attack is expected to resolve by that time unless a fluid collection persists. So always rule out a walled off necrotic or pseudofluid collection of the first attack. And an ideal contrast and CT is recommended to exclude chronic pancreatitis. So I think Dr. Naresh Bhatt is not here. So I can pose this question to Dr. Deepak Gunjan. Does every pain episode after the first attack of acute pancreatitis denote a recurrence?
No, it's not necessary that every episode of pain is labeled as acute pancreatitis. The initial stage of acute pancreatitis either moderately severe or severe. It can be complication of acute pancreatitis per se also. Like the patient has fluid collection, the patient can have gastric obstruction, patient can have a stress ulcers. But if acute pancreatitis has resolved and patient has pain abdomen, typical pain abdomen, elevated amylase lipase, and particularly in ultrasound or imaging, there is evidence of pancreatitis, we label that it is acute pancreatitis. But definitely, you should look into that. Is this episode, second episode, or third episode is acute pancreatitis, or the cause of a pain is something different? Sometimes in these patients, they are not very common, but rarely they can have a mesenteric venous thrombosis also. It also can give rise to the pain and complications.
So always rule out chronic pancreatitis as well. So in our practice, an endosonography or MRCP should be done in case second attack of pain occurs. And ideally, the endosono, if you can time it, it should be timed around 6 to 8 weeks after the first episode or the second episode. So you do not get lot of haziness during imaging, and you can make a clear-cut diagnosis whether chronic pancreatitis is present or not. So again, to you, sir, what is the usual etiology that we see for recurrent acute pancreatitis patient?
So the common Figaro classification is followed, but our clinical setting, our practice, mostly it is alcohol is the cause of recurrent acute pancreatitis, or if there is a missed gallstone or microlithosis, these other common cause of recurrent acute pancreatitis. Rarely we do see the hypercalcemia and hypertriglyceridemia, very rarely we do see. We see more hypercalcemia related recurrent acute pancreatitis than the hypertriglyceridemia. And there are other rarer cause of recurrent acute pancreatitis. And idiopathic pancreatitis, particularly in younger age group, is common. And also now the evidence are that in recurrent acute pancreatitis because of idiopathic reason is also becoming common in our part of the population.
Rightly so, and now the more and more the role of getting genetic workup done, as I tell my patients, it may not make a dent in their life, but when they're planning a family, maybe that's where the change happens, and detecting these autosomal recessive genetic modifiers become very important, especially with anatomical variants like pancreas disease. So one of the most common etiology that we see in our male patients is alcohol, and that's up to 17% of recurrent acute pancreatitis. Then we also know that with complete cessation, your chance of transitioning to chronic pancreatitis goes down, and the complications like diabetes go down as well. Those who continue the same drinking pattern, their recurrence rates upwards of 50%, transitioning to chronic in up to 40%, and diabetes mellitus type 3 in around 40% as well. So timely stopping alcohol is a must if you want to reduce the patient's chance of transitioning into endocrine exocrine insufficiency with chronic pancreatitis. And there's a synergistic effect of alcohol and smoking together. There's a cigarette independent dose which can lead to recurrent pancreatitis, and recurrence rates are much higher in smokers as compared to non-smokers. So coming to our second case, again, a young 35-year-old lady came with severe abdominal pain. With their total bilirubin was 1.3, their SGOT is 161, SGPT 89, serum alkaline phosphatase relatively normal, lipase was more than 3 times upper limit of normal for the lab, their triglycerides and the calcium levels were normal, no history of any inciting drugs, no history of alcohol or smoking, past history of similar pain episodes around 3 months ago at another episode,
was a relatively mild episode and could be managed with conservatively with analgesics. Current ultrasound shows a partially distended gallbladder, no calculi, CBD is also normal. Pancreas due to gases not easily visualized and was managed conservatively and discharged. And the plan was to get a EUS at 6 weeks and repeat the metabolic profile at 6 weeks when the patient is completely pain-free. So this is the EUS picture of the patient. You can see the layering and the sludge and few microliths on endosono with the normal Wolico layer pattern of the gallbladder. So the next question to you, Dr. Ravinder. Microlithiasis is the cause of recurrent acute pancreatitis. Can you shed some light on this topic?
Microlithiasis is also one of the common. It's been reported in India. From 6 to 10, 15% of cases may be related to microlithiasis for recurrent acute.
So first is microliths are calculi which are less than 3 millimeters and cannot be easily visualized on a transabdominal ultrasound, but they are not the same as biliary sludge. They have a low amplitude echo in the gallbladder. When there's no acoustic shadowing, it's sludge, and there's layering of sludge. When they have some acoustic shadowing, it is just a microlith. And EUS sensitivity is very high, 96%. These days we do not need to do microscopy, but sensitivity was variable up to 95% for those. So this is data from AIMS, which has studied this, and etiology of recurrent acute pancreatitis around 13%. And the arguments against microliths as an inciting event, the terms microlith, sludge, microcrystals have been used interchangeably by a lot of doctors and in their studies as well. Early studies have not used endosono, it was not available to the same extent, and this may have led to improper classification of cases. And microliths in recurrent acute pancreatitis suspect biliary if LFTs are abnormal within the first 2 days of pancreatitis. And if they go undergo an endosono, always rule out microlithiasis. But if the GB is normal on endosono, LFTs are quickly normal, then please don't go ahead with a gallbladder surgery. So the rule of thumb which we follow in our unit is if a patient has presented with recurrent attacks of pain over a period of 6 months or longer, and yet gallstones are not done on ultrasound, it is highly unlikely the microliths are the underlying cause of recurrent acute pancreatitis. So coming to our third case, a 45-year-old lady from a neighboring country came to us, history of recurrent acute pancreatitis since 2018, multiple episodes in the last 3 years, frequency going up, history of diabetes in the last 5 years, evaluation of lipid triglycerides of 813, rest of lipid profile much better, HbA1c is 10.5%. So initiated on lipid-lowering agents, fenofibrate and insulin dose was titrated as well. So Dr. Chalapati, coming back to you, hypertriglyceridemia, I think is a cause of recurrent acute pancreatitis. Would you like to discuss that?
Yeah, so we sometimes come across with this etiology. So hypertriglyceridemia, because of the lipotoxicity, there will be increase in the intracellular calcium release and activation of enzymes and SNS cell injury. Downstream pathways will be high. It is contributed by the miscellaneous, the inflammatory mediators, and the viscosity as well. So we need to treat this with fibrates and insulin, and then we need to keep a check on the lipids. And sometimes it can be more than 1,000, 2,000 also. And as we introduce the diet over the course of this recovery of acute pancreatitis related to hypertriglyceridemia, again the diet is very important because the diet itself can again induce the hypertriglyceridemia. Because once we start these therapies, it can come down to 300, 400. Once patient starts diet again, it can shoot up to 800. That is one of the key that very important.
Yeah, so I think these cutoffs are to be kept in mind for all physicians here. Triglycerides below 500 very rarely will be a inciting factor. Mostly we consider value above 1,000 to be a definite cause, but also consider the fact that the later the patient acute pancreatitis due to hypertriglyceridemia comes to your emergency room and the first time you get a lipid profile, some consumption of triglycerides is occurring during the process of saponification. So a value around anywhere between 500 to 1,000 you should consider as a probable etiology. So this was data from 2019, which showed that ambulatory triglyceride levels have a risk of recurrence in these patients who had a first episode of triglyceride-induced acute pancreatitis. In the range of 200 to 500, the adjusted risk ratio was 5.5, and those over 500 was almost double of that. So always keep that in mind. So this is the fourth case. Again, a 50-year-old man, 3 distinct episodes of acute pancreatitis, each 1 month apart. The LFTs are normal, the calcium triglycerides are normal, undergo an MRCP, which showed an MP dilatation on 4 millimeter in the head without an obvious mark noted. This is the side wing endoscopy that you can see. So this question, Dr. Chirayu, to you. So ampullary tumors, do you see that as a cause of recurrent pancreatitis in your practice, and how do you approach these patients?
Yes, around less than 7% of patients with ampullary tumor can present as an acute pancreatitis, especially in the elderly population. And MRCP and the CT can miss tumors less than 5 mm. That is where the role of US, especially the image which you are showing is in the second part. Very beautifully, you can see the tumor arising from the bile duct going up to the main pancreatic cavity. So this is where the role of US is definitely there.
So yeah, so in this patient, when the endosono still wasn't a great patient to do a FNB, so we do a small papillotomy, take a biopsy, and send some brushings as well. And the brushing showed on day 2 the ampullary possibly ampullary adenomatous cells. So we strongly suspect this as an etiology in patients who are coming of the age of 50 for the first time without another identifiable cause of recurrent pancreatitis. Prevalence, as Dr. Chokshi mentioned, around 7 up to 7%. Imaging would be an MR or endosono is better. For small tumors, endosono is much more sensitive to pick up these tiny lesions. The next case, a very young nursing student presented with recurrent abdominal pain for 3 years and evaluated another hospital, diagnosed with a focal pancreatitis. On ecological evaluation, no obvious toxic, metabolic workup was normal. This is the MRCP of the patient. So Dr. Deepak, to you, what do you think of this MRCP image, and can this be a probable etiology for the acute pancreatitis and recurrent?
So this image showing pancreas division because you can see that duct is crossing the cilia. The best way to recognize it. As a cause of recurrent acute pancreatitis, it is controversial. The initial studies has shown there is a relation between the pancreas division and recurrent acute pancreatitis. But however, if you will see the recent studies in last decade, it is as a cofactor. It's not a sole factor of deciding as a cause of a recurrent acute pancreatitis. Because the study has found that there is associated genetic mutations in this group of patients that leading to the recurrent acute pancreatitis. And the EMS study has shown that, an AIG study also shown that the SPINK1 and the pepsin B mutation is associated with as a cofactor in case of recurrent acute pancreatitis along with the pancreas division.
So data from across the board says that alone pancreatitis cannot be considered the culprit, and usually, but in this subset who are coming with such a presentation, who are genetic profiling, most of the labs are offering a whole exosomal sequencing, where most of these chronic pancreatitis or recurrent acute pancreatitis related genes will show up, and that is again useful for their family planning counseling. So Dr. Chirayu, for you, role of ERCP in this patient subgroup with pancreas division.
Yes, a very difficult decisions. Patient keeps coming to you, pancreas division is there, minimally ductal dilatation of 3-4 mm in a young child. Parents are anxious. Definitely, we have to do ERCP, do a pancreatic papillotomy. Three golden rules are: number one, you have to cannulate the minor papilla, put a short stent for about 4 to 6 weeks. The stent may fall off by itself. Always do a papillotomy over the stent. If you follow these 3 steps, usually it is quite safe to do ERCP in pancreas division, especially when you're worried in a young patient.
So yeah, there was initial data was very optimistic about intervening in these patient subgroups with doing a papillotomy or doing a minor papilla stenting. So this was the initial paper of 92, which showed that the original enough scale for pain that did improve in the stent group in large majority vis-a-vis the control group. And now with the evolving time, the role of ERCP, the efficacy has gone down. And the newest data is from the SHARP trial, which was started in 2019 and has been concluded this year in May. So they have studied in a sham controlled, randomized controlled trial setting, role of synchrotony of this minor papilla in these patients subgroup with 3 divisions. So the SHARP trial showed no obvious benefit of doing an ERCP with a minor papilla synchrotony in these patients with idiopathic recurrent pancreatitis with pancreas division. And acute pancreatitis as a complication occurred in 35% patients in the intervention group. These are with 44% in the sham group. So maybe this is something which has been a bit of a revelation in the last year, that it did not make much of a difference. We might be giving them more episodes of pancreatitis rather than helping them. So maybe this should be studied in our Indian patients as well. Maybe a multi-center trial should be in the works. So just as a conclusion for etiology, we know hypercalcemia patients evaluate the vitamin D first. Don't just go straight away go for PTH levels. The vitamin Ds are low, correct them to rule out secondary hyper-PTH. rise. And but if they are normalized, then primary hyperparathyroidism should be considered. Look for parathyroid adenomas in those patients, get a good neck scan and their molecular scans as well. Drugs should be thoroughly investigated in this patient, be it azathioprine, fibrates, which a lot of hypertriglyceridemic patients are on. So you're never sure what caused it, the drug or the triglyceride. AUBPD as a anomalous union, again, no definite treatment, no role of ERCP yet. For docosheal, deroofing of the cyst or surgery may be helpful. Annular pancreas association with the causative role in RAP is still weak, but a surgery for the creating a GJ may be useful. Again, for etiology, sphincter dysfunction now is taking a very, not a very prominent role alone. And type 3, which was considered something very important, is not considered a disease entity at all. And this study has shown that both biliary sphincterotomy and double sphincterotomy biliary pancreatic were equally effective. Hence, pancreatic sphincterotomy may not be useful in this patient group. Dr. Ravinder, what is the approach to these patients who come with recurrent acute pancreatitis? Just quickly.
So basically, we'll do some baseline report, like F followed by imaging, maybe in the clinical class. And then if they are negative, I'll go for this.
I think we can skip through a lot of this. We have discussed it already as the etiology. What is the role of EUS, Dr. Chirayu? We discussed it in short, but just as a brief.
It is the first line of investigation, especially when beyond 6 weeks of the first attack. It can pick up small abdominal tumors, very small stone particles, maybe 3, 4, 5 mm in the lower bile that missed on the radiological investigations. It can pick up microlithiasis as well. Most importantly, you may not need an MRCP if you are doing the good EUS to pick up a pancreas division. So all this highlights the role of EUS with a very high sensitivity.
So timing the EUS correctly is very important. Let's not, don't do it during the pain episode. And genetic testing is very important. So therapeutic approach, ERCP with biliary sphincterotomy patient with the obvious CBD stone of ladopofil may be helpful. As I said, in pancreas division, no real role. SOD3 patients do not do a ERCP as shown by the episode trial. Cholecystectomy, if there's definite proven biliary pathology or you have recurrent episodes with microlith. Medical therapies, UDCA has some beneficial effects, but always be sure that if despite UDCA they are having recurrent episodes, presumably due to biliary etiology, get rid of the gallbladder, even in a young patient. So to summarize, when a patient comes to you, check their history thirdly for alcohol and smoking and keep harping on it. If there are gallstone abnormalities in the first 2 days, biliary etiology is proven, get rid of the gallbladder when time permits. If they're not alcoholic, not biliary pathology, do a detailed drug history, family history, check their calcium, triglyceride, and PTH levels. Best practice, do an endosono. We don't have to treat an MRTP. Some data is with pineapple juice in our MRTP. We don't do it in our practice. Look for gallstones or microliths. Look for CBD stones, pancreas division, producocele, small ampullary tumors or a normal anatomy. Gallbladder to be removed when feasible, endotherapy for limited etiologies, surgery for tumors, and for normal genetic testing. I don't think there's a role of manometry into this time. So thank you, everyone. Thank you for my panelists for all the answers. And please, I'd like to invite all of you for our next edition of the Endoscopic Premier League in April of next year, held by our team at Medanta. Thank you.
Very lucid talk. Nowadays, as earlier we used to see many fatty livers on USG, now we are seeing fatty pancreas on USG and CT. So do you think this is a potential, this may be a potential cause of recurrent pancreatitis? Any message you would like to give?
Yes, it is. I think same etiopathic anesthesias are sitting in the pancreas, these are with the liver. It's an organ which is more prone to fibrosis compared to the liver, less regenerative potential. So when we see patients with fatty pancreas, with data coming in, the triglyceride levels may actually correlate, the metabolic profile metabolomics correlates with early fatty pancreas, even adolescent age group. And there is now data coming in that might be a early predictor of future pancreatitis episodes.
Sukhvit, I think very beautifully shown so many cases. One query, you are here and telepathy is there. Any role of IgG4 if you've drawn totally blank in everything, type 2 autoimmune pancreatitis as a cause of recurrent acute? Do we do IgG4 at any point of time in evaluation of recurrent acute pancreatitis, or it has no role whatsoever?
No, I think it does. In the right setting, right, type 1 is where we rule out with IgG4. Type 2, they will not have IgG4 in majority of the patients.
Type 1, I think, more with a mass only, mass and obstructive jaundice. Recurrent acute will be anecdotal.
Yeah.
Type 2 is the one which
almost in half of the cases by
Represent an acute attack. Yeah.
the
So
treatment.
IgG4 I would not like to use as a ruling out factor at all because I think it's a negative predictive value even for type 1 AIT. For type 2, it has no role to rule in or rule out. It will be a tissue diagnosis in the end. And obviously, do random rectal biopsies. And a lot of these patients are harboring latent IBD, ulcerative colitis variant.
Sir, definitely not for RAP.
Not okay.
That definitely does not require. If you have some suggestion on imaging findings, if it is typical, definitely. If it is even the atypical findings, like a focal pancreatitis or focal mass like, or there are other organ involvement, then you should do it. But not typically for recurrent acute pancreatitis, you should do because there is false positive. Okay.
Type 2, we have more of 50% IBD association. And IgG4 is frequently not possible, but it still presents as recurrent acute pancreatitis. It is the concept.
Thank you.
Thank you, sir, for sharing your experience with us. Now we will move to our next session on the stepwise management of acute pancreatitis. I would like to welcome our chairperson, Dr. Abhinav Jain, Dr. Sheetal Patel, Dr. Ashok Khatri, Dr. Mahadev Desai, Dr. Bhumit Patel. I would like to call our first speaker, Dr. Vikas Singh.
Hello. I invite Dr. Vikas Singla for his talk on acute pancreatitis symposium, Day-1, stepwise management of acute pancreatitis, less than 2 weeks.
Good afternoon to all of you. Thank you, Yogesh, for the kind invitation. I must appreciate two qualities of Yogesh. One is the excellent management skill, and second is the hard work. So this meeting is proof of all both the qualities. He has many other qualities, but I think these are two qualities I admire most. So I will be discussing about acute pancreatitis. So pancreas is a small beautiful organ which is in the retroperitoneum. It helps in digestion of food, controls blood sugar, but it's also home to the two deadly diseases. One is the acute pancreatitis, you can kill the patient, and second is the pancreatic cancer, again having a bad prognosis. So in patient with the acute pancreatitis, there is sudden onset acute inflammation of the pancreas, and as discussed previously, gallbladder stone and the alcohol are the most common cause. And the most common symptom is the epigastric pain going to the back, associated with the vomiting and reduced bladder. Patient will have abdominal distension, vomiting, and this can be confused with the bowel obstruction also. And there are two phases in a patient with the acute pancreatitis. In the first phase, there will be systemic inflammatory response syndrome. Patient will have tachycardia and dyspnea, and there can be organ failure also. There can be renal failure. There can be respiratory failure. And second phase start after the 2 weeks, and then there is a local injury in the retroperitoneum. There can be fluid collections, and the fluid collection can get infected, and they can lead to secondary organ failure. Treatment of acute pancreatitis needs a team approach. There should be gastroenterologist, GI surgeon, intervention radiologist, nutritionist, and the intensivist. So this picture shows the treatment of pancreatitis over last 30 years. 30 years back, pancreatitis was a surgical disease, and the most of the patients were treated by open surgery, and there was high mortality. And gradually it was felt that surgery leads to mortality and surgery should be avoided. Now it has become more of medical disease. Now most of the patients, they are managed without intervention or minimally invasive approach. It placed drains through the endoscopy or percutaneous drain. So from surgery, it has become a medical illness. So in a patient with acute pancreatitis, key issues are diagnosis, finding out etiology, and how to use imaging
to assess the severity, which patient should go to the ICU, and then role of ERCP. So to diagnose acute pancreatitis, we need 2 out of 3 criteria. First, they should be typical abdominal pain. So what is the typical pain of acute pancreatitis? It's the epigastric in location. Sometimes there can be diffuse pain. Otherwise, typical pain is epigastric pain boring to the back and relieved by bending forward. The pancreas is retroperitoneal organ. When the patient bend forward, there can be relief in the pain. It's associated with the vomiting, obstipation, and abdominal distension. This is typical pain of acute pancreatitis. And there should be elevation of either amylase or lipase should be more than 3 times of upper limit of normal, or there should be evidence of pancreatitis on imaging like ultrasound or CT scan. So only 2 out of 3 criteria can be satisfied to diagnose acute pancreatitis. It means that patient having typical pain along with the amylase, it's sufficient to diagnose acute pancreatitis. Not all the patients with pancreatitis will require CT scan to diagnose acute pancreatitis. So only 2 out of 3 criteria are needed. So if you see role of amylase and lipase will have earlier peak and it will come down to normal earlier. Lipase will peak later on, but the level remains elevated for a longer time. So if patient come after 5 days, then lipase can be a better marker for a diagnosis of acute pancreatitis than amylase. So lipase is more sensitive and more specific than amylase, and it has a broader diagnostic window. Patient with alcoholic pancreatitis or due to increased triglyceride level, they can have normal amylase despite of having acute pancreatitis. In this patient, lipase can be used, which has higher sensitivity in this situation. So not all the epigastric pain are due to acute pancreatitis. There are differential diagnoses like acute cholecystitis. Again, patient will have typical pain in the epigastrium, but now this will radiate towards the right side, or there can be shoulder pain. CBD stone again can lead to epigastric pain with the increased amylase, but on LFT there will be increased bilirubin. Patient with the intestinal obstruction can have vomiting and pain abdomen, can be confused with the acute pancreatitis. Bowel ischemia and gangrene can be confused with the acute pancreatitis. They both have severe pain, obstipation, and vomiting. Intestinal perforation can also be confused with the acute severe pancreatitis. So these all are the differential diagnoses for acute pancreatitis. MI, especially the right-sided, can have epigastric pain and can be confused with the acute pancreatitis. Already discussed, gallstone and the alcohol are the most common causes. After ERTP, 2 to 3% of patients can develop acute pancreatitis. Raised calcium, raised triglyceride are the common causes of acute pancreatitis. Infection during COVID, we have seen a lot of patients came with the pancreatitis, and hepatitis E virus also can lead to combined acute hepatitis and pancreatitis. In children, trauma is a common cause of acute pancreatitis. Drugs are common cause of acute pancreatitis. Recently, we have a patient who had pancreatitis due to methotrexate last week only. Pancreatic divisum is a doubtful cause of acute pancreatitis. So how should we work up this patient? So first of all, we should take history of alcohol intake, endoscopic intervention, or family history. If patient has fever prior to onset of pain abdomen, it's very suggestive of viral pancreatitis. Most of the patients with pancreatitis, they don't have fever in the initial phase until unless they have simultaneous cholangitis. Fever followed by pain is very typical of viral pancreatitis. Repeated attack of pancreatitis, young male, it's early presentation of chronic pancreatitis. So ultrasound should always be done in a patient with acute pancreatitis to rule out gallbladder stone. Day 1, we should always do liver function test. As soon as patient comes to us and we are suspecting biliary pancreatitis, we should do liver function test. If the patient has elevated bilirubin, elevated SGOTPT, it's highly suggestive of biliary pancreatitis. Even ultrasound abdomen may be normal, may not show gallbladder stone. This patient may be having microleak. So normal ultrasound, but with the elevated bilirubin, elevated SGOTPT, it can be a biliary pancreatitis, and we should also do calcium and parathermal level. So if ultrasound is normal, LFT or deranged, we can do endoscopic ultrasound that can show small stone in the gallbladder. These are microleak. This patient will be benefited with either by ERCP or lap cholecystectomy. Can we restart the? Day 1 neurofunction test is a very important investigation. Also, role of imaging. Ultrasound should be done in every patient to rule out gallstone. If there is a suspicion of CBD stone, either endoscopic ultrasound or MRCP can be done. If the diagnosis of pancreatitis is not clear and we are suspecting perforation or ischemia, CT scan should be done in these patients. And to assess the severity, especially in second week, we should do CT scan with the contrast to delineate the pancreatic necrosis. Unnecessary imaging should be avoided, especially in a patient with a mild pancreatitis. We should be doing CT scan. It will add to the post. So pancreatitis is a evolving disease. So patient may not be having severe disease today, but he may develop organ failure later on. So how can we predict patients are going to develop severe disease? So there are multiple scores. The Ransom score is more than 3, Apache score more than 8. It indicates that patient is high risk of developing organ failure in a later time, maybe on day 3 or day 4. And thirst is the best indicator of prediction of severe pancreatitis. What is thirst? Patient having tachycardia, hypothermia, leukocytosis, or leukopenia. Patient having these features are likely to develop organ failure and severe pancreatitis and potential mortality. So search with the high IL-6, high CRP. These patients are sick patients, they may develop severe pancreatitis. So how we define severe pancreatitis? Very simple criteria, Atlanta criteria. Mild pancreatitis, no organ failure, no local complication, no cirrhosis, no fluid collection. So it's a mild pancreatitis. Moderate pancreatitis, patient having transient organ failure lasting less than 2 days, transient renal failure, or local complication in the form of pancreatic fluid collection or cirrhosis or the world of necrosis. Patient having persistent organ failure like renal or respiratory failure, they are classified as severe pancreatitis. And we calculate organ failure according to modified Marshall score. Score is more than 2 for any system defined organ failure. So which are the patients who require ICU admission? Patient having organ failure would be kept in ICU. Patient suspected to have intra-abdominal hemorrhage would be in ICU. They have high mortality. Patient having infected necrosis, sepsis should be in ICU. And patient having chronic fistula, they should be managed in the ICU. So coming to IV fluid, patient with acute pancreatitis, they have limited oral intake due to pain and they have vomiting. They may develop hypovolemia and organ failure. So ringer lactate is better than the normal saline. Meta-analysis of 5 RCT has shown that ringer lactate is better than the normal saline to prevent the organ failure. And how much fluid should be given? This is a waterfall trial which compared aggressive fluid with the moderate fluid. One arm given 20 mg bolus, other arm 1.5 ml per kg per hour fluid. And it was seen that patients who were given moderate fluid, they had better outcome than patients who were given aggressive fluid. Patients who were given aggressive fluid, they were more likely to develop congestive heart failure. So ideally, we should be giving 1.5 ml kg per hour fluid ringer lactate. Bolus should be given if patient has hypovolemia. Target blood pressure should be 65 to 85 mean arterial pressure. Unit output should be 0.5 ml per kg per hour. And one should be targeted less than 20. Routine use of antibiotics should be avoided. Antibiotics should be used only if the patient has infected pancreatic necrosis. CT showing collection with the air inside, or we are suspecting cholangitis, pneumonia, or UTI. For pain control, we can use either the opioids or NSAIDs. Opioids have better control than the NSAIDs for the pain relief. but they can lead to respiratory depression or IVS. For patient having severe pain only, we should be using the opioid. Early nutrition should be started. It can prevent the bacterial translocation and infection. Oral feed, if possible, should be started. If patient has vomiting, NG or NJ can be placed. ERCP should be done selectively in patient who has cholangitis. Sometimes there can be stone stuck at ampulla. They should be offered ERCP. Only indication of ERCP is the cholangitis in a patient with acute pancreatitis. Routine ERCP should be avoided in a patient with acute pancreatitis. And patients who are having biliary pancreatitis, mild pancreatitis, surgery should be offered prior to discharge. Otherwise, there is high risk of recurrence of pancreatitis. Mild pancreatitis, do the lab cholecystectomy before discharge. And in moderate pancreatitis, after resolution of all the collection, lab cholesterol should be offered. Last is the pharmacotherapy. Many drugs have been tried to prevent the organ failure in acute pancreatitis. No drug was found to be useful to prevent the severity of acute pancreatitis. Protease inhibitor meta-analysis showed that there was no benefit of protease inhibitor. Similarly, steroid failed to show any effect in preventing organ failure in acute pancreatitis. So there is no medication for failure of prevention of organ failure in acute pancreatitis. It's mainly the supportive care in first 2 weeks. So to summarize, gallbladder stone and the alcohol are the most common cause of acute pancreatitis. For diagnosis, we need the clinical presentation, phase, amylase, lipase, and imaging. 2 out of 3 criteria should be present. Day-1 LFT should be always advised in a patient with acute pancreatitis. It may help in diagnosing the etiology. Ringer lactate is better than normal saline for the resuscitation. Aggressive fluid should be avoided. Best is to give 1.5 ml per kg per hour fluid. No role of prophylactic antibiotic in a patient with acute pancreatitis. No pharmacotherapy can prevent the organ failure in a patient with acute pancreatitis. And in patient with the mild pancreatitis, gallbladder should be offered in a patient with biliary pancreatitis. Thank you very much for the patient there.
Thank you, sir. So we'll be taking questions at the end of the symposium. So please have your seat.
I would like to call our speaker, Dr. Chalapati Rao. He will cover the topic of stepwise management of acute pancreatitis in 2 to 4 weeks.
Yogesh, thank you for the kind invitation. Congratulations for yet another meeting from Dixon. So the management of acute pancreatitis week 2 to 4. So Dr. Vikas has covered the first 2 weeks of management. Slides, please. Yeah. So I'll just give you a case detail. Briefly, 45-year-old lady with gallstone pancreatitis. She was detected to have SARS, initially managed outside with oxygen support, with IV tramadol, PPI, and IV fluids. And she was started on day 5 with NJ feeds, and ultrasound showed a peripancreatic fluid with bulky pancreas, abdominal pain, and the distension improved. She started passing platters and stools. There was no fever, and she could able to tolerate oral diet, and she was discharged with oral medications. But after 2 weeks, she developed fever with intermittent pain and vomiting, and she was referred to our hospital. And we detected to she's having tachycardia with 92% of saturation on oxygen support with a PaO2 by FiO2 ratio of 320. Patient was again shifted to nasojejunal feeds due to poor tolerability of NG feeds. And CT scan showed necrotizing pancreatitis and ill-defined collection of 12 to 7 centimeter in the lesser cell. The first slide is the first initial management. She improved, and patient again got readmitted with pain, fever, and she had a collection. Now this brings us to actually the real problem of acute pancreatitis, especially in moderate to severe cases, because these patients between 2 to 4 weeks, they really present with still persistent organ failure or a recurrent organ failure. There will be issues with nutrition. There can be necrosis and fluid collections. There can be suspicion of infection, and there is an issue how to manage them. So this is the representative CT of this patient having some pancreas and large peripancreatic collection with extra pancreatic necrosis. So the major concerns in 2 to 4 weeks of acute pancreatitis is basically an organ failure, which can be secondary. The primary organ failure, which can happen in the first week, settles down, but secondary organ failure can happen, and there can be a potential infection of pancreatic necrosis. So coming to secondary organ failure and infected pancreatic necrosis, the risk of mortality is high. So the organ failure, which is secondary to sepsis and infected pancreatic necrosis, is basically a secondary organ failure. It can happen late in the course of pancreatitis. There is a large window of opportunity to treat, and the basic treatment is control of sepsis, and the prognosis is relatively better. So if you see the infected pancreatic necrosis patients, those who have primary organ failure in the first week of illness, almost half of them, they die. But at least 36% of patients still die because of secondary organ failure or ongoing infection. And if they don't have organ failure, 4% of patients only die. So having this combination of secondary organ failure and infected pancreatitis and recognizing this combination is very important and treat them accordingly. So for example, if the patient had some kind of collection and there is no fever, there is SIRS and TLC is high, still it is called sterile collection. Generally, we don't consider infected pancreatic necrosis. So largely the treatment of sterile pancreatic fluid collection depends on two things, whether there is necrosis and what is the size. Generally, more than 30% of necrosis and large collections, generally they do persist and can complicate. So then the question happens whether to drain it or not. So RCT of conservative versus catheter drainage in of these sterile collections has shown that 55% of patients in the conservative group needed actually a catheter drainage, and 55% those who got catheters early, they got secondary infected. So generally, if you actually do a kind of preemptive catheter drainage in sterile collections, generally there is a risk of secondary infection, and generally it is not practiced and trained only if they are symptomatic. So coming to back to our case, patient had fever, pain, abdomen, new onset, mild respiratory failure, white cell count is high. So now infection is suspected. So the major concerns are they are too sick, and most of them require a prolonged hospitalization, and they need to be maintained nutritionally, at least a target between 1500 to 2000 kilocalories. So enteral nutrition is preferred because it reduces the infectious complications. Either oral or NG feeding can be given as tolerated. There is no difference between polymeric formulations versus semi-elemental or elemental formulations. So coming to this, you maintain the nutrition, you manage the organ failure, and now you actually come to the main problem of infected pancreatic necrosis. How do you suspect or prove it, and how do you treat it? So diagnosis of infected pancreatic necrosis is generally clinical if there is gas in the collection, if there is bacteremia sepsis, if there is clinical deterioration or a new onset organ failure, or for any other chance from any others, if you take some kind of cultures from either the pancreatic fluid or the bloodstream blood cultures, if there is culture positivity, then we start suspecting infected pancreatic necrosis. But generally, a proactive practice of CT-guided FNAC is discouraged. So word about non-invasive biomarkers, procalcitonin and CRP. Procalcitonin of more than 1 nanogram per ml plus clinical evidence of IPN actually reduces the need for antibiotic use without altering the dose. So if you add this procalcitonin with your clinical judgment, probably the need for antibiotic practice may be reduced. Also, elevated procalcitonin and CRP beyond three days actually increase the suspicion of IPN. So IPM have actually infected pancreatic necrosis. The bacterial translocation from the gut into the pancreatic fluid and necrosis happens, leading to infection. Generally, it is with gram-negative bacilli and occasionally nucleococci, especially those who got prophylactic antibiotics or prolonged antibiotics because of any reason. There can be a surge of MDR organisms and rarely fungi. Generally, we treat with IV carbapenem or quinolones or metronidazole because they have good penetration to the pancreatic tissue and the duration is up to 14 days. So who fail with antibiotics? Generally, around 40%, 30 to 40% can respond, but generally, those who have organ failures, those who have central necrosis, a large total or subtotal pancreatic necrosis, they generally fail with antibiotics alone. If all three were present, 95% fail only with antibiotic strategy. And if none were present, at least 47 were successful just with antibiotics. So this brings us to the concept of drainage. So if there is a clinical suspicion or documentation of infected pancreatic necrosis, if there is an ongoing organ failure for several weeks or a new onset organ failure, uh, if there are sterile collections but still can be symptomatic by causing obstruction to gastric outlet obstruction or biliary or intestinal obstruction, there is persistent unwellness, or if there is a disconnected pancreatic duct, we need to drain even if they are sterile collections. Or if there are other kind of complications like intra-abdominal hypertension, bleeding, bowel ischemia, ascites, pleural effusion, you need to intervene in these patients over and above the conservative or medical management. And generally, it is delayed up to 4 weeks, especially for collections, to make them or let them wall out. So the early surgical strategy is now obsolete. So generally, non-surgical management is rational. This is based on these two studies. If you intervene these patients early in first or second weeks, actually the mortality goes up to 60%. But if you intervene them after 4 weeks, generally the mortality is up to 20 days. And if you see this, those who are intervened or with surgical necrosectomy, the mortality is 8% beyond 30 days. Almost three-fourths of these patients, they die if you actually open their stomachs in first 2 weeks. So generally the rationale is non-surgical management. So this brings us to the point of how do you treat these collections? It is by percutaneous drainage, by Seldinger technique. You can put the catheters from any route, left retroperitoneal, transbowel, right retroperitoneal, and if needed, you need to upsize to large bore catheters, but always be careful with the risk of secondary infections. This is based on this trial, the famous PANT trial. First, the protocol was you intervene to the collections through the retroperitoneum to the left side. After 72 hours, you wait. If patient is not improving, put more catheters. If patient is not improving, then go for a surgical necrosectomy. So this is the protocol. And if you see this, the complications are higher with upfront necrosectomy strategy, multi-organ failure, diabetes, requirement of enzyme supplements are higher in open surgery, incisional hernias are higher, and also new ICU admissions were higher with open surgical strategies. So this actually became the standard of practice of putting up pigtail catheters and upsizing, and if patient is not improving, then go for open surgical necrosectomy. So when to drain these collections? Early versus a postponed drainage. 104 patients in this point trial, again published in NEJM. They showed similar complications and mortality, and 39% did not need drainage at all. And there are lesser re-interventions and interventions in this postponed drainage group. So whether you do only drainage or whether you do a necrosectomy, conservative versus necrosectomy, a beautiful meta-analysis from the AIDS group, 8 studies published some 10 years back. Conservative plus minus a percutaneous drainage, 2/3 of these patients achieve success. 70% need only a catheter drainage, 26% still need necrosectomy, and mortality is 12%. What about EUS? I'm sure my subsequent speaker will touch upon this. But what about EUS guided drainage? Conventionally, EUS guided drainage is done when there is a full warm wall that is formed, whether it is a pseudocyst or whether it is a wall that necrosis. But in these kind of cases, when wall is not completely formed, still we can attempt EUS guided drainage, especially in endoscopically accessible locations at expert centers with a backup of surgical and IR teams, and when they have infected necrotic collections which are refractory to antibiotics. So beautiful meta-analysis comparing the early versus standard endoscopic drainage showed similar outcomes. 182 patients in the early group, median collection size of 14 centimeter. They have intervened somewhere at 23 days, and the clinical success overall adverse events and mortality is similar. So this group actually have went on and proactively said, if you have a chance of to drain the lesser site collections, in patient who is not responding to antibiotics in lesser site collections, irrespective of the wall, you can still consider doing an endoscopic or EUS guided drainage. Surgical approaches, if these patients doesn't get better, open necrosectomy is the gold standard, but minimally invasive and lesser invasive approaches with laparoscopy or retroperitoneoscopy, minimally invasive necrosectomies, minimal incision necrosectomies, transgastric laparoscopic approaches are actually practiced by the surgeons. So if you see the step-up approach, you need to treat these patients conservatively with IV antibiotics, which is the initial strategy, put a percutaneous drainage, and you can do a minimally invasive necrosectomy using a surgical technique or EUS guided or even percutaneous endoscopic necrosectomy algorithm. So also be vigilant about other complications like intra-abdominal hypertension, vascular pseudoaneurysm, which is chronic fistulae, infected ascites, and vascular thrombosis, which can happen during this time frame of 2 to 4 weeks. So generally, 2 to 4 weeks is a period of watchful wait. Maximize the ICU support, involve the multidisciplinary team. Conservative treatment is the norm, including IV antibiotics. Nutrition is the key. If organ failure or sepsis worsens, percutaneous drainage. So diagnose these patients properly. You maintain the nutrition with appropriate dietary strategies. delay all your interventions and keep a wakeful watch. You need to use the drugs that are antibiotics very, very cautiously. Train these patients only when it is absolutely necessary. And when patients are not improving, debride and do kind of necrosectomy, but still mortality can happen in these patients. Thank you so much for your patience.
Thank you, Dr. Rao. It was really very nice and very succinct. And we move on to the last part, that is the management of acute pancreatitis after 4 weeks. May I call upon Dr. Ravi Rai to deliver his part.
Very good afternoon. I thank Yogesh for this wonderful event, and really impressed by Dr. Goenka's talk. So I'm going to talk about acute pancreatitis management. Weeks. So this whole time-based approach about acute pancreatitis. So this is the review article published last year in Gastroenterology, and everyone should read it. So first 2 weeks and up to 4 weeks is already been discussed. During after 4 weeks, the important things that happen is the formation of fluid collections, and then you label it as acute necrotic collection or acute pancreatic collection. You have presence of pseudoaneurysm, vascular thrombosis, and certain other things which I'll just touch upon that are dominantly the exocrine pancreatic insufficiency, the diabetes to look at for these patients, and sometimes quite delayed the occurrence of chronic pancreatitis. So this slide is again very familiar. After 4 weeks, you label it as cirrhosis of the patient, interstitial pancreatitis, and walled-off pancreatic cirrhosis in patients with necropathy. Importantly, all fluid collections will not drained, majority resolved. Only 10 to 30% form cirrhosis, the setting of intestinal pancreatitis, and majority of these cirrhosis also resolve. So all cirrhosis need not be drained. What are the guidelines for intervention, which has already been touched upon by my previous speaker? It has to be asymptomatic, infected, or increasing signs, preferably after 4 weeks. Occurrence of compression, gastric, duodenal, or biliary obstruction, persistent pain, early satiety, vomiting, bleed, ascites, or massive urolithium. So these will merit an intervention. Therapeutic options: conservative endoscopic drainage, percutaneous drainage, open or the laparoscopic cystogastroscopy. So these are multiple options that are available when we deal with pancreatic cirrhosis. Endoscopic drainage is usually preferred. It can either be a transmural or a transpapular drainage. Considered the first line and significant advantage compared to the surgery or a percutaneous vein, which I'll touch on. Usually avoided if the distance is more than a centimeter. Again, when you choose an endoscopic drainage, it can either be a conventional endoscopic drainage or now it is being increasingly used in EUS guided drainage. The advantage of EUS guided drainage is higher technical success, avoids intervening blood vessels, lower complications, identifies debris, and at 5% to up to 10%, it changes management as it picks up cystic tumors which you have not yet identified. So beyond doubt, US is the way to go. This is shown in this studies where the technical success was high,
the days of hospitalization was less in, or the complication was less in patients who underwent an EVAS guided drainage compared to an endoscopic drainage. So again, as you can see, this is what you do. You have a large bulge here. And when you see a large bulge, you puncture with a 19 gauge needle. After puncture with a 19 gauge needle, you dilate the tract. And after dilatation of the tract, you deploy a stent. So this is what is the conventional technique that is followed. Here again, the second slide just tells you, the second video is directly when you puncture with a cystotome instead of the traditional needle and then dilators. This is what we practice in our center. Somehow this video is not playing. Okay. So this is in the direct using a 10 French cystotome. What we do is we go in with a cystotome, which is an inner 5 French catheter. Pass that, and over that we place the 10 French device. You do not need any dilators, and you avoid using the needles, so it saves on the cost, as it also saves on the time. So the duration will be somewhere around 12 to 15 minutes. You will be able to complete the procedure. So So once you have, so this is what I wanted to show. This is with the viscotome. You can go in, dilate the tract with the catheter itself, that is a 10 French device, no need of additional dilators, and then you deploy the stent and come. So this is the study that we published, again, 2021, which technical success was high. Clinical success, again, 98%. So it's a quick, effective, and a safe procedure. It may be less expensive since it obeys the use of FNA and dilator, is what I do. The transpapillary drainage indicated for the lesions which are small in size, usually in communication with the pancreatic duct, where you can do a transpapillary drainage, usually for lesions less than 5 centimeters. How does your endoscopic drainage compare with a percutaneous drain? This is again a study which tells you that if you compare US versus the percutaneous drainage, re-intervention rate is less, length of hospital stay is less when you're doing an endoscopic drainage compared to percutaneous drainage. How does it compare with surgery? There's again 2 studies which tell you that the length of hospital stay is less and the recurrence is less when US guided drainage is done compared to surgery. Coming to walled-off pancreatic necrosis, as I mentioned, it occurs in setting of necrotizing pancreatitis associated with a high risk of mortality, and that is the reason we need to be very cautious in these cases. Again, the indications we have already discussed, the same indications of drainage as was in cirrhosis. Here, one of the additional maybe presence of abdominal compartment syndrome, and these patients usually present with fever. So for the optimal management, you need gastroenterologists, critical care physicians, intervention radiologists, and GI surgeons. So this is very, very important to understand that you should have a team if you are trying to manage patients with pancreatic necrosis. Again, the options remain the same as it were there for pancreatic cirrhosis. So here, as you see, antimicrobial therapy is indicated for culture-proven infection in pancreatic necrosis, or when the infection is strongly suspected, which is by presence of gas neglection, bacteremia, sepsis, or clinical deterioration. Again, the antibiotics have been already told, carbapenems will hold the job in major cases. Routine use of antifungals is not indicated. Again, very, very important to understand. So broad principles of endoscopic drainage and necrosectomy, you see this debridement as being told is usually delayed to more than 4 weeks until next heart press to drain early. ECD and endoscopic drainage are both appropriate first line for hold-up-pancreatic necrosis. Endoscopic drainage through transmural drainage of form may be preferred. So mind you, these words are very, very important. May be preferred. So again, when you intend to do drainage, you have the options of placing plastic stents, self-expanding metal stent, human-opposing metal stents. And when you do a necrosectomy, again, you have the option of placing bi-flange stents. So which to choose, again, becomes very, very important. So there are multiple studies on this. To summarize this, if you see, the evidence is equal. Three meta-analysis tell you that metal is preferred, while four tell you that plastic does equally good job. So how to choose? Plastic stents, again, for small size collections, predominantly liquid content. PPDH, we're suspecting patient is not reporting procedure. Metal stent, large size collection, significant solid component, compliant for follow-up because patients don't turn up, you may have complications later, particularly in patients where metal does a quicker job, you're able to place the metal stents quickly. So what does the guideline tell you? Either plastic or lamps for initial drainage. AGA practice 2020 tells you lamps appear to be superior to plastic for endoscopic transmural drainage of necrotics. So technique, just to understand, is basically what we do is we debride, extract the necrotic debris, and irrigate. So these are three important steps which are important to understand that you're trying to remove the necrotic material. And as you can see, you go in, remove this with rocknet, dormia, snare, different devices you use to bring about this necrotic material outside. And then you can place the ENCD also and flush hydrogen peroxide to achieve clean movement. Additional therapy, as I mentioned, hydrogen peroxide, this has been it's proven in studies to be highly effective, usually considered safe if you are using in a right proportion. So 3% hydrogen peroxide is the one that is preferred. We have another devices. So if you see the endo-rotor device, water-jet necrosectomy device, or over-the-scope grafts or an excavator, these are the additional modalities that you have to bring about the debridement and the removal of the necrotic material. So if you see this, this is what the endo-rotor does. It removes the adhered necrotic material and then tucks it. So this is what is achieved with endo-rotor. Again, we still don't have this in our center, and but it looks a very promising device. The other device, as I mentioned, is a water-jet necrosectomy device. And then you have over-the-scope grasper. Again, the intention is to grab hold of the material, necrotic material, and to pull them out. So this is a systematic review and a meta-analysis. We have many trials. Earlier two were shown. Besides that, we have the Miser trial as well. And if this is a systematic review and a meta-analysis of all the RCTs available till date, and what this tells you that the endoscopic management performs better compared to surgical treatment due to its lower complication rate and higher patient's life quality. So when should the patient be referred to surgeons? Inadequate drainage to the endoscopic appropriate approaches, inadequate clinical response, ineffective, or sometimes in the setting of a disconnected pancreatic capsule. So these are reasons why surgery may be offered to these patients. So importantly, 3Ds become very, very important. You need to delay, you need to chain, and then you need to debride, beginning from either percutaneous or a endoscopic option, and then progressing to surgical ones if the condition doesn't. So others, just I will touch upon this. Vascular complications, again, very, very important. Please remember, incidence of visceral artery pseudoembolism is between around 6%, which are usually managed either radiologically or EUS guided. You may have mesenteric vein thrombosis, which is between of around 7%. Anticoagulation in this setting is again debatable. If you have multiple vessels involved, you will choose to anticoagulation. Pancreatic endocrine insufficiency, please remember that there's a systematic review and meta-analysis tells that an index attack of acute pancreatitis, the newly diagnosed diabetes occurred in 15% within 1 year and 30% after 5 years. So you have a 50% rate. So this should be checked in all the patients who had a single episode of acute pancreatitis after 1 year. Exocrine insufficiency, again, common, and is present, patients usually present with abdominal symptoms, abdominal bloating, dyspepsia, and weight loss. Again, prevalence is 62% of all acute pancreatitis patients during their index admission, and the risk of EPI is higher with alcohol etiology and in patients with severe acute pancreatitis, because screening for EPI should is important in selected patients, even with a single DAC, to avoid late complications of myelofibrosis. So to summarize, only symptomatic pancreatic fluid collections and drainage. US-guided drainage is the preferred modality. Use of a single or multiple plastic stent suffices with high efficacy in cirrhosis. Metal stents more appropriate for Vaughan, and endoscopic step-up approach is preferred. Percutaneous approach, preferably less than 4 weeks, or you have a large paracolate collection. Surgery, usually step up on the percutaneous or endoscopic approach. Pseudoaneurysm and mesenteric venous thrombosis should be suspected in patients. Screening for diabetes at 12 months to 5 years after acute attack, and screening for EPI will be more important in selected patients with even a single tap. Thank you.
Thank you, Dr. Rai. Question is open for question and answer. Yes, first question to Dr. Since we are physicians, we are more interested in managing the first part with the nutrition part. So your ideas about the nutrition, difference of parental, enteral nutrition, and what exactly is enteral nutrition?
So first, I think I should try with the oral diet. The fail and degree, you can start oral diet. Sometimes patient will fail vomiting. Those patients you can say or negative. Sometimes there is gastric edema and partial gastric ulcer. In this case, enzyme may be better. Enzyme will bypass the fibrous. You can aspirate the gastric fluid. That vomiting is something you can directly face the. Sometimes patient has hypotension and ileus abdominal distension. In those patients, may be difficult to give the injection also. In those patients, we can use the parenteral. The priority wise, first is the oral feed, then nasogastric, then nasogastric. Can't give nasogastric, then comes the.
Clearly, you thought that we have to give the rest to the pancreas. That is one. Main point is that we don't have to keep, we have to keep in mind the translocation of bacteria and no sepsis. All if it just don't start the enteral as a risk.
Dr. Vikas, there is an increased utilization of immunostatin by intensively for severe acute pancreatitis, mainly in ICU setting. What is your message on this?
In the setting, maybe in the post-RCP setting, they are found to be useful, but not in the setting of acute pancreatitis in the ICU. There is no class 1 evidence for that may prevent the mortality.
It would not be used.
Just to add about nutrition, actually, all the guidelines tell you that you have to start nutrition as early as possible. And it has to be oral, because not all of it some people. However, there is a study now. There is a study comparing the nutrition given as early as possible, that means within a day, and nutrition started 72 hours in patients with severe acute pancreatitis. Again, from the gastroenterology review that has come up, talked about that study. So they have shown that in severe acute pancreatitis, to delay even up to 72 hours, it is acceptable. So this is a very, very important, because earlier, if you see, majority of the patients with severe acute pancreatitis, they have pain, have so much of nausea, vomiting, that it's really difficult to treat them at day 1. So in those subgroup of patients, even if you delay up to 72 hours, it's acceptable.
So my question is that I have been following this particular disease for 25 years. Almost everywhere it has been seen that antibiotics do not have a role. In the setup that I treat the patient, most of the patients that come to us are alcohol pancreatitis. Almost all of them have a count of 18,000, 20,000. And I think almost all of them need antibiotic at some stage. So personally, almost all patients, we have to give antibiotics. And almost in all the conferences, we hear that antibiotics do not have a role. If you can, if possible, please elaborate.
I think in the mild pancreatitis, in moderate pancreatitis, there is no role of pancreatitis antibiotic until the patient has cholangitis. The high TLC count may be part of inflammatory response syndrome. And during the first 7 days, there is unlikely to be infection. Mostly it's an inflammation. The infections are usually developed by the end of second week and in third and fourth week. Here comes the role of antibiotic. If you are using antibiotic in during first week or second week for mild or moderate infection, patient may have infection later on due to fungal infection or due to a resistant bacteria. So there is no doubt for mild and moderate pancreatitis, please don't use antibiotic until unless you have clear evidence of infection in the form of cholangitis or blood culture positive infection.
Yeah, I think it's very, very important to understand this because see, the problem is we think that the patient having high count, high fever, which is expected in patient with systemic inflammatory response happens in the first week. So by that standards, all the patients coming to your clinic, your practice, will need antibiotics. But unfortunately, the problem is that if you give antibiotics to these patients, during the first week, without established infection, the chances of these patients having increased mortality is evident. There are multiple studies which tell you that if you use antibiotic, then the chances of having complications, mortality increases. So that is the reason one needs to hold back to give antibiotics. I do understand the concern that the patient is having fever and having a count of say 18,000, and it looks like that if we give antibiotic, the patient may probably be a shade better, but that's not the case. So you're increasing the risk of complications and mortality. What Vikas said is again very, very important. Until unless we have some definite evidence of infection, only that may be the scenario where we may choose to give antibiotics. Otherwise, we should refrain.
Madam, setting the patient is 2 weeks down. Patient clinically improves. We do pancreatitis. Improved clinically also counts are okay. Patient involved start having low-grade fever. CRP is starting rising. Patients not to take it orally. And PCT is borderline. It is only 3 to 7, 8. It's not very, very. So sometimes PCT is not really the real insight. So what can be done that? On one side, you want to start antibiotics, but what we have seen that 4-5 PCT is not indicator of infection, and there is a fluid connection. What to do in those areas, borderline cases? Borderline PCT is there. Yeah.
I think in this situation, we need to start antibiotics, especially to the beyond 2 weeks. And as I've shown in one of the studies, the study, cutoff that they have taken is a clinical situation plus prophylaxis of one. So if you follow that strategy, then the choice of antibiotics or addition of antibiotics makes sense. So I think one they have taken. The thing which we are mentioning is actually theoretical part of prophylactic antibiotics. In an ISG study that we all know, 66% of gastroenterologists also use prophylactic antibiotics in a countrywide study. Okay, so this is a fact. So the explanations, whatever Dr. Vikas or Dr. Ravindra is trying to give, is to reduce that practice, probably to bring it to certain number. But still, the reality is 66% they still give prophylactic.
Excuse me. Dr. Perry suggested that almost all the patients have acute pancreatitis. We have fever, we have raised WBC count, we have high CRP. So under the other circumstances, we think that this is an indication of a sepsis. So do you want us to send the blood culture just to prove that the patient is having sepsis before starting antibiotics? Or go for PCT or some other case? In the initial stage, I'm talking about. In the initial phase. So another thing, whenever the patient's reference is done to a gastroenterologist, I'm yet to have been practicing for my 50 years. I'm yet to see a gastroenterologist not writing antibiotics. Everyone does. So, ठीक है, let us start with macrobing or neuroplexus. I have not seen a single gastroenterologist who would categorically say that do not give antibiotics in this. Sorry, it is true.
In the initial phase, it is cytokine storm, the sterile inflammation. So there is no point in giving antibiotics, especially in mild to moderate. So with no doubt, mild to moderate, please don't give antibiotics. Patient having multiple organ failure, renal failure requiring dialysis, ventilation, they have too much of fluid lines. There we can start antibiotics, but mild and moderate pancreatitis. As of today, please don't start antibiotics. High TLC, high CRP, it's all are due to sterile inflammation. So the patient keep on having fever, then we can use the procalcitonin, we can set blood culture, they are positive, then we can start. So this is always going to be an ongoing debate, I think, for next 10 years also. So thank you, all speakers and chairperson. Please go.
We will start our next interesting session on imaging in acute pancreatitis. I would like to request our chairperson, Dr. Rupesh Mehta, Dr. Ashwin Gadvi, and Dr. Sorin Upadhyay. I would like to invite our speaker, Dr. Deepak Patel.
So good evening, friends. As you all have heard, that imaging is one of the important uh, evidence to suspect of true acute or chronic pancreatitis. And imaging has many aspects to reveal which are not clinically recognized, or even if they are recognized, how serious they are, and what will be the prognosis about the patient, or what will be the outcome, and when to do any intervention or anything. Imaging is one of the most important investigation in this type of patient. So I request Dr. Deepak Patel to start his talk.
Thank you, sir. Good evening. I especially thank Dr. Yogesh and entire team of NIG for this successful event. Now, what is acute pancreatitis? We all know, right? But actually, for acute pancreatitis, there are two different kinds of pancreatic involvement is there, right? First is interstitial edematous pancreatitis, which is IEP, and the second is necrotizing pancreatitis. So, according to this revised Atlanta classification, we always follow now to record these things, because previous to this revised Atlanta classification, there were so many nomenclature used by radiologists as well as GI physicians and surgeons. So the things were very confusing. According to this revised Atlanta classification, we should use, and I request you all to ask your radiologist regarding this kind of classification, so that it will form the uniformity between the radiologist as well as the treating consultant. So according to this, interstitial edematous pancreatitis and necrotizing pancreatitis. And according to the RSE, there are four types of collections. First is acute peripancreatic fluid collection. If the this pancreatitis duration is less than 4 weeks, and pseudocyst, if it is more than 4 weeks. In case of necrotizing pancreatitis, there will be acute necrotic collection, which is called ANC, if it is less than 4 weeks. And if it is more than 4 weeks, then it will be termed as walled off necrosis. So as you know, there are so many imaging modalities for diagnosing, right? X-ray, sonography, CT, MR, MRCP, CT, MRCP combo, EUS, ERCP. So every time, just to diagnose pancreatitis, we don't require cross-sectional imaging. Let me be clear. As my previous speakers also told, that each and every patient don't require CT scan or MRCP. X-ray is now no longer used for this, but again,
sonography, it is the primary modality of choice. But my focus will be on the cross-sectional imaging because ultimately the most of the complications and the overall prognostication would be done by CT scan or and or MRCP. So CT would be continuing to be the main imaging modality of choice. And what is the optimum time of imaging for any kind of pancreatitis? So we should not perform CT scan before 72 hours if it is uncomplicated, right? So if you find any complication like a systemic inflammatory response in severe, if you find some organ failure, then definitely we require imaging. Otherwise, CT scan, we should refrain to do CT scan in case of acute pancreatitis for at least 72 hours. So optimum time is 70, not less than 72 hours. Follow-up CT, if patient doesn't improve or worsen, or if you find some invasive treatment is planned, then we should go for follow-up CT. For this pancreatic imaging, we do plain CT scan without giving any contrast, IV contrast. Then we give IV contrast and take 2 phases minimum. One is pancreatic phase and another is portal venous phase. So pancreatic phase is kind of late arterial phase, what we take in the liver imaging. And the fundamental role of CT is extent of the necrosis, presence of local complications, and whether there is a super infection or not. There are previously so many grading systems were used for the severity of pancreatitis, but right now we are using is modified CT severity index. So I will go to the modified CT severity index because this modified CT severity index uses pancreatic inflammation, then pancreatic necrosis, and the extra pancreatic complications all together. So, and according to the this involvement of the pancreas, we give a scoring like if it is normal, then 0. If it is mild alteration of the or edematous pancreas, then it is 2. And if we find peripancreatic or pancreatic fluid collections, then it will be 4 grade. For necrosis, if it is absent, then 0. There is a cutoff of 30%. Like if the necrosis is less than or equal to 30%, then it would be 2. And if more than 30%, then the score would be 4. And the extra pancreatic like ascites, pleural effusion, vascular invasion, then GI complications. So everything, whether they are all or single present, then we will give it score 2. So total score would be 10. Suppose if patient is having severe necrotizing pancreatitis, then the maximum score would be 10 and the minimum score would be 2. So according to this, either if it is a 0 to 2 index, this modified CT severity index, then this has mild pancreatitis. If it is 4 to 6, then it is moderate. And if it is 8 to 10, then it is severe pancreatitis. Mild acute pancreatitis, according to this RAC, no organ failure, no local or systemic complications. Again, my previous speaker already narrated this thing. Moderate acute pancreatitis means transient organ failure, which resolves in almost 48 hours, and local or systemic complications. And severe pancreatitis, persistent organ failure more than 48 hours, whether single or multi-organ. So we are jumping to the imaging. I will show first the normal pancreatic enhancement. Because once we know the normal, then we will understand what is abnormal. So this is a plain scan. This is the arterial phase, and this is the venous phase. You can see this. This is a homogeneous pancreas, which is showing absolute homogeneous arterial phase enhancement. And if you take venous phase, then what happens? The arterial phase enhancing pancreas will show contrast washout on the venous phase. And at the same time, you will see the enhancement in the spleen. Initially, arterial phase, no enhancement or mild enhancement in the spleen, but avid enhancement of the pancreas. And on a venous phase, the spleen will show enhancement and the pancreas will show contrast washout. Coming to the first interstitial edematous pancreatitis, which is more common, and either there will be focal or diffuse enlargement, and the pancreas will show either homogeneous hypoenhancement or sometimes the pancreas would be diffusely swollen with edematous parenchyma. So, and there may be or may not be peripancreatic inflammation in form of subtle that head heaviness only. So this is a interstitial edematous pancreatitis. Here you can see diffusely edematous bulky hypoenhancing pancreas and mild peripancreatic inflammation. Here you can see there is a stone impacted at the ampulla. So it is a biliary pancreatitis that impacted calculus at the ampulla has created pancreatitis. This is an MR image of the interstitial edematous pancreatitis. Here you can see this is the entire pancreas with diffusely bulky appearance. Here the head is more enlarged, and because of that head enlargement, there is some effacement of the main pancreatic duct with resultant the dorsal pancreatic ductal mild prominence. Now, when we so this interstitial edematous pancreatitis in follow, there will be the acute peripancreatic fluid collection, where with the pancreas, and if you see the peripancreatic partly defined fluid. So this is acute peripancreatic fluid collection. Then the pseudocyst. Nowadays, according to the RAC classification, the pseudocyst is almost obsolete term because most of the this acute this peripancreatic fluid collection, they gradually resolves, and most of the time, even if it forms a pseudocyst, then also it will be gradually regress. So in revised attempt classification, they do not give much significance to the pseudocyst. Then coming to the necrotizing pancreatitis, it is a less common, three subtypes. If the necrosis involves pancreas only, if it is involving peripancreatic tissue, and if it is involving pancreatic as well as peripancreatic tissue. So combined type like pancreas as well as peripancreatic necrosis would be the most common cause. Non-enhancing pancreatic parenchyma and non-enhancing peripancreatic heterogeneous collections. So here you can see this entire pancreas is showing no contrast enhancement. This spleen is showing enhancement. Kidney are showing enhancement. This pancreas is not showing any kind of enhancement. So this is a pancreatic only necrosis. We don't see any kind of collection or peripancreatic type necrotic changes in the vicinity of the pancreas. The pancreas is absolutely normally enhancing, but you can see the partly defined and hazy collection within the peripancreatic space. So this is a necrotizing pancreatitis with peripancreatic phase only. And this is a combined pancreatic as well as peripancreatic. Like this is enhancing pancreas, focal enhancement, and the entire dorsal pancreas is showing no enhancement. Along with there are multiple partly defined collections which are showing heterogeneous contents. Acute necrotic collection. Here you can see the non-liquefied heterogeneous content within the retroperitoneal space, within the lesser sac, and entire left anteroperitoneal space, going to the right anteroperitoneal space, and then reaching up to the left iliac fossa. Walled-off necrosis. Here you can see the completely walled-off necrosis. When we term walled-off necrosis, when it is more than 4 weeks. So very clear that acute necrotic collection would be less than 4 weeks, and walled-off necrosis would be more than 4 weeks. So again, one more case of walled-off necrosis. Walled-off necrosis. This is an MR image. Now I will go through these complications very fast. Here you can see the air pockets within this necrotic collection. So this is the infected necrosis. You can see the perforation in the stomach. Then gastric outlet obstruction. This is intrapancreatic as well as intrahepatic one. This is pseudoaneurysm. Here you can see the extravasation of the contrast. Here, this is a pseudoaneurysm. This is a pancreatic or pleural fistula. You can see the collection is going right into the pleural space. So the take-home message would be CT scan. We should do at least 5 to 7 days later for the necrotizing pancreatitis to assess the exact complications of the necrotizing pancreatitis. And MRI may be superior to the CT in characterizing liquefied as well as non-liquefied necrosis. MRCP for cholelithiasis and CT angiography when there is suspected pseudoanemia. Thank you.
Question. Okay, sir. Thank you. Thank you.
Yes, thank you.
Thank you, sir, for sharing your expertise.
Deepak, nice presentation. Any advances in contrast? Problem with us as gastroenterologists, majority of these patients who are sick do have a concomitant renal involvement. So what do you do with the creatinine of 1.3? You're always worried it will jump up to 4. Any advances in future?
Yes, sir. Actually, we do have one isoosmolar contrast. Take EGFR as a cutoff value, right? So if the EGFR is more than 60, we can inject non-ionic contrast, what we inject Omnipac or like. But if it is less than 60, but we up to 40. So if it is 40 to 60, between 40 to 60 EGFR, even if the pancreas is that creatinine is high, but if it falls EGFR within this 40 to 60 limit, we can use VZ-PEG contrast. So it is isoosmolar contrast where we can definitely inject that. And again, if the pseudoaneurysm is suspected very strongly, then again we have to go it for anyway we have to inject like that. But at least VZ-PEG is a good contrast where we can use in renal.
And the procedure use of MAC and followed by again MAC after the procedure, after injection of the contrast. Does it help prevent the kidney injury?
Most of the nephrology is dead enough.
Thank you.
Yeah, thank you.
Now we will start our next session with the lung injury in acute pancreatitis. I would like to welcome our chairperson, Dr. Narendra Maheshwari, Dr. Vaisal Sheikh, Dr. Partho Patel, Dr. Rahul Jalan, Dr. Varun Shukla. I would like to invite our speaker, Dr. Somin.
Audible? Yeah. Good afternoon. Is there any intensivist here? Intensivist? No? Yeah. Okay. I need your help. So some question regarding ventilatory setting, I will direct it to you. So when there is a something lung injury in pancreatitis, this presentation is basically physician oriented. So what is the mechanism? How common it is? And at what state does lung involvement happen? Okay. So first get this answer. So mechanism of acute lung injury in pancreatitis is SIRS, and everything, if we understand the SIRS and if we understand the pathophysiology, that's why this debate of antibiotic or infected or inflammation happens, or why early nutrition is required. So pancreatic enzyme escapes because of some injury, autodigestion, tissue injury, cytokines, and plenty of pathophysiology happens at molecular level, and that leads to the systemic inflammatory response syndrome, and variety of organ damage occurs. And that leads to the capillary leak, surfactant dysfunction, microthrombi in pulmonary vasculature that lead to the VQ mismatch, and resulting in the non-cardiogenic pulmonary edema, hypoxemia, and bilateral infiltrates called the ALI or ARDS. And how common? If we see, prevalence is around 15 to 20% in severe acute pancreatitis. So it is one of the organ failure in the severity. In mild pancreatitis, ALI is rare. The mild hypoxemia is very common in first 3 to 4 days, and mortality increases from less than 10% to more than 30% if ARDS develops. Now, just like in real estate, everything is about location. In same thing, in the pancreatitis, everything is about timing. At what timing complication happens, at what location collection occurs, you have to intervene via which mean that we are going to decide. Same, ARDS may be primary in the initial phase, that is a non-infective or inflammatory surge response, and sometimes patient is doing well. After 2 weeks, 3 weeks, he or she develop fever and again develop lung injury, and that is a secondary ARDS in which antibiotic is required. So that is a second hit. But most of the time on the presentation or initial first 2 to 5 days, we are dealing with the primary or early phase ALI. Now, second question, how will we differentiate it is ALI or it's a pleural effusion related hypoxia or pneumonia? What is the role of imaging? And is there, can we go for CRP, PCT and differentiate between this or not? Now, first of all, ALI is always bilateral, while the pneumonia is usually focal, and within 1 week, there is a possibility of early ALI in severe acute pancreatitis is more rather than pneumonia unless and until you get your patient and intubated on the same day. And ALI and ARDS is diffuse and bilateral, and there is a disproportionate hypoxia. While pleural effusion, usually very small, left-sided, and sometimes we see with such a pleural effusion, patient may have requirement of oxygen, and you feel that pleural effusion may be responsible, but not. Pleural effusion is reactive, it is small, but there may be some component of underlying ALI which is developing, and patient may require 2 to 3 liters of oxygen. Now, use of PCT. Suppose patient develop a lung injury in the first week, and can you differentiate between it is an infective ALI or ARDS or versus inflammatory? So PCT is always a supportive role. It is not that PCT is high, because in severe acute pancreatitis, there is a shock, there is a renal failure, which may give a false positive risk. So in first week, usually if patient is non-intubated and you are, means there is a less chances that patient is having a infective ALI. So serial PCT is more important than the single measurement. PCT can rise in severe trauma, shock, and renal failure, even without infection. So I have seen references when patient having a severe pancreatitis, don't have a lung injury, but creatinine is high and PCT is high, fever is there, and patient have been started on meropenem. So this is in the first week, very, very unlikely. So it should not be used in isolation, always combined with the clinical finding, imaging, and cultures. So meta-analysis say it is a very good sensitivity and specificity, but again, not in isolation, combined clinically, and serial has a more value rather than a single measurement. Role of imaging, X-ray or CT, it should be bilateral, non-specific, but bilateral is essential to diagnose ALI or ARDS. Biomarker, can CRP or IL-6, which is not commercially available, or procalcitonin have a value in differentiating? It has some value, but nothing like that. If the high CRP, that patient has an ALI, and if it is a low CRP, it doesn't have ALI. It is always a clinical with biomarker. Berlin criteria. Now, whatever criteria you apply, our basic purpose is it is ALI or is not. So it should be within first week for the primary ALI. Exclude other cardiopulmonary cause by imaging, echo, and pro-BNP. Why? Because we used to give resuscitate the patient with the vigorous fluid in the initial phase. And some patient has a compromised kidney because of the SARS, and patient may develop pulmonary edema. At that time, patient saturation drops, and we may feel it's a ALI, but it may improve with the conservative fluid management. Now, first line approach, what should we do? Should we give antibiotic in ALI? What is the preferred ventilator strategy? Is NIV safe in this patient, and when to intubate and when to ventilate? So keep your SpO2 around 92 to 96. Use first nasal cannula oxygenation, and if saturation drops with simple nasal cannula, you can use HFNCA. I think this is the last post-COVID. I have seen in many ICU, they have used HFNO rather than directly putting on NIV. And I think it is a relatively very good measure to avoid a NIV or to avoid a ventilation in initial, or you can delay intubation in this patient. And some patient may avoid totally intubation. So if your ICU has a HFNO, do you just before NIV try to use HFNO and then go to intubate or NIV. Fluid management after initial resuscitation. So if there is a shock and hypovolemia, if correction happens, switch to conservative or neutral fluid strategy that we will discuss. Pancreatitis specific care means start early nutrition, avoid aggressive fluid management, because this will increase fluid overload and lung injury, and general ICU care such as a DVT prophylaxis and no steroid for this acute lung injury. Now, initial phase. Now, when you start a fluid management, what should be your goal? Why fluid management is important? Because you want to adequately resuscitate the patient, but you don't want to overload the patient. So our goal is to correct the hypovolemia and to prevent early organ hypoperfusion. So use a balanced fluid, use the RL if not contraindicated, and it should be a guided resuscitation. So there was a, I think before 10 years or something like that, there was a practice is some patient with the pancreatitis come, irrespective of mild, moderate or severe, we used to give 500,000 ml bolus and then 200 ml per hour, at least for 24, 48, 72 hours. But nowadays, it depends on the severity of pancreatitis and severity of water deficit or fluid deficit in which we have to resuscitate. And there is a breakthrough trial called Waterford trial in 2022. And that's why that is published in NEGM. It is a multi-center randomized controlled trial, but basically designed in the Italy, Mexico, and India, including 18 hospitals, and 249 patients was enrolled. Now look at the exclusion criteria. They have excluded the severe pancreatitis, shock, and the significant comorbidities like CHF and CKD. So forget about the CHF and CKD. We are not going to aggressively resuscitate this without any direction. But in severe pancreatitis, this trial does not fulfill the criteria. It means this severe pancreatitis has been excluded in this trial. So this does not apply to severe pancreatitis. So aggressive fluid resuscitation, what happens in the arm, aggressive arm, they give 20 ml per kilogram finger actate, is almost 1200 ml. Bolus, followed by 3 ml per kilogram in 60 kg patient. So it is around 200 ml per hour for 72 hours. Okay. And in moderate, they reduce it to the 10 milligram and 1.5 milligram. And adjust the based on the frequent clinical assessment. Now the last line is very important. You have to adjust the based on the frequent clinical reassessment. Reassess every 3 hourly for first 12 hours and then 6 hours. And their goal is mean arterial pressure more than 65. Urine output should be more than 0.5 ml per kg per hour. Hematocrit should be between the 35 to 44%. Normalization of B1. So primary endpoint is development of moderately severe or severe acute pancreatitis within 72 hours after randomization. So they feel if you aggressively treat this patient, there is no difference in the development of the severe pancreatitis from mild to moderate. But if you aggressively resuscitate this patient, there is a significant complication of fluid overload. So aggressive fluid resuscitation is not recommended in mild and moderate pancreatitis. This trial excludes the severe pancreatitis. There are few problems with this trial, but because of time constraint, we are not going to discuss it right now because I think there is one lecture I have just seen regarding the fluid management in pancreatitis. So these are the criticism of this trial. So antibiotics in acute lung injury, in the first week, it is not recommended, even in acute lung injury or even in severe acute pancreatitis. You can give, if your patient is intubated and you feel there is a chances of ventilatory associated pneumonia and you have to give some prophylactic antibiotic, but it is not an infective ALI. Non-invasive, HFNO, we have already been discussed. Low tidal volume and prone position ventilation. I think sir is better to describe regarding this, but this sometimes been used in our patient with the severe SIRS and severe ARDS in the first week, even in the second, third, or fourth week. Does ALI and ARDS increases your mortality? Yes. Which AP patient are at the highest risk? Any severe acute pancreatitis, all the clinical, biochemical, any severity having a higher risk. And what are the predictor of poor outcome? Severe acute pancreatitis by any means will have a poor outcome. Why I'm just, these are all the criteria for severe acute pancreatitis, but you are a master physician, you know what is severe. So I'm not going to discuss. Role of the steroid. Now this is in ARDS, we used to give most of the time steroid, but in the first week of pancreatitis or even later on, you try to use judiciously dexamethasone because there is a chances of infection. And believe me, the only complication which is so dreadful in pancreatitis post-SARS is infection. Another ulinastatin in acute pancreatitis, as Yogesh has been already discussed, it is not useful, don't use it. Anakinra IL-1 is also an experimental IL-1 blocker is. ECMO may require. So use HFNO in your ICU if available. PCT don't use as a single statin. Fluid not too aggressive in mild and moderate pancreatitis, but yes, in severe pancreatitis. So you use IVC, use MAP, and use urine output. These three criteria in your clinical setting involve good pulmonologist for the ventilatory care. Steroid, unless and until it is much necessary, don't use this for ARDS. First week is sterile and avoid antibiotic. Thank you.
Thank you, sir, for your valuable insights. Now we'll begin with our next topic on the ideal fluid management in acute pancreatitis. I would like to invite our chairperson, Dr. Anil Kulsheswar, Dr. Ketan Joshi, Dr. Saumin Shah, Dr. Gyanendra Singh, Dr. Surbhi Jani. I would like to invite our speaker, Dr. Nirmaljeet Singh Mali.
Evening, everyone. At the outset, my sincere thanks to my dear friend, Yogesh Nuvani and team for a wonderful event, giving the kind invitation to be part of it. And it's a privilege to be here as a speaker on a very important topic. We've been looking some time ago, Somin did due to its disqualification by the last thing that but this is the idea of fluid management, the setting of acute pancreatitis. We see all
sequence of events, as you see in this slide, whenever there's an insult to the pancreas, the initial response is pancreatic inflammation. Once that sets in, there's actually fluid extravasation from pancreas to the peripancreatic tissue, and what we call as a third spacing into the peritoneum and other way, and thereby the intravascular volume contraction takes place, which in turn leads to pancreatic hypoperfusion. And that hypoperfusion is the harbinger for pancreatic ischemia, leading on to necrosis. And once pancreatic necrosis sets in, we have the release of battery of pro-inflammatory cytokines and what we call as a DAMs, which are damage-associated molecular patterns. And they in turn lead on to a series of local and systemic complications, more likely systemic organ system failure, leading on to high morbidity and mortality. So where does intravenous hydration actually fits into this? The major role actually comes as a disease modifying. It is something which actually alters the course. Somewhere from here, when there's a pancreatic hypoperfusion and ischemia, before it actually goes on to necrosis, if we start that hydration early, we possibly are able to reverse a certain sequence of events and take this ischemia back to just pancreatic edema and inflammation. So that's the whole hypothesis, and that's been shown clearly in so many studies over a period of time, how this intravenous hydration, it helps in reducing the severity of pancreatitis. So what are the major concerns? What patients need intravenous hydration? The answer to that is very clear. It's all patients with mild, moderate, or severe pancreatitis, but more importantly, it has to be done early in the course of disease. What should be our choice of fluids? This is I'm going to discuss in detail in the subsequent slides. What should be our rate and volume of resuscitation? Aggressive versus non-aggressive, again, a very important question. What should be our goals and monitoring? And what should be our duration of resuscitation? A very simple slide, which we had gone through our in previous days. The classification of the resuscitation fluids or the IV fluids, crystalloids, colloids, and blood products. And crystalloids, again, we have either a balanced or the unbalanced. And depending upon tonicity, we have the isotonic, hypo, or the hypertonic. Most commonly used fluid for resuscitation is normal saline. But normal saline, though is isotonic, but this is an unbalanced fluid because it has an acidic pH and the composition of electrolytes is not very similar to plasma. It is a much higher fluoride content than a plasma. And the most balanced fluids, most extensively being used, is ringer. And when we look at the type of fluids used, and there are two major trials which have shaped the outcomes of resuscitation, how we want to do. One which came in 2012 in NEGM, which was comparison of colloids versus crystalloids. And this trial very clearly demonstrated if we use hydroxyethyl starch and later other colloids, you have much higher chance of renal toxicity and you have a increased requirement of a renal replacement therapy in critically ill patients. And thereby, crystalloid became the obvious choice. But among the crystalloids, ringer lactate versus normal saline, this is called the SMART study, which was again published in NEGM 6 years later. And here you see the composite outcome of death from any cause or new onset renal dysfunction or need for renal replacement therapy was much less in balanced crystalloids, which is ringer lactate, compared to normal saline. And once we look at all the studies which have come till date, this is the four major randomized control trials, which have compared RL versus normal saline, and then a large meta-analysis which has come this year itself, and this is the forest plot curve. And here you see there is a distinct advantage. This side is ringer lactate, this is normal saline. So the diamond clearly is on the side of ringer lactate, and this clearly shows in mild acute pancreatitis, you start resuscitation early, there is much lesser chance of progression from mild to moderate to severe pancreatitis, reduced need for ICU admissions, lesser local complications, shorter overall stay for people of pancreatitis. And what is the whole rationale behind this? Why ringer lactate is actually doing better in critically ill patients and people with acute pancreatitis actually come from the very composition. Normal saline has a very high chloride load. So if you give higher doses of normal saline, say in excess of 3 to 4 liters in 24 hours, there's a definite risk of a hyperchloremic metabolic acidosis causing new onset AKI. And there are two important components of ringer lactate, one being calcium and other being lactate, which are called the buffering agents. And they've actually been shown to be anti-inflammatory agents. One side, they negatively regulate the T toll-like receptor TLRs, reducing the interleukin 1 beta and IL-6 levels. And calcium actually binds the free fatty acids and thereby able to observe an anti. That is why I think ringer lactate, one, by reducing the AKI, and because of anti-inflammatory effect, reduces the chances of side. So now in 2025, there's hardly any dichotomy or dilemma as far as the choice of fluid is concerned. So for acute pancreatitis, mild, moderate, or severe, ringer lactate should be the preferred choice of fluid. Aggressive versus non-aggressive. Somin very beautifully alluded in his presentation. The aggressive is very high bolus, that means 20 ml per kg. For 100 kg, that is around 2 liters. And then infusion rate of around 3 ml per kg per hour. That means 250 ml of fluid versus a more moderate resuscitation. Where we just give a bolus if patient has hypovolemia. An infusion rate of around 1.5 ml per kg per hour. That's around 120 to 150. Again, we have 5 RCTs till date in acute pancreatitis. 2 of them actually showing with aggressive, higher mortality and higher need of mechanical ventilation. Remaining 3 either plus minus benefit, or maybe some of them actually showing an improvement. And it is only because of waterfall trial, which came in 2022 in NEJM, which actually laid most of the controversies to rest. And this clearly showed with aggressive, chances of reducing the severity are much lower, but there's no difference in the severity of pancreatitis, but the complications due to fluid overload are way, way higher in people who are aggressive resuscitation compared to moderate. And this was 20.5% versus 6.3. That means a relative risk of almost 2.8. And this trial actually had to be prematurely terminated because of a very high complication due to fluid overload. So now at this point of time, being in 2025, after the waterfall trial, where we stand, things are much clearer, at least as far as the resuscitation is concerned. You have to assess the volumic status of the patient. So if there is a hypovolemia, you need to give a moderate bolus, which has to be a 10 ml per kg. How you assess hypovolemia? It's clinically and with biochemical parameters. The clinical is your systolic or the mean arterial pressures and the urine output. And the biochemical parameters are serum creatinine along with hematocrit values. And then you start an infusion and keep monitoring these patients in a dynamic fashion every 3 to 6 hours. And the important endpoints are 12, 24, 48, and 72 hours. And aim is to make the people normovolemia. So if the normovolemia is achieved, you just continue with the maintenance infusion of 1.5 for at least 48 to 72 hours. Still hypovolemia, you can give repeat boluses at 6-hourly or 12-hourly intervals. If hypervolemia, which is basically patient is becoming dyspneic, or you have peripheral edema, or your echo and other things demonstrate there's a volume overload, you need to decrease or stop your fluids. And basically, you might need in early phase need for diuretics as well. So this is very clear, assessing the volume status clinically, as well as with the help of biochemical and even radiologic parameters. IVC assessment, again, is a very important criteria. And then along that, you optimize your fluid therapy. So where we've come over the years, in standard hydration in 1990s, to very aggressive hydration in early 2000. So 2020 onwards, we have gone back to moderate hydration, which possibly gives us the best results in people with any severity of acute pancreatitis. So ladies and gentlemen, I'll just coming to the last part, which is the conclusion. So fluid resuscitation is the key and mainstay in the management of acute pancreatitis and should be for all patients irrespective of their severity. But the best results we achieve if the resuscitation is started early in the course of treatment. Ringer lactate undoubtedly is a much superior solution compared to normal saline, and synthetic colloids, because of high renal toxicity, need to be avoided. Amount of fluid, it is a moderate resuscitation and not aggressive or over-aggressive resuscitation. In mild, you need slightly lesser amount of fluids, maybe 3 liters in first 24 hours and 4 to 6 in 48 hours, and little more aggressive in people with moderate to severe pancreatitis. The monitoring goals, two very important criteria clinically. One is the mean arterial pressures, which have to be between 65 to 85, and urinary output has to be more than 0.5 ml per kg per hour. Hematocrit and BUN are the other two important biochemical parameters. Hematocrit ideally should be between 35 to 44. BUN, you need to lower it as early as possible to below 25. And if you translate it to creatinine, that has to be less than 1.1. And this resuscitation is very important in first 24 to 48 hours till a period of 72 hours. And finally, I think the most brief words I would say, ringer lactate, moderate hydration, started very early in the course of acute pancreatitis, preferably in 24 hours, in all patients, not as a fixed level of hydration, but a goal-directed dynamic therapy with a very close vigilance and monitoring, 3 to 6 hours, and changing your goals every now and then to achieve normovolemia, and maintaining that normovolemia basically optimizes our results and gives us the best possible outcome in people of acute pancreatitis. Thank you, and thank you so very much. And to all the GI colleagues, this is an invitation to be there at Ludhiana with us for a Punjab Endolive, which is our own flagship event. It's an endoscopic workshop. We had first edition 2 years back, and the next we are coming next year on 7th and 8th. Thank you, and thank you so much.
Any question from audience? One question is allowed. Sorry.
Metabolite latent function test. So I think the first and foremost would be the clinical parameters. But then patients who are feeling that there is some signs of SIRS, they can be repeated as frequently, even 12 hours. You can do, say, morning and evening. Some of the centers have even gone for a 6-hourly monitoring of these parameters. But standard is you can do routinely in hours, you do once a week because we monitor with other parameters, but even can be done at a 12-hourly basis.
Excellent talk.
Ringer lactate versus plasma lactate.
The results are very similar. So both are balanced solutions. So the risk of complication we encounter with normal saline, both are almost negligible, both with RL and plasma. Any one of them can be different.
Excellent talk, Dr. Madam. My questions are two. First is, what is sacrosanct about fluid management in acute pain? Why do we talk so much about it? Won't same thing be applicable in a patient, say, with severe burn, or with severe gastro, or with cholera? Why are we after pancreatitis every time? So almost same thing will be followed in patient with burns, severe diarrhea, cholera, depending on clinical parameters like urine output and pulse. The simple examination of the tongue or the volume status, is that not enough? Don't be stressed so much. We have come up from aggressive to very aggressive and back to normal. That is first. Second is there a evidence to show that pancreatitis is a process in evolution, or it can be halted if the patient comes? So many times we have seen once the patient comes in casualty, irrespective of what we do, it keeps on deteriorating function, different multi-organ failure. He goes into multi-organ failure setup, and he deteriorates in front of him. Is it a one-time event at the time of admission and casualty, or it progresses over a period? Just a basic.
I think both the questions are really wonderful. So first, you're talking about acute pancreatitis. So the two studies which are shown in NAGM, both these studies had the resuscitation in critically ill patients. And those critically ill patients were people with severe trauma, burns, severe sepsis, and acute pancreatitis. So basically, they were all clubbed because all these people, they need aggressive hydration and they need a significant hydration. So I think this is not only for acute pancreatitis. The same with the SMART trial, which looked at the balanced versus crystalloid versus normal staging, that again included critically ill patients, and pancreatitis was a part of that arm. So in both those studies, they showed colloids do poorly. Among the crystalloids, balanced really. So that's one part. Second is about pancreas. Pancreas, I think we all are very clear, it's the process in evolution, especially people present early. And that is how early resuscitation has been shown to be done. If someone which comes, say, in 8 hours, it's very difficult to distinguish whether it will be mild or severe pancreatitis. Here, if we start resuscitation in the right way, ringer technique with a little bolus and then with hydration, we might be able to circumvent that pancreatic ischemia which is going to set, because this process is still evolving. But when someone comes late, if beyond 40 or 72 hours, then possibly a major part of injury or irreversibility is already happened. Then resuscitation might not be that beneficial or any other thing we want to be quite desirable.
Thank you, sir. Because of lack of time, next question will get presentation.
Thank you so very much.
Thank you. Thank you, sir.
Thank you, sir, for sharing your valuable knowledge. Now we will move to our next session on antibiotic strategy in acute pancreatitis. I would like to request our chairperson, Dr. Harshad Shah, Dr. Akhil Patni, Dr. Vipul Chavda, Dr. Rashid Vora, Dr. Vismit Joshipura. I would like to invite our speaker, Dr. Savan Bhutan.
Good evening, everyone. At the outset, I would like to thank my dear friend Yogesh for this excellent meeting and congratulate him for the same. While I'm speaking on antibiotic strategy in acute pancreatitis, most of these points have already been discussed again and again in this meeting, making it work very quickly. If you look at the global trends in antibiotic resistance, there's an emergence of multi-drug resistant bacteria, with India being one of the highest per capita consumer of antibiotics. If you look at E. coli being resistant to third generation cephalosporins, again, India is at the top. And most of these resistant bacteria are happening because of gene transmission, and that is the genetic basis for this mutation. And by 2050, in this article from Lancet, there is an estimated annual death of around 4 million people in Asia and around 4 million in Africa happening only because of multi-drug resistant bacteria. And the major risk factor for this is the irrational use of antibiotics. And if you look at the countries, there are a large number of countries where 50% or more of the antibiotics are beyond guidelines, suggesting an irrational antibiotic use. Now, in acute pancreatitis, there are a lot of infections, and therefore antibiotics form an important part of managing acute pancreatitis, and therefore a judicious strategy is important. If you look at overall infections in acute pancreatitis, around 20% of them develop infections, primary IPM around 9%. And several other extra pancreatic infections can also develop in these patients like pneumonia, UTI, cholangitis, ventilator-associated pneumonia. Therefore, the right antibiotic strategy is very important. When you consider antibiotic therapy, it can be prophylactic, which means that you are administering the antibiotic even before the infection. It could be therapeutic, in which case you're suspecting infection, you don't have the definite proof, and therefore you're starting an antibiotic when it is called empirical. And the third one is obviously when you have antibiotic sensitivity-based cultures where you have a positive organism and you can give the antibiotic. So I'll be talking today in my talk about the two main aspects, that is prophylactic antibiotics and empirical antibiotics in the management of acute pancreatitis. Now, this study was also referred in the last session. So this is a multi-center study which looks at antibiotic use in acute pancreatitis among gastroenterologists. And this study published in Indian Journal of Gastroenterology saw that around 67% of patients with acute pancreatitis received antibiotics, and prophylactic antibiotics were used by gastroenterologists in more than 50% of the patients. So the rate of antibiotic administration should be between 20 and 40%, considering the amount of infections that there is in acute pancreatitis, according to the International
antibiotics. So you can see that we are overusing antibiotics in almost 20 to 30% of our patients. Now, this study also looked at the pattern of antibiotic usage in mild, moderately severe, and severe acute pancreatitis. And most of the cases, whether it's mild, moderately severe acute pancreatitis, more than 30 to 40% of patients received antibiotics. Mild acute pancreatitis patients received mostly cephalosporins. And you can see that in moderately severe or in severe acute pancreatitis also there are several antibiotics like cephalosporins that are being used. But there's also use of aminoglycosides in severe acute pancreatitis and moderately severe acute pancreatitis. Aminoglycosides are not generally a good antibiotic to use in pancreatitis. Now, this pattern is there globally also, where more than 40 to 50% of patients with acute pancreatitis, either they are mild or moderately severe, do receive prophylactic antibiotics, and this is not a pattern that is seen in India. Now, why does this happen? As we discussed in the last session, the patient comes with acute pancreatitis, is a young male, is developing cysts, he has tachycardia and tachypnea, and by day 3, he develops fever with a response, and therefore we are pressured into starting antibiotics. Now, this non-compliance to antibiotics policies, like guidelines, is majorly occurring because of major things like fever, two major things like fever and a high TLC. And this is also seen in a survey, which is a multi-center international survey, where they looked at the cost for gastroenterologists or treating physicians of starting antibiotics early on. And they found that the major reason why they started was because of high TLC and fever. Now, the high TLC and fever, again, has been discussed, is mainly a part of what we call as a systemic inflammatory response syndrome, or it is because of the cytokine release, where the damage to the SNR cell actually produces something called as damage-associated molecular patterns, which stimulate the immune system to release cytokines, and these cytokines are actually necessary for patients having inflammatory markers like high TLC and symptoms like fever. And if you look at the components of the systemic inflammatory response syndrome, there's high TLC and fever, which is part of it. And this is basically because of the immune response to the damage that is occurring in the pancreas, and the necrosis is sterile, but still the patients develop fever and have a high TLC. But there's no role of antibiotics at this stage in patients, especially in the first week. Now, that's the pathogenesis, but what does the evidence say? So we have double-blind placebo-controlled trials which have looked at the role of prophylactic antibiotics versus placebo. And we are good quality trials, and some of them are large trials, based on which the guidelines have come up with no role for antibiotics, that is prophylactic antibiotics in the first week. So these trials did not find any significant difference in infected necrosis, need for surgery, or in-house mortality if you start early prophylactic antibiotics. Now, these trials were all clubbed into meta-analysis, and these are a few of the most recent meta-analyses that have been done on this subject. And many of these meta-analyses really did not show any improvement in mortality or the incidence of infected necrosis or extrapancreatic infections with early use of antibiotics or prophylactic antibiotics. Now, to summarize the double-blind trials in meta-analysis, there is no effect of antibiotics, prophylactic antibiotics in prevention of infection necrosis. They do show some variable results in prevention of extrapancreatic infections like cholangitis or ventilator-associated pneumonia. And the trials which have actually showed some benefit of antibiotics are actually poor quality trials, and they have very small sample size. And the pitfalls of these meta-analysis are, of course, the methodology is very heterogeneous, the selection criteria, the treatment duration, and the antibiotic selection are all heterogeneous. But then definitely there is no role of prophylactic antibiotics in the first week of acute pancreatitis. Now, somebody may say that why not use antibiotics? What is the harm? But can these irrational antibiotics actually cause harm? So there are several studies which have actually seen the increased rates of multi-drug resistant infections as you move further on into the course of pancreatitis in patients who received very early high-end antibiotics like carbapenems or imipenem. Now, there are studies from India also which have shown that the early use of broad-spectrum antibiotics actually increases the risk of fungal infection in patients who develop infected pancreatic necrosis. And therefore, the fungal infection rates are higher in patients who received early prophylactic antibiotics. Therefore, yes, irrational antibiotic use can cause harm and should be avoided as much as possible.
Now, then what is the right time to start antibiotics? So if you look at the immunopathogenesis of pancreatitis, the first 2 weeks, there is actually a rise in cytokine storm, that is a pro-inflammatory phase. But beyond the second week, it's basically a phase of compensatory anti-inflammatory response called as CARS, where there is increase in anti-inflammatory cytokines like interleukin-10. So the pro-inflammatory response gradually becomes anti-inflammatory beyond 1 to 2 weeks. And that is the time when the intestinal bacteria translocate and patients develop infection. So if you look at this, the right time to probably start antibiotics in a patient who has continuing fever and a raised TLC is beyond the first 1 and 2 weeks. Now, is there a role of proving this infection by doing an FNA from the necrosis or by EOS or CT guidance? So there are considerable studies in the past which have looked into this, and they've shown that there are a large number of false negatives if you do an FNA for culture of bacteria, and there are also false positive results. And the very act of getting a sample from the necrosis may introduce infection. Therefore, today we do not use FNA to the diagnosis of infected pancreatic necrosis. Now, if we do not use a culture method to diagnose infected pancreatic necrosis, then how do we give empirical antibiotics? It's based on clinical assessment. So suppose you have a patient who has initial improvement, but followed by clinical deterioration like fever, raised TLC. After 7 to 10 days of onset of pancreatitis, those patients you can start antibiotics. If there's persistence of this fever or raised TLC since admission, even beyond 1 week, then those patients can be started on antibiotics. Or if there's definitive evidence of infection like extraluminal gas bubbles in your imaging, then those patients can be started off empirical antibiotics. Now, is there a role of biomarkers? The role of procalcitonin, it's been discussed in the previous session. So there's a large study which is called as the PROCAP study, which is a single center, double-blinded, randomized controlled study, which looked at whether procalcitonin algorithm can reduce the use of antibiotics used during acute pancreatitis. So they divided patients into two groups, that is the standard care group and the procalcitonin group. And antibiotics were stopped and not started if procalcitonin value was less than 1, and started or continued if the procalcitonin value was greater than 1. And they found that using the procalcitonin-based algorithm or a strategy actually reduced the use of prophylactic antibiotics. It did not have any difference on the all-cause mortality, but the days of antibiotics used and the amount of antibiotics used were definitely reduced if procalcitonin was used as a strategy. But the guidelines do state that this is the only study that has actually looked at such a strategy, and this may not be the only thing that needs to be followed. You have to take into consideration the other clinical parameters, and only procalcitonin may not help you make a decision as to when to start antibiotics. Now, what is the ideal empirical antibiotic for acute pancreatitis? So there should be good in vivo bioavailability, and there should be adequate concentration of antibiotic in the necrotic tissue. And many studies have looked at it, and the antibiotics that have been found useful are basically carbapenems, metronidazole, and fluoroquinolones. The adequate gram-negative and gram-positive coverage should be given when you start empirical antibiotics. So to conclude, key takeaways from my presentation are antibiotic prophylaxis cover should not be given to patients in acute pancreatitis as a blanket cover. Suppose you have only mild interstitial edematous pancreatitis, these patients do not require prophylactic antibiotics. And infection-specific therapeutic antibiotics, if you find documented extrapancreatic infections like cholangitis or UTI or pneumonia, then you can use a mild interstitial edematous pancreatitis. But suppose there is acute necrotizing pancreatitis, definitely no prophylactic antibiotics in the first week. You can start empirical antibiotics beyond the first week if the patient is either clinically deteriorating or the systemic inflammatory response is persisting with fever and raised TLC. And definitely, as soon as possible, if culture sensitivity is available, then you should change your antibiotic strategy based on the culture sensitivity. Thank you.
Questions from the all? I think this topic was already discussed just few minutes back. If there are no questions, we can move to it.
Thank you, sir, for sharing your experience with us. Now we will move to our next session on endocrine and exocrine insufficiency post-acute necrotizing pancreatitis. I would like to welcome our chairperson, Dr. Anand Patel, Dr. Manoj Kataria, Dr. Hardik Kotecha, Dr. Gautam Tambulia, Dr. Viral Vyas. I would like to invite our speaker, Dr. Deepak Gunjan.
We welcome you, sir, and we have a speaker, Dr. Deepak Gunjan, and he will speak on endocrine and exocrine insufficiency following the acute necrotizing pancreatitis. Stage 4.
Thank you. Talk about endocrine and exocrine insufficiency in post-acute necrotizing pancreatitis. I think my job only is that I will convince you that acute pancreatitis does not end just treating the collections. It is way beyond that. I think if I will convince you, my job is done. So these are my under the headings I will talk about it. And I will not discuss about the treatment because most of them are physicians. They know, you know more about diabetes, how to treat it rather than me. So already discussed local and systemic complications. And mild is 80% and moderately severe and severe are 20%. And most of the complications and morbidities have been in moderately severe and severe acute pancreatitis. But you will see later on that mild is not mild. Later on, it also causes a problem. If you will look at the acute pancreatitis, these are the algorithms, how it behaves less than 4 weeks and more than 4 weeks. But mostly we talk of necrotizing pancreatitis, how it causes collections, how to drain it, how to treat it, either endoscopically or surgically. This photograph is shown by Dr. Mali. The question is, what is necrosis and why it is happening in case of acute pancreatitis? So necrosis is simply death of a cell, and particularly in acute pancreatitis is glandular necrosis. And why it is happening? Because of hyperperfusion of the pancreatic parenchyma that leads to the necrosis. And you see by imaging that there is a non-enhancement of pancreas and later on developing walled-off necrosis. What are the consequences of necrosis? We saw that there is organ failures, there is a prolonged ICU stay and hospital stay, there is infections, and also there is a mortality. But the story does not end here. So what is the long-term consequences of acute pancreatitis? This is recently published Hungarian pancreatic study, large studies, national database that's showing you can see that the mortality in 12 months, 5.5%, and within 3 months, it is 3%. So even after discharging, the patient has mortality. And further follow-up, you can see beyond 3 to 4 years, till 8 years, the mortality in AP cohort, those who have acute pancreatitis, they have higher mortality as compared to the person's general population. Meaning thereby that acute pancreatitis, even after discharge, they have higher mortality. This is another study, Dutch pancreatitis study group that followed for, see the median follow-up, 13 years. What they saw, almost 1/3 of a patient has endocrine and exocrine insufficiency. And those patients having more than 50% glandular necrosis, they have a higher chance of development of endocrine and exocrine. If you will see that patients having higher the necrosis, they have a higher chance of developing endocrine and exocrine insufficiency. So let's talk about the endocrine insufficiency. I will talk about the 3 terms. One is the stress hyperglycemia, usually can happen in any stressful conditions. So the patient does not have a pre-existing diabetes, but when you measure the blood sugar, they have a higher. The second one is new onset diabetes after pancreatitis. This is, you can classify it
or define it if the patient does not have a known on investigations or by the treatment that it's not known case of, they develop the diabetes after pancreatitis. And then PPDM, post-pancreatitis mellitus, that also includes unrecognized diabetes. During the course of the disease, the patient has previously diagnosed, but it was during the course of acute onset pancreatitis, you diagnosed diabetes mellitus, and it is 1/3 of a total diabetes. The bracket term is PPDM, post-pancreatitis diabetes mellitus. If you will see the incidence, it is 1/5 of the patient has diabetes after pancreatitis, and it is more common in alcoholic as compared to the biliary pancreatitis. What's surprising was that if you will see the first line, even in mild acute pancreatitis, patient has diabetes. Almost 1/10 of a patient has diabetes. Why it is so? So it's not enough to us even the mild pancreatitis. Discuss those having necrosis, higher chance, those having alcohol have a higher chance of, and also within 5 years of acute pancreatitis, almost 1/5 of the patients will require insulin. What are the risk factors? Already discussed: severe acute pancreatitis, those having alcoholic etiology, those who are having necrosis. In some studies, if there is a recurrent acute pancreatitis, they will develop diabetes more so. And also if the patient has CKD and obesity, they are higher chances of developing diabetes mellitus. And also, if a patient has pancreatic necrosis and along with organ failure, they will have higher chances of developing diabetes mellitus as compared to those who does not have a necrosis and no organ failure. Why it is so? There are various factors. It's not that only there is a volume loss of a pancreatic parenchyma. The various factors taken into the account. Exact pathophysiology is not very well known. But initial phase of an acute pancreatitis, there is an increased insulin resistance because of compensatory hyperinsulinemia. This is one of the pathophysiologic mechanism of diabetes mellitus. This is the largest studies from New Zealand that look at it, the interval, what is the rate of development of a diabetes mellitus, 3% at 6 months, 7% at 12 months, and 11% at 2 years duration. And also, if a patient has diabetes after acute pancreatitis, this is the Dutch cohort that shows that the patient has higher mortality as compared to those who are having type 2 diabetes mellitus. And also, there is a higher chance of hypoglycemia in these group of patients. If we look at the mortality, the cardiac mortality is not different. Again, the New Zealand population-based cohort study, the higher chance of mortality is because of GI causes or infections as compared to those who are having type 2 diabetes mellitus. So what we have seen in endocrine insufficiency or diabetes after acute necrotizing pancreatitis, there are various terms we should be aware of. 1/4 will have diabetes on follow-up, and there is a significant burden of a disease, and there is increased risk of hypoglycemia and mortality in these group of patients as compared to type 2 diabetes mellitus and also as compared to the general population. Now coming to the exocrine dysfunction or abnormality, in contrast to the diabetes mellitus, it's not well characterized in acute pancreatitis. Particularly, it is well characterized in chronic pancreatitis, but not in acute pancreatitis. Good. Two terms. One is exocrine pancreatic insufficiency when there is a clinical manifestations because there is a deficient pancreatic secretions that lead to the facilitating the digestion is not happening, either steatorrhea, weight loss, or malnutrition. And this functions, it is principally when there is a physiologically low level of secretions, but it does not manifest as a clinical manifestation. So we have acute pancreatitis, they develop exocrine pancreatic dysfunction, and some of the patients will develop exocrine pancreatic insufficiency. This is the meta-analysis that shows that those who are having alcoholic etiology, they have a higher chance. Also, those who are having severe pancreatitis, they have a higher chance of developing the exocrine pancreatic dysfunctions. And the pool prevalence of exocrine pancreatic insufficiency is 60%. However, with time, it decreased to 35%. I will come to later this on. And if you will see, there is a higher the chance of necrosis, there is a higher chance of having pancreatic exocrine insufficiency. Is it reversible? So see this. In initial phase, the 60% patient has pancreatic exocrine insufficiency. But after 1 to 3 years, you can see there is 30 to 40% decrease in exocrine. So to some extent, it is reversible. But few studies suggest that this is true for diabetes mellitus also, but the evidence is not great. So should be surveillance or a screen. So we saw that there is a large burden of both exocrine and endocrine insufficiency. But what about the cost and practicality? So we should identify the high risk population, not well characterized, but those who are alcoholic, having smokers, male, more than 50% blended of necrosis, having recurrent acute pancreatitis or comorbidity. These are the group of population we can. So if the diagnosis of acute pancreatitis identify high risk population, or these could have a biomarker that's not available right, and then you can annually screen for either diabetes and for endocrine insufficiency. Only issue is that HbA1c is not costly, but fecal elastase is costly. So we don't know whether we should screen annually or not, because later on also the rate of development of a pancreatic exocrine insufficiency decreases by 30 to 40%. What the guidelines say, this is the recent guidelines, the multi-society guidelines, and Indian Pancreas Club was part of it, that recommend that this is the first time any guidelines has accommodated this point, that patients who recover from an attack of acute pancreatitis should have followed up periodically after discharge to assess salt and mouth. The second thing, we should screen for diabetes first at 3 to 6 months, thereafter in Malaria. But for exocrine insufficiency, patients with exocrine insufficiency may occur due to extensive pancreatic necrosis in patients with acute pancreatitis, but how and when it's not well defined. You can see it's conditional recommendation and moderate qualitative. But when to treat it, patients with clinical symptoms of aciduria or severe and nutrition with low fecal elastase, or if a patient has undernutrition, they should be treated with pancreatic exocrine pancreatic enzyme replacement therapy, not every patient. So how should manage the acute pancreatitis? What we are looking at, gastro person is looking at what the surgeons are looking at different perspective. The endoscopists are looking at different perspective, but we require a team that can manage acute pancreatitis. And this is what the commentary we wrote about in that is acute pancreatitis in the chronic disease. We still don't know, but care of these patients a long drawn better, much like that of chronic disease. We can't call it a chronic disease right now, but it requires more collaboration from various stakeholders. So summarizing my talk, that acute pancreatitis has long-term complications, not that diabetes and exocrine pancreatic insufficiency. The other metabolic complications are also known to. But endocrine insufficiency, be careful of the various terms used. They have increased mortality and also there is a more hypoglycemia. Exocrine insufficiency may be reversed in some cases and need treatment in certain circumstances. Not every patient requires birth therapy and require close collaboration with physicians, endocrinologists, surgeons for diagnosis, treatment, and support. Thank you.
We can accept question.
So, best part of all this is to prevent the necrosis, because we don't have any you are able to prevent the necrosis, the major part is done. But having said that, necrosis is not the only part that take part in the development of there is low-grade inflammation that's ongoing. There are various other hormones that have been seen that take part in development. But later on, as we see in the study also, there is slight decrease in but till now we don't have any drug to do.
Nice job, Deepak. My question is, totally asymptomatic patient, no symptoms.
the fecal elastase, but why should we get it? And if we say if it is 150, we give him curd and how long? So no any normal albumin, no weight, no malnutrition. Okay. Simple answer is no, sir. There is no requirement of bird therapy. Until unless patient has undernutrition, a patient has catabolic stage, losing weight, we should start. Or if the patient has acidophobia or anything. But if it is asymptomatic patients, maintaining weight, as I said, normal albumin does not require it.
So, Putunja, my question is just like the patient is losing weight, and normally say the patient is not taking anything because the catabolic scale. So, what is the protocol we recommend in these patients, with necroplastic pancreatitis from OPD base regarding fecal elastase and HbA1c and sugar checking? Any protocol we can recommend to house?
So, till now, there is no protocol, definite protocol from the study point of view. What the New study has shown that, and also now the IP guidelines has come back. After the resolution of acute pancreatitis, within 3 to 6 months, we should do the HbA1c.
3 to 6.
Yeah. And after that, and so only questions come for the exocrine part.
Fecal elastase.
The questions come because if it is cheaper, you can do it. So it is very costly fixed. Okay. So in initial phase, we don't do because anyway, patient has acute severe acute pancreatitis, they lose weight, you know that in natural history. But after the resolution of the pancreatitis, the patient is not in then you can.
So we should be aware about that.
Yeah. Okay. Second question, should we repeat? That's difficult to answer. But again, the process.
Okay. Thank you very much, sir. We would conclude this session. Thank you, sir.
Thank you.
Thank you, sir, for your valuable insight. Next, we will move to our session on disease-modifying therapies in acute pancreatitis. I would like to invite our chairperson, Dr. Mukund Patel, Dr. Gaurav Agrawal, Dr. Apurva Shah, Dr. Krunal Patel, Dr. Nilesh Daw. We have our speaker, Dr. Jahangir Bashir.
Thank you, Chairperson. And good evening. I thank friend Dr. Yogesh Harwani for the kind invitation. And the topic allotted to me is disease-modifying therapies in acute pancreatitis. Or I would ask a question: can we modify the disease course with any drug or agent in acute pancreatitis? So before going into the actual topic, we need to realize certain facts about the unpredictable nature of the acute pancreatitis. First of all, at the onset of acute pancreatitis, no one knows whether he is going to develop acute, mild pancreatitis or severe pancreatitis. If he develops severe pancreatitis, whether it is restricted to only the necrosis and fluid collection or there is organ failure also, that also we don't know. If organ failure develops, whether that is a transient or persistent, that also we don't know clearly. And the necrosis, whether it is sterile or infected, it is again unpredictable. And ultimately, we need to look at the outcome, whether the final outcome is survival of the patient or mortality, that also not very clear. So having said that, the unpredictable nature of the acute pancreatitis, it seems logical or reasonable if we get a ideal disease modifying agent that helps us to understand and to predict and to treat and to modify the clinical course would be great. But what are the ideal goals of a disease modifying agent that we need to expect? It should reduce the pancreatic injury, it should remit the systemic inflammatory response, and it prevent the organ failure and infection in the pancreatic necrosis. It should improve the survival. It should be safe, can be applicable early in the course, and also it should be widely acceptable. So do we have an agent really fulfilling all these criteria? Let's see. So before actually discussing the topic, it is important to understand certain key steps in the pathophysiology of acute pancreatitis which already has been discussed, but I would highlight the key steps like whenever there is an acute insult, the first pathophysiological event happens in the HNR cell injury where there is release of pancreatic enzymes causing the damage, causing local inflammation, release of inflammatory cytokines, leading to second important step that is systemic inflammation and organ failure, and ultimately infected pancreatic necrosis. So these are the key steps that decide the clinical course. And ultimately, our aim in this uh, topic of discussion is to reduce the mortality, which is primarily decided by the organ failure. So organ failure, again, early in the course is mainly because of the systemic inflammatory response. That is called a primary organ failure, which is up to 1 week. During the late phase, it is primarily decided by the infected pancreatic necrosis, that is called the secondary organ failure. So we need to have an agent which can target these two phases and should control the organ failure so that there will be a less mortality. So ideally, they should target certain key steps as we discussed so that they can alter the clinical course or alter the outcome of the acute pancreatitis. So it's not easy because of certain challenges being an ideal disease modifying agent because most of the important deciding events like acute SNR cell injury or pancreatic parenchymal injury occur rapidly at the onset of pancreatitis within few minutes to hours, less than 6 hours after the onset of AD. So this is the most important fact that we need to understand. The second thing is by the time patient already reaches the hospital, these events have already occurred. So we are losing a therapeutic window here. And there is always a knowledge gap how a local injury progresses to systemic inflammation. And to understand all these things, the evidence that we have is primarily derived from the animal experiment. We don't have a robust data from the human studies. And also there are multiple targets with narrow therapeutic window. So all these facts make challenging aspect of the disease modification. So primarily, the current management strategy of acute pancreatitis is mainly supportive by IV pain management, early management of the complication. But it doesn't mean that we don't have any disease modifying therapy. Many are in the pipeline, and we can see what is the current status. So as we discussed, the targets for the disease modifying agents are primarily at three areas. The early event that is in the SNR cell injury. Second one is to target the systemic inflammation. And the third area of target is infected pancreatic necrosis. Coming to the SNR cell injury, probably this is one of the most important early events and also one of the most important to alter the clinical course or to modify the clinical course because already whatever the pathophysiological event or outcome is decided at this stage. So it is primarily calcium influx leading to activation of enzymes that is causing releasing of the DAMs, that is damage associated molecular atoms, which subsequently responsible for the local inflammation, the systemic inflammation. So if we get a disease modifying agent at this stage, that would be ideal. But what is the reality? There are two groups of disease modifying agents at this stage. One is protease inhibitor, of which statin is most robust. And the second one is anti-secretory agents like somatostatin and often. So unfortunately, the benefit is uncertain at this clinical stage because the studies have not shown a clear advantage of using these agents. But of these, statin, I would like to discuss here because a lot of discussion, and I think in the previous session also there was a discussion about the statin. So many studies have shown that there is a definite benefit of the statin. This is a recent meta-analysis from BMC gastroenterology. Almost 12 studies have shown that there is a significant reduction in the mortality rate, but there is no change in the hospital duration and surgical score. So, does it mean that it is the ideal drug and it should take into the clinical practice? If you look at carefully about the data where it has come, almost all studies are published from China, one or two studies from India, and also there are various issues from the study design, and also the authors in various studies are the overlapping authors. So we cannot take the results as granted. We need to have a multi-center RCT, universally studied studies, so that we can conclusively say that this is helpful. Till that time, even though the data is showing, I would say it is not a very good option to modify the disease course, but it can be tried in the clinical setting like post-ERCP pancreatitis, where early events are not yet happened. So we can try, but it, we need to have a data on this one. So coming to the second important key step, that is tackling the systemic inflammation and organ failure, that is primarily mediated by the pro-inflammatory cytokines. So two important clinical events here are, as discussed, there will be endothelial injury leading to increased vascular permeability and further blood loss. And also there is a vasoconstriction and microthrombosis ultimately leading to the ischemia. So if you look at the pathophysiology of these two events, and if you see the fluid resuscitation strategy, we had an excellent talk by Malisa before this talk, and it has clearly shown that the goal-oriented, moderate fluid resuscitation is definitely helpful. So by seeing the principle or the underlying nature of the disease course, it was previously assumed that there will be a definite advantage of or a disease-modifying nature by giving aggressive fluid resuscitation, but this was not the reality, and there is a paradigm shift, and the fluid therapy should be goal-directed. But at this point of time, I would like to say that fluid resuscitation is one of the disease-modifying strategy, though it is a supportive, but it has the potential of disease-modifying strategy if we tackle these patients early in the course, so that we can prevent the proportion of patients from going from mild to severe by preventing the pancreatic cancer. And two important clinical events, as we discussed, pro-inflammatory cytokine and the coagulation system. These becomes an important therapeutic target for the disease-modifying therapy by tackling the inflammation. So various modifying therapies have been tried for tackling the inflammatory cytokines like TNF-alpha antagonist like infliximab and the steroid that agents targeting interleukin-6 like tocilizumab. But the quality of studies are good and only few small studies with some case reports. But the good part is large studies like RCTs are currently are going, like one is in UK on TNF antagonist, and on steroids, two important studies are going on in USA and also in AIMS. And when it comes to the coagulation, low molecular weight heparin, it seems to be logical and seems to be helpful. But earlier meta-analysis has shown some benefit, but again, most of these studies are from China. And now recently two ongoing trials are going on, and we need to wait to see the result. And cytosol is another option where we can remove the inflammatory cytokines by extracorporeal removal. And if you look at the overall likelihood of benefit, all these studies at this point of time are not shown a clear benefit, but maybe we can expect some results in near future by completing these RCTs. But one important molecule that is looking promising, which targets the calcium pathway. Here, the calcium pathway is important both for the acute external cell injury and also the systemic inflammation, because calcium receptors are present at both external cells and also the neutrophils and lymphocytes. So if we tackle the calcium pathway by oral calcium channel blocker, there can be a benefit that has been studied in research studies, and Oxora is the molecule. This is the animal experiment shown clearly that has advantage. This is a clinical study, but only 21 patients are studied, and two RCTs are going on. We can expect the results in 2070. The third important aspect is infected pancreatic necrosis, which is primarily because of the bacterial complication by disrupting the intestinal barrier. And this can be tackled by one of the supporting treatment strategy, that is early nutrition, so which helps to maintain the intestinal barrier so that we can prevent the infection in a proportion of patients. So there is a paradigm shift where pancreatic rescue early nutrition. So among these three steps, disease modifying therapies that were studied are antibiotics and probiotics, already discussed that from oral, and also supplements are also have no role. So at this point of time, I would like to conclude by saying these four important statements. While the current management is excellent for providing a supportive care, there is a significant therapeutic gap that still exists. A deeper understanding of the pathophysiology of acute pancreatitis has opened the doors for targeted disease-modifying therapy. The promising agents are investigated in clinical trials, but we need to have more data to show the efficacy and safety. So the future of AP management is moving towards a personalized and targeted intervention, not only treating but also the modifying the disease. Thank you.
Thank you, Dr. Basa, for excellent talk on disease modifying therapy. I think because of lack of time, not inviting this.
Thank you.
Jagir, excellent talk. It's a very difficult topic to talk about, but I think wonderful justice you did to the topic. Some data has been emerging on the COX-2 inhibitors as well. So last year I was going through because analyze the whole topic. Multi-center Chinese trial. So I think they looked at 4 days of pharmacofox followed by oral fox, where actually they showed that given a mild acute pancreatitis within 24 hours, the risk of SIRF significantly drops. Any more data coming on COX-2?
So till now, whatever the study that mentioned is showing promising results, but more studies are in pipeline, and we need to see the data. I'm also not very sure about the outcomes of the results. And the various factors in the inflammatory pathways are studied, not only COX-2, also like platelet activating factor, and so many molecules are studied. But at this point of time, the likelihood of benefit is still uncertain, and we don't have a clear, definite evidence of agent seems to be ideal. But in near future, we expect some agents to
But we showed that ORI-1, I think, again, looked very promising.
Yes,
let's see if they might be a good drug. Wonderful.
We move on to the next session.
Our next session on is there any role of ERCP in acute pancreatitis? I would like to request our chairpersons to come on the stage. Dr. Kaushik Shah, Dr. Kirit Parnas, Dr. Parth Shah, Dr. Supridev Mogdam, Dr. Pragnesh Goran. I would like to invite our speaker, Dr. Neela Mehta.
Over to Nilay Mehta, sir, for a topic of what is the role of GRCP in acute pancreatitis. As we all know, Nilay Mehta, sir, is well-known, renowned gastroenterologist from our city. And over to you, sir.
Thank you, sir. I thank and congratulate Yogesh and Dr. Gaspati for this meeting. I'll speak on something which is very important, ERCP in acute pancreatitis. So what are the indications? So what are the indications of ERCP in acute pancreatitis? Of course, it's biliary obstruction, but more importantly, if it is with cholangitis, sometimes we do ERCP in acute pancreatitis when there are pancreatic leak, ascites, fistula, and then there are early reports long time back where they used to do it with with necrotizing pancreatitis and feeding leaks. I would rather concentrate myself on biliary obstruction in cholangitis. But not everybody should undergo ERCP in patients of biliary pancreatitis. So when I talk about pancreatitis, I'll just speak to, I'll concentrate on biliary pancreatitis. The reason is obvious. ERCP is not absolutely safe, and that's why we never do nowadays ERCP for a diagnostic purpose. We know that ERCP can cause pancreatitis. In fact, when you have pancreatitis and you do ERCP, there are all the chances that the pancreatitis severity can go up. And of course, patient has complications like bleeding, perforation, sepsis, ERCP. Why this topic is important? Because first of all, as I told you, not everybody should undergo ERCP. The other question is when to do ERCP. Should we do ERCP when we see a patient and just put a scope? Early reports in 1980s used to suggest that early ERCP is indicated and is efficacious in severe necrotizing pancreatitis. So early ERCP was recommended for acute biliary pancreatitis. But again, the same question comes into mind. What are the indications and when should we be doing ERCP? You know that pancreatitis is a heterogeneous topic. It can be severe pancreatitis, it can be mild pancreatitis, it can be with cholangitis, with biliary obstruction or without biliary obstruction. So let's take and discuss this case by case. 40-year-old female has had severe abdominal pain a day back. When patient came to us, there was predicted severe acute pancreatitis because this patient had tachycardia, hypotension, hypovolemia, reduced urine output, counts were high, CRP was high, and there was jaundice. On sonography, and of course, CT should not have been done, but then even CT showed edematous pancreatitis with multiple gallstones, and there was CVD dilatation and suspicious calculus in lower end. So if we go for ERCP, no, what we did was we did endoscopic ultrasound, and you can see dilated bile duct, and momentarily you will see calculus at the ampulla. So this is basically a patient who is very toxic and has an infected stone at the ampulla. And no question, this patient should immediately go for ERCP. So this is the most clear-cut indication that there is a patient with severe hepatitis, there is a biliary obstruction at the level of ampulla, and if you don't do ERCP, this patient is going to go worse. So this is a clear-cut indication of doing urgent ERCP, and that is what we did. Many times we see the urgent or early ERCP. So urgent is within 24 hours, early is within 72 hours. That is what the definition is. But it is always reasonable to, when you see a patient, wait. Make the patient, if patient is hypovolemic, hypertension, if patient is cholangitis, then stabilize the patient. Without stabilizing the patient, if you try to do ERCP, what they have found out that there are high chances of respiration pneumonitis, and there are high chances of post-ERCP hypovolemic shock. And in fact, recently a study shown by AIG group that even if you have cholangitis, you have to make this patient stable before venturing into ERCP. So no ERCP blindly, don't rush into doing ERCP. Another case, 35-year-old female, abdominal pain for 3 days. Now, for last 12 hours, patient is abdominal pain free. This patient had mild pancreatitis. Bili was high, suggesting acute biliary pancreatitis. But within 3 days, bili has gone down. AST, ALT, which were high, has also gone down. Patient has had edematous pancreatitis, multiple gallstones, and CBD had shown 7 millimeter. So should this be do patient undergo ERCP? No. Why? 2, 3 reasons. One is patient is improving. Second, patient has mild acute pancreatitis. Third, patient's bilirubin and SGPT are going down. That means that even if there was a stone, of course, this patient has dilated biliary duct. So could be there is a stone, or could there be a stone passage? Most likely there is a stone passage because patient's bilirubin and SGPT has gone down. So this patient, I would wait. Even I would not go for MRCP, that is non-invasive test. I'll just wait because patient has mild pancreatitis, patient is improving, patient's bilirubin is going down, and when bili SGPT is going down, this patient has a very low likelihood of ongoing obstruction or stone. Even if there is stone, I would just wait, make the patient stable, and then do ERCP. So early reports, what I showed you in my second slide, what does it suggest? That if it is mild pancreatitis, in fact, ERCP is counterproductive. Third case, 40-year-old male patient. Patient has had acute pancreatitis for 5 days, for fever for 2 days, CT severity index 10. That means patient has severe pancreatitis, high count, high SGPT bili. CT scan was done on 4th day, showed necrosis, the multiple gallstones, bile duct dilated. So this patient has severe acute pancreatitis and possible inflammation or cholangitis, but no obvious CBD stone. Another case, 38-year-old female, pain, 4 days, severe pancreatitis, but this patient has CBD stone. So one patient has severe pancreatitis without stone, other patient has severe acute pancreatitis with stone, and both of them have high bilirubin. So what should we do? So this patient, should we do ERCP? If yes, which patient? If yes, then when? Urgent or early? Urgent again is less than 24 hours, early is less than 48 hours. So early reports, 80s reports, 3 trials, meta-analysis, what does it say? Severe acute pancreatitis, you do ERCP, it is beneficial. But if you see the meta-analysis over here, what does it say? Doing blindly ERCP in severe acute pancreatitis does not help because you do ERCP or you do conservative management, the results are same. So if there is no cholangitis, there is no point in doing ERCP. What if there is stone or obstruction? Same story, doing urgent ERCP. So the word is important. Urgent ERCP in this scenario, it doesn't make a difference. What does make a difference is early ERCP. That is means you make the patient stable. Once patient is stable within 72 hours, and if there is ongoing obstruction, how do you know ongoing obstruction? That means patient has bili, patient has pain, or bili is going up. That means patient has ongoing obstruction or cholangitis. Then early ERCP is beneficial in preventing complications and also in outcome. So early, if obstruction, no urgent ERCP is required, even if there is CBD stone. Just wait, see whether this obstruction is continuous obstruction is going up, whether patient is worsening. If it is the case, go and do ERCP again. Why? Because ERCP can do more harm than help you. That is what is shown by the Cochrane database. No difference in mortality or systemic complications in early ERCP if there is the acute biliary pancreatitis, if there is no cholangitis or obstruction. If there is cholangitis or persistent biliary obstruction, the word is persistent biliary obstruction, and that's why no urgent ERCP if you have stone. But if there is a persistent biliary obstruction, then you have to do ERCP. Same thing, what the European guideline says, it also says the same thing. But if there is cholangitis, you have to do urgent ERCP. So urgent means within 24 hours. But if it is biliary obstruction, again, biliary obstruction is defined as obstruction by imaging, obstruction biochemically, and obstruction clinically. If it is going on and on, then you do ERCP. But the true challenge is, it's easy to say, oh yeah, this patient has biliary obstruction or this patient has cholangitis. But to see, because you must have seen that most of the times you do sonography, you don't see a stone, you just see a biliary dilatation. You do a CT, even if there is a stone on CT, you can miss a stone in bile duct. Why? Because radiolucent stones are not seen on CT scan. So to pick up those scenarios where you need ERCP. So there are 3 scenarios. One where there is obvious jaundice, there is obvious stone, and this is high risk. But and then there is another extreme where the bile duct is normal, bilirubin was high, which has come down. And why it is important is not all bilirubin high means there is a CBD stone, because you know that acute pancreatitis itself, when there is edema in the pancreatic heart, it can cause biliary obstruction, and then that can cause dilated bile duct. That can also cause mild bilirubin elevation. And doing ERCP in this scenario is a disaster. So if you have a doubt, and that is what the intermediate proof is, that there is mild CBD dilatation, there is mild biliary dilatation, and or jaundice, SGPT elevation, then you need to confirm that this patient has obstruction cholangitis, and that can be done by two things. One is MRCP, which is non-invasive, and the other one is EUS. MRCP is a great test if the stone is more than 6 mm. But if it is less than 6 mm, it's not a great investigation. And there is a role of EUS. So EUS goes over MRCP if the stones are small, but otherwise it is the same. But EUS has better negative predictive value and likelihood ratio. So how do I compare MRCP? Yes, it is non-invasive, but if there is a small stone, it can miss. MRCP, many a times you know that acute pancreatitis patient, you ask to go for MRCP, and the radiologist will give you a call. No, he can't hold his breath, so I can't do MRCP. Or there is ascites and you can't do MRCP. So these are the scenarios, then MRCP is not useful. Many a times you've done MRCP, it has shown stone. You ask the gastroenterologist to do an ERCP, and you do ERCP, and then you don't see any stone. So all this scenario, there EUS is beneficial. So this is what the trial says. If you have a suspicion, a high suspicion of biliary obstruction, that US guided ERCP, that means if you do EUS, you see a stone, you do ERCP, has definitely an advantage. But routine US is not recommended. Same thing, routine US in all severe acute biliary pancreatitis is not required. Only in this indeterminate where you are not sure whether there is stone or not. So before doing ERCP, you can do US and then do ERCP. To summarize my talk, I would say early ERCP in acute biliary pancreatitis should be only done for cholangitis, if it is cholangitis, as early as possible, or ongoing obstruction when you can safely wait for 2-3 days. When biliary obstruction is in doubt, please don't hurry. You may do EUS or MRCP, and I told you when to do EUS and MRCP. And just near you have a CBD stone, you should not hurry up doing ERCP. You can still wait if the patient is not having cholangitis or his bili is going up. Make the patient stable and then do ERCP. Again and again, whenever in doubt, avoid ERCP. It is more dangerous to do an ERCP than not to do it. Thank you very much.
Excellent presentation, sir, as usual. So we are not going to take any questions like we are.
Thank you.
Thank you, sir, for the interesting talk. Now we have a keynote lecture on the good, bad, and ugly side of GLP agonists. I would like to call our chairperson, Dr. Maulik Kinnariwala, Dr. Ajay Nadmer, Dr. Sajjan Limbachia, Dr. Nilesh Top, Dr. Jayesh Pawara. I would like to welcome our speaker, Dr. Anil Arora.
Dr. Anil Arora is the Director of Gastroenterology at the Indira Hospital, and he will be giving us this interesting talk. Welcome, sir.
Good evening to all. And after a hectic, heavy, toxic dose of pancreatitis, let me move on to something which will ultimately allude to pancreatitis because most of these drugs do act on the liver. The topic which has been allotted to me is GLP receptor agonist, the good, bad, or the ugly of it. What are GLP receptors? It is basically a gut hormone which is released by the nutrient sensing neuroendocrine cells located in the upper and the middle and the lower part of the small bowel, which release a number of hormones called incretins into the circulation. This is in response to the food intake, particularly the glucose and lipids. So as soon as you consume something in your intestinal lumen, there is a release of incretin hormones, which play a key role in regulating not only the blood sugar and insulin secretion, as well as also affecting the energy metabolism. And once this GLP hormones or incretin hormones get into the circulation, they affect almost every organ system of the body, including liver, brain, heart, kidney, pancreas, etc. So by default, these are very small hormones measuring about 30 to 31 amino acids. As soon as they enter the circulation, they are acted upon by this enzyme called DDP4. I'm sure most of you would have heard of these set of drugs for diabetes called gliptins. So these are primarily the inhibitors of DDP4. So by default, GLP-1 hormones will have a very short half-life of 1 to 2 minutes. That means whatever they have to do within 1 to 2 minutes. Unless you substitute two amino acids and make a new substance called semaglutide. Semaglutide is a two amino acid substitution of a hormone called GLP or incretin, in which the half-life increases from 1 to 2 minutes to about 165 hours. That is 1 week. That is because of two reasons. One is you have substituted two amino acids. In addition, you have attached a side chain called dicarboxylic fatty acid side chain. So because of the two reasons, you have increased the half-life from 1 to 2 minutes to 1 hour. There is another hormone called GIP or glucagon-dependent inhibitory polypeptide, insulinotropic polypeptide, in which again by substitution, you produce a molecule called tirzepatide. I'm sure most of you will be well versed with this hormone called Mounjaro, which is the talk of the day. It's called tirzepatide, which again has a half-life of almost 1 week. It is said that GLP receptor agonists are not only useful in controlling diabetes and also treating and also causing weight reduction, but they are important and of use in plethora of conditions, including sleep apnea, arthritis, fatty liver disease, hypertension, dyslipidemia, and anybody with a bad lipidemic profile characterized by low HDL and high triglycerides. As of now, today we know that these are the first line drugs for our treatment of patient for weight reduction as an adjunct to the lifestyle modification, because as of today, the US FDA have approved it of its utility in patients who want to lose weight with a BMI to begin with if it is more than 30, or else if you have a BMI of more than 27 with one weight-related comorbidities like diabetes, hypertension, dyslipidemia, or sleep apnea syndrome. Are they really useful? The answer is this big yes. If you look at the trial published in Antigen Step 1 trial, compared to placebo, if you give semaglutide, you have a 14% or almost 15% total body weight loss. With side effects, it is pretty acceptable. So compared to lifestyle change, weight reduction of only 2.4%, you have a weight loss between about 15% in this publication. Not only do these drugs like semaglutide cause weight reduction, they have a substantial effect off target. They also improve the inflammation by activating the T cells. In addition to reducing weight, they also have shown to have improvement in vascular endothelium. They decrease the thrombogenesis in the vascular system. In addition, they also are known to cause decreased inflammation in the brain, leading to plethora of other advantages in patients with comorbidities like neurological diseases, like Alzheimer's disease, Parkinson's disease, etc. So not only do they act on the liver as well as on the pancreas, they have a lot of off-target effects which are useful in a patient who have a concomitant comorbidity. In fact, based on these results, semaglutide was recently tried in a subgroup of the patients who, in addition to having diabetes, had one pre-existing cardiovascular disease. That means they either had an MI, stroke, or a peripheral vascular disease. And if you see the results, within a period of about 42 weeks, there was a 30% reduction in the composite cardiovascular risk. That means the major coronary event, major stroke, or a non-fatal MI were 30% less in patients who were being given semaglutide compared to placebo. So here is a drug which is not only giving you weight reduction, it's trying to control your diabetes, but it has a major advantage of protecting your heart. New drug which recently been released is a drug called tirzepatide. It is a drug which is a combination of the GIP and GLP agonist, and you look at the staggering weight loss of about 20%. Compared to 2% in the placebo to 15% in the semaglutide, you have gone on to about 20% weight loss over a period of 72 weeks by this drug called Mounjaro or by Eli Lilly company. In fact, based on the same principle of the off-target effect, there is a recent publication called Surmount OSA trial in which these authors have tried to look at the utility of this drug in patients with obstructive sleep apnea syndrome. And there is a index called hypoapnea index or AHI. And if you look at the placebo versus tirzepatide, there is a 30% reduction in the episode related to the apnea and hypoapnea in patients who were being given tirzepatide. There is a molecule which is not only useful in control of the diabetes and weight reduction, but is also useful in a subgroup of the patient who have obstructive sleep apnea syndrome. So, ladies and gentlemen, this GLP-1 receptor antagonist, which have been variously named as liraglutide, semaglutide, and now tirzepatide, they have different names in patients when they were being treated for diabetes and weight loss. Liraglutide was referred to as Victoza and Saxenda in diabetes and for weight loss. Similarly, tirzepatide for diabetes was marketed as Mounjaro. Now, tirzepatide for weight reduction is now renamed as Zepbound. Similarly, semaglutide, when it was released for use in patients with diabetes, was referred to as Ozempic. But same molecule, when it is being used for control of the diabetes, is called Wegovy. So as of today, Wegovy or semaglutide is the first-line drug for a patient with obesity who wants to lose weight and has a concomitant cardiovascular disease, as has been shown that there is a 30% reduction in the composite cardiac risk. Recently, the publication of the Essence trial, which most of you would be aware of it, has clearly shown that this drug has also very good benefit in patients with MASH, and hence after resmetirom, this is the second drug which has been approved by US FDA for treatment of MASH. Similarly, in patients with tirzepatide, in addition to obesity, with concomitant obstructive sleep apnea, the US insurer will try to give you this drug for use in patients with obesity and obstructive sleep apnea. So I think clinicians in USA are trying to find out different reasons for getting this drug from insurance companies. So if you have obesity with cardiovascular disease, you can ask for semaglutide. If somebody has obesity with sleep apnea syndrome, then you can ask for tirzepatide. What about the relevance of these drugs over a long period of time? How long do they act? How long is the sustained action maintained? If you look at the long term, two issues are important. Are we able to sustain these drugs over a long period of time? And once these drugs are sustained over a long period of time, what is the side effects of its passage of time? Semaglutide studies have shown that if you continue this drug over a long period of time, you are likely to sustain weight. It is just like in any anti-diabetic drug or any anti-hypertensive drug. If you keep on taking the drugs concurrently, you'll continue to maintain the weight. But once you stop the drug, there is a good 30% chance, especially with tirzepatide and semaglutide, that the weight will try to come back. So as of today, the current status of different GLP receptor agonists compared to the bariatric surgeries, that drug like semaglutide, tirzepatide, and a new drug called uh, CagriSema, which is a amylin agonist, which is another GI hormone, which is going to be a part of our formulary in the next 5 to 10 years. You can achieve a weight loss to the tune of about 24%, which will be going shoulder to shoulder with the bariatric surgery or endoscopic bariatric surgery, which is going possibly out of the work with passage of time. But these drugs do have side effects. They have a lot of GI side effects. They have a potential loss of lean muscle mass, and you need to use it for a long period of time in addition to health cost. Most of us remember that whenever you want to start one of these GLP receptor antagonists, it's not that it's one drug to start immediately. You have to start and build up the drug over the next few months. Any GLP receptor antagonist cannot be started on day one. You have to build it up over a period of time. And most of these drugs do require long-term usage to give you efficacy. And it has been shown that only 35% of these patients are likely to sustain the drug continuation over a long period of time. There are two major contraindications in which the GLP receptor should not be given. One is a multiple endocrine neoplasia, or MEN type 2, and a metabolic for the thyroid. We do not know the role of these drugs in pregnancy, but it has been clearly shown that the ladies with PCOS who are being treated because of obesity with GLP receptor antagonists have 3 times higher chance of getting pregnant. Because these drugs, they decrease obesity, they improve insulin resistance, and hence they are likely to be more useful. So weight loss, in fact, it is a very composite problem of not only difficulty in maintaining, but it is a relationship between the mind and the brain. And then there are so many confounding variables when you try to look at the variables. The genetics of the patient, the type of the food, the behavior of the patient, the stress, and so many other confounding variables which cannot be looked into by a single GLP-1 agonist. Look at the high cost of the GLP. If you see, at the moment, 7 lakh people in US are using GLP receptor agonists, but in next 10 years, 70 million of the US people are likely to be using this drug in future. And if you look at the cost of these drugs with the passage of time, it is an unending flow of the money. And all of us know that after the top tech companies like Google, Meta, and Nvidia, these Lilly and other companies like Novo Nordisk are likely to be competing head to head with these drugs. These GLP receptor agonists have side effects on almost every part of the body because they have pleiotropic effects. They are likely to affect thyroid, lung, gallbladder disease, intestine, muscle, etc. There have been various side effects which have been noted in different aspects of GI tract, like nausea, vomiting, pancreatitis, retinopathy, and so many lawsuits have been filed against these drugs. But suffice it to say that we have to exercise our caution in trying to give GLP receptor antagonism to the patient as a gallbladder disease, past history of pancreatitis, retinopathy, or patients who are taking sulfonylureas, because you are likely to have hypoglycemia. In addition, it has been mentioned that these drugs also lead to muscle loss. If a GLP receptor antagonist makes you lose 1 kg of weight, mind you, 300 gram of that will be muscle loss. It is said that 300-gram muscle loss may not be as bad because you are in any case 1 kg less than what you were, and you do not need that many muscle to propel you out. But there is a new concept which is coming up that this GLP-1 agonist, you can have this drug called bimagrumab, which is basically an antibody that blocks activin type 2 receptors, and that can prevent the loss of the muscle. There is also some suggestion that if you keep on taking 30 grams of protein diet per meal and do regular exercise, you are likely to have resumption of your muscle. So a combination of high protein in the diet, 30 grams per meal, just finish, is likely to give you a final answer. In patients with the GLP receptor antagonist losing muscle. Fracture and weight loss are another combination, and most of these drugs can be easily tolerated once you try to optimize the drug. Start with minimal dose. Do not take a lot of water with the drug and try to take less fatty meat. So these are the tricks of the trade which will help you tolerate these drugs with passage of time. And exercise, as I said, is likely to prevent uh, muscle loss which occurs in these subgroup of the patient. To sum up, ladies and gentlemen, pancreatitis, which was supposed to be one of the major side effects of GLP receptor antagonist, has been shown repeatedly that if you have found a cause of pancreatitis, past history of pancreatitis is not a problem in these patients with GLP receptor and agonist being given in medical therapy. To sum up, ladies and gentlemen, GLP-1 receptor antagonists are effective at delivering clinically significant weight loss and improving obesity-related comorbid disease, especially in a subgroup of the patient who have a concomitant cardiovascular disease. Drug of choice is semaglutide. If you have obstructive sleep apnea, tirzepatide is the drug of choice. Most of the GI side effects can be managed with proper medication, starting with a smaller dose, reducing fluid in the diet, decreasing the fat content in the diet. Cost may be substantial, but within the next 4 to 5 years, we are likely to have a generic drug coming into being, and that may be the finding. So these are the futuristic drugs, not only for us as gastroenterologists, but also physicians throughout.
Yes, sir.
Let's conclude the session as we are out of time. Only one comment at the last. It is a molecule hyped by the celebrities, and now it has been thrown out by the media. Let's see what is the outcome. Wait a minute.
Thank you, sir, for the interesting talk. Now we will move to our next session on esophageal malignancy symposium. I would like to welcome our chairperson, Dr. Shreya Butala, Dr. Hitesh Thakkani, Dr. Milind Prakashan, Dr. Bhavesh Thakkar, Dr. Vivek Tang. I would like to invite our speaker, Dr. Jeffrey George.
the outset, I would like to thank my friend Yogesh for the opportunity. So the topic for my today's presentation is esophageal cancer, early detection and endoscopic management. So histology-wise, we have two types of esophageal cancer. One is the adenocarcinoma and the other is the squamous cell carcinoma. The risk factors, the treatment, the prognosis, extremely different. For esophageal adenocarcinoma, which is a disease of the West, the risk factors are basically GERD, obesity, and tobacco. Whereas in India, the risk factors boil down to smoking, obesity, micronutrient deficiency, achalasia cardia, in which there can be long-standing inflammation, as in this variant, which leads on to squamous cell carcinoma, and lye ingestion and Plummer-Wilson syndrome. So there is a big global burden with half of the population from the East, the world. And the 5-year survival rate in esophageal cancer is very low, to the tune of 25%, and males being more affected. So why is the survival rate low? This is primarily because of two factors. One is the biology of the disease, and second would be the anatomical factors, which lead on to increased lymph nodal metastasis, because there is extensive lymphatic network as well as there is lack of serosa. So that is the reason exactly why we need screening for esophageal cancer, because the earlier disease stages in which it is a T1 cancer, in which you can see the T1 is actually the stage of the cancer which is limited to the mucosa and submucosa. The 5-year survival is almost 80%, whereas once it involves the second stage, the T2, which the muscle is involved, or T3, in which the adventitia is involved, the survival drops from 25 to 4.5%. So there is a critical role for early detection, which gives you a survival boost. And then the late stage perils of decreased survival can be mitigated. So people should be screened, and there should be a targeted screening. So at-risk individuals who are at high risk for esophageal cancer should be screened, especially with the surveillance intervals as documented for Barrett's esophagus, where they screen at 3 to 5 years intervals. But unfortunately, I think that is not there in India. And for screening of at-risk individuals, you have got advanced imaging techniques, and one is the high-resolution endoscopy, the high-definition endoscopy, which are the new generation endoscopes, the zoom endoscopes, which offer you 125 to 150x magnification. So the mucosal structure, the surface pattern, the vascularity of the lesions can be better delineated. You have the chromoendoscopy, which employs dyes, which can be used for both squamous and Barrett's mucosal delineation. And then the optimal magnification, which comes with this scope, helps you take targeted biopsies in which the delineation of the disease can also be much better. So this is a topical based chromoendoscopy, what we use for detection of squamous neoplasm. The dye is actually the glucoside, and it stains the esophageal mucosa yellow. And absence of mucosal staining can be used to delineate the squamous metaplasia or the squamous dysplasia. Similarly, for Barrett's esophagus, you have acetic acid. The whitening of acetic acid can be used to delineate the Barrett's mucosa. So having said about the diagnostic modalities coming to treatment, before going to treatment, you need to understand the tumor staging. As I mentioned, T1 involves the mucosa and submucosa, which is actually the treatment what we endoscopists do for endoscopic detection. T1 constitutes the T1A, which involves the lamina propria and muscular mucosa. And when it invades the submucosa, it is T1B. So T1 is the lesion which is amenable by endoscopic resection. For esophageal adenocarcinoma, the treatment indications would be any T1 lesions which are restricted to the mucosa and submucosa. And there is a subcategory for all T1A lesions of the mucosa, you can do endoscopic resections. For T1B, after resection, if the margin of the tumor, the vertical margin comes as more than 500 micrometers, you need additional treatment. So there is a subcategory within the T1B for adenocarcinoma. If the vertical margins stay positive, more than 500 micrometers on pathology, you need additional treatment in the form of esophageectomy or chemoradiation. Along with that, if you have any of these high-risk factors, like poorly differentiated histology or lymphovascular invasion of histology, again, you need to go for additional treatment. So, select T1B cancer patients in which the tumor depth is less than 500 micrometers can be eligible for endoscopic resection provided the patient is surgically unfit. So this is the group of people who can be managed with endoscopic resection. And these are the TN guidelines of thing. For esophageal squamous cell carcinoma, the criteria is a bit more stringent in that the squamous cell carcinoma, the lymph node metastasis is much more than compared to adenocarcinoma. And hence, the diagnostic criteria for endoscopic resection is more stringent. So, for all mucosal lesions for T1A, which involves the mucosa, excluding the muscularis mucosa, that is the M1 and M2 tumors in squamous cell carcinoma can be resected by endoscopic resection. Whereas if it involves the muscularis mucosa in T1 stage, these are amenable for additional therapy. This is because for M3 cancer, the lymph node metastasis is much higher, and with deeper invasions, the lymph node metastasis increases even higher. So these are the absolute indications, the T1A, M1, and M2 cancers, and the expanded indications, especially in surgically unfit, could be the T1A, M3 cancers, or even if it involves submucosa, it should be less than 200 micrometers as opposed to 500 micrometers in adenocarcinoma. So 4 risk factors for all cancers could be the Paris, the excavated lesions or the Paris protruding lesions, poorly differentiated histology, and presence of lymphatic or vascular invasion, which always contributes a negative risk factor for prognostication. And having talked about the endoscopic resection strategies, how do you resect? So we have 2 modalities of treatment. One is the endoscopic mucosal resection, which is a very minimally invasive technique. You use the help of an endoscope. There is a thin wire which is attached to an electrical current. You can inject saline underneath the lesion, and then this can be cut using the electric current. So up to 15 to 20 mm of lesion can be removed in one go. The advantage of PMR is that it offers lower mortality and morbidity. It's a very simple procedure. It's an outpatient rapid recovery times. Coming to ESV, so this represents a significant enhancement. The advantage of ESV is that it gives you an en bloc resection, but at the cost of technical expertise, it gives you enhanced precision, complete removal of the lesion with superior outcomes. So ESV can remove the whole of the lesion in one go compared to EMR and piecemeal resection, especially if the lesion is very large. So this was a lady, 70-year-old lady who presented with dysphagia to an outside center. They biopsied, it came an inlet patch with low-grade dysplasia. Because she had dysphagia and evidence of dysplasia on biopsy, she was referred for ESV. This was just below the cricopharynx, and this is how you do an ESV, similar to what surgeons do. You mark the lesion around, and then you have to carefully dissect by injecting saline, which is stained with methylene blue, so as to delineate the submucosal fibers. Always in the esophagus, the Japanese say that esophagus is the worst place to do any complications. So you have to be close to the muscle close to the mucosa as possible. The muscle has to be kept intact because any damage to the muscle, you are end up in complications like mediastination infections. So now, after having clearly delineated the lesion, dissecting the lesion from the muscle, the mucosa can be cut on all sides. You have excellent devices like clutch cutter from QG, which was used at this point. And then the whole lesion can be removed. And this is what the base of the lesion looks like. You have to have a clean hemostasis so as to prevent bleeding. Muscle has to be intact. And if you find any muscle injury, you can always approximate the lesion or cause the defect. And this is what you get. The whole lesion was removed. It's almost 2.5 centimeters. So whenever you have larger lesions more than 15 millimeters, it's always better to go ESD with that expertise. And comparing ESD with EMR, significantly higher en bloc resection rates, lower recurrence, and better results with ESD when compared to EMR. Adjunctive endoscopic therapies would be the radiofrequency ablation, which uses heat to coagulate the residual spastic epithelium, and you also have cryospray ablation, which uses liquid nitrogen, especially used in cases of failure of radiofrequency. So to conclude, the innovations in endoscopy and the advancements in endoscopic techniques have transformed the outcomes in the way we manage esophageal cancer. There's something to do with screening esophageal cancers, and PhD has come a long way in organ-preserving therapies, and a multidisciplinary approach is always recommended to embark on therapies, especially in esophageal cancer. With this, I conclude. Thank you for your patience.
Thank you. The topic will be direct focus to be very for each page. Will be and
Thank you, Yogesh, for having me here. I'm going to talk to you about Barrett's. Jeffy spoke to you about esophageal cancers in general, but talk about Barrett's. And is the scene foggy still, or is there a lot of clarity? What is Barrett's? Barrett's is basically the esophagus, which normally has squamous epithelium. If it has a metaplasia to columnar, you tend to call it Barrett's. But they had to have a big meeting to have a consensus to define what is Barrett's. So that's the first area where there's controversy. And because some people insist that there should be intestinal metaplasia. But we now to a large extent agree that if there is columnar mucosa in the esophagus, you call it Barrett's. We believe that there are three clinical phenotypes of patients with GRD. One with non-erosive reflux disease. Then you have those with erosive reflux disease, and those with Barrett's. Though some people believe that non-erosive can progress to erosive and erosive can progress to Barrett's, but that's not really what really happens. So Barrett's is therefore an acquired condition with columnar metaplasia. Now, if you have to say that there's columnar metaplasia in the esophagus, first we need to know where does the esophagus end and where does the stomach start. So if you look at the landmarks here, all three of them, the top of the gastric folds, the squamocolumnar junction, and what is called these palisading vessels, all are around the same area. So it's pretty easy to make out where the esophagus ends and where the stomach starts. However, when we do an endoscopy, this is what happens. You don't distend enough and you can't make out too much. You can miss lesions. If you inflate a little, you can make out the folds well, but the palisading vessels are not seen. But if you inflate more, you can find that the top of the gastric folds are here, and you can see the palisading vessels here. So this is dynamic, and hence one needs to do this examination carefully to have an accurate estimation of is there Barrett's, and if so, how long does it extend? Is there a hiatus hernia, or is there just Barrett's? What's the length of it can be measured, because the longer the length, the more the significance. So therefore, there are a lot of problems with interpretation, and unfortunately, over the last few decades, we have gathered tons of evidence which have very little value because we don't know whether what we have done has been the right thing or we've got all wrong data and we are basing our decisions based on this wrong data. So therefore, there's a lot of heterogeneity and poor understanding of that. Now, what led to we call it Barrett's? Should there be intestinal metaplasia? And I think of 6 societies here which don't seem to agree. Whether anything more than 1 centimeter or any length is called Barrett's, whether there should be intestinal metaplasia or not is again not very clear. So you realize that across the world, there is a lot of confusion about Barrett's. Now, should we do a biopsy for intestinal metaplasia? I personally think it's a waste of time because whether there is intestinal metaplasia or not, you're still going to call it Barrett's. Yes, the presence of intestinal metaplasia makes it a little more sinister, but the fact is, there's something called a 1 centimeter threshold. In this area here, if you have a very short segment of Barrett's, 1 centimeter or less, we don't know whether it's an intestinal metaplasia with G junction or it's an irregular G line. There's a very high inter-observer variability.
only 20% of endoscopists agree on what is the length of that barrage. And we also know that the risk of dysplasia is virtually nil. So I think ultra short segment barrage or barrage less than 1 centimeter, I think we should clearly forget. How common is it? We find that in Asia, the prevalence of barrage is increasing. Risk factors are GRD, hiatus hernias, smoking, and namesakes. We classify barrettes as long segment or short segment if it's 3 centimeters or more or 3 centimeters or less. So less is short segment, anything more is long segment. And of course, the histology can be just columnar epithelium, which is non-dysplastic, to the other extreme of advanced esophageal adenocarcinoma. But yes, whenever there is barrage, there's risk of adenocarcinoma, which is estimated about 11 times more than that of the general population. And that is where the significance is. What is the natural history? Unfortunately, that's not well known. We can't predict for an individual as to what to do. Does dysplasia resolve with PPIs? Not sure. Perhaps it may become less, but may not really disappear. But what we definitely know is that the longer the extent of the Barrett's epithelium, more the risk of adenocarcinoma. About that, there is no doubt. Whom to screen for Barrett's? GRD is the main factor, so it would seem logical that we would screen all those who have GR. But the unfortunate fact is that about 50% of those who have Barrett's have no GRD symptoms. So if you use that as a yardstick, we'll miss half the patients with Barrett's and therefore we'll not be able to screen them for cancer. So as a rule, what we do is we try to do the best possible to the circumstances. Chronic GRD, older men, smokers, those obese, we do an endoscopic screening. But if they have any of the so-called alarm symptoms, you definitely would screen. So as I said, the length of the Barrett's epithelium and cancer risk run parallel. If you have a long segment, the annual risk is about 0.2%, short segment, much less, ultra short segment, very, very low. So if you have to detect a cancer in a patient with a long segment, you have to screen about 455 patients to find one cancer. If for short segment, it's maybe 3,500 patients. And for ultra short, it's about 12 to 13,000 patients. So which virtually means that any screening program is very expensive and not very productive in these two. So question is, should we even bother about them or just focus on the long segment Barrett's? We are interested in Barrett's because we want to look for dysplasia and deal with it. So what has been recommended is so-called CIP protocol. You keep taking 4 biopsies every 2 centimeters throughout the Barrett's segment. They say you better do even every 1 centimeter. Almost impossible to do. Even in the West, not more than 10% of endoscopists are compliant. And in India, maybe Anil Arora is the only one who does it, but I'm not sure if any of us really do that. So what do you do? So we use advanced technology. And this is one of the things that you can look at this. This is cardiac sort of epithelium, non-neoplastic. This is with intestinal metaplasia, non-neoplastic. This is again intestinal metaplasia. You can't see the surface pattern, just the vessels. But here, this is certainly dysplastic. So you try to focus using advanced technology where it shows you dysplasia. How good is it? Very good. If you look at the negative predictive value, over 95%, which means that if an experienced endoscopist looks at it and says it looks normal, you need not biopsy. The chance of there being dysplasia is almost negligible. We can use acetic acid endoscopy. This is a segment of Barrett's. So you put acetic acid, the whole surface lights up, and it's very easy to look at it in 10 seconds and say, this looks normal. What else can you do? If you look at it in a patient who has got dysplasia, you can see this reddish area, which is loss of acetic acid whitening, and this is dysplastic. So when you see this, what do you do? Do you biopsy? No. When you see this, you resect. So any visible area that you see, you do not biopsy, just remove it. Because you can upstate the histology, what you think low grade, maybe high grade, maybe even cancer, and there's a good staging of the T1 cancers. So you can do an EMR, that we showed it, so I won't go through this video. But it's a very easy outpatient procedure. It is a good staging procedure, and plus you've got rid of the lesion elsewhere. This is what we found in that patient. So endpoint is what? You just remove dysplasia or to remove all the intestinal metaplasia. 40 studies clearly showed that the incidence of recurrence is very high if you only remove the dysplastic. So resect the dysplastic area and ablate the rest of the intestinal metaplasia. That is what should be done. So biopsy only if you have something that looks frank cancer, this patient goes for surgery. If it's a visible lesion, resect, and what is left, you ablate. To summarize, a lot of unresolved issues in definition diagnosis. Guidelines that are in place are based on very shaky data, very poor compliance and adherence because of this. Prevalence in Asia is rising, but so are our skills. So we must use our skills to make more important and better decisions. At least clarity in management is quite good. Thank you.
Sir, we'll take the
Excellent talk,
questions.
sir. Sir, please, please. Sir, please be on the stage, sir. Naresh, sir. Sir, please be on the stage. Questions will be at the end.
The next speaker is Dr. Vikas Singh from Max Hospital, Delhi. He'll be speaking on non-cancerous esophageal lesions, whom to treat and how to treat.
I will be discussing about the non-cancerous esophageal lesion. So this is an interesting case. Everybody gets a first diagnosis in this case. So this is a fibrovascular tumor of esophagus, collection inside the mouth, and sometimes this tumor can lead to laryngeal obstruction also and lead to asphyxia and sudden death also. So we will be discussing about the clinical presentation of esophageal non-cancerous lesion, but in differential diagnosis, and how we can remove such lesions. So as compared to malignant lesions, the benign lesions are uncommon and majority are asymptomatic lesions. They are a slow growing tumor as compared to malignancy, and mostly they present between third to fifth decade of life. The treatment is either follow-up or endoscopy or surgery, and they have excellent long-term outcome. So if we see clinical presentation, most of the lesions are asymptomatic, but when they got enlarged enough, they can lead to obstruction and dysphagia. And they can also compress the surrounding structure like larynx or trachea and lead to asphyxia or breathing difficulty. And as you saw, they can also lead to regurgitation tumor from the mouth. And sometimes on the lesion, there can be ulceration and bleeding. So the picture shows the layer of esophagus. Outside is the adventitia. This is the muscularis propria. Then there is submucosa. Then there is lamina propria and the epithelium and basement membrane. The known cancerous lesion can arise any of these layers, and the differential diagnosis will depend the layer of origin. So these are the most common differential diagnosis. The lesion which are intraluminally bulging mostly are the either papilloma or fibrovascular polyp. The intramural are the leiomyoma, diffusion cyst, hemangioma, and the granular tumor or duplication cyst. Then there can be extramural lesion like duplication cyst. So sometimes tubular nodes can also erode into the esophagus and give the appearance of lesion. So whenever we have a esophageal lesion, so first we should have a good endoscopic appearance, and this red line indicate the angle between the surrounding structure and the lesion. If the angle is obtuse, it means that lesion is deep, coming from the deeper layer. If angle is acute, it indicates lesion is superficial and coming from the mucosa or superficial submucosa. Then we should notice the color of the lesion. The yellowish lesions are likely to be lipoma. The bluish lesion can be varix or hemangioma. If the lesion is translucent, it can be lymphangioma. Next step is performing endoscopic ultrasound. Endoscopic ultrasound can differentiate whether it's a lesion is arising from esophagus or it's a node compressing from outside. Like here we can see there is a large node in the mediastinum which was compressing the esophagus and giving appearance of a mass lesion. And on EUS we can see the layer of origin which can tell us what is the differential diagnosis of the lesion. So these are the various examples of the non-malignant lesion. The first is the heterotrophic gastric mucosa. It's a gastric mucosa inside the esophagus. And on NBI, we can further see the what's the nature of the mucosa. This can produce acid and can lead to heartburn and the regurgitation. And this is the famous papilloma. This is xanthoma, cholesterol deposits. All these are benign lesions. Papilloma have a malignant potential. This needs removal. And this is the hyperplastic lesion likely due to GRD. And again, a benign lesion. These are sebaceous glands in the esophagus. And this is the glycogen deposit. And we can see on iodine staining, glycogen is taking up the iodine. It's a benign lesion. So these are all the epithelial lesions. Now coming to the subepithelial lesions, again they are incidental, mostly asymptomatic. Overlying mucosa will be normal, and mostly they are leiomyoma or duplication cysts, but sometimes they can be cysts also. So leiomyoma are mostly incidental, diagnosed during endoscopy. They arise in the fourth layer, muscularis propria, and they are mostly seen in middle and distal third. Upper one third has a striated muscle layer, and the leiomyoma arise from the smooth muscle layer. That's why they are more common in the middle and distal third. And the malignancy is uncommon in leiomyoma. On immunohistochemistry, they are positive for desmin and smooth muscle antigen. And rarely they can lead to dysphagia and chest pain. If the lesions are large enough, they may require surgery. So here we can see after opening the muscle layer, we can see there is a leiomyoma which need to be removed. And the mucosa should be intact. Otherwise, there can be leakage after the surgery. So surgeon just remove the tumor from outside, leaving the mucosa intact. And the lesion less than 3 centimeters can be followed up. If the patient is not willing for the follow-up, then we can do the endoscopic dissection with the third space endoscopy. So what is third space? Third space is a submucosa. This layer is expandable. Normally thickness is less than 1 mm. But when we inject fluid inside the layer can be expanded to 10 to 15 mm layer, and scope can enter inside the layer. So this is how we remove the leiomyoma by endoscopic technique. So first we inject fluid inside the submucosa, then we make a tunnel. On one side of tunnel is the mucosa, one side is the muscle layer. And the scope is inside the submucosa, and the tumor is arising from the muscularis propria. And once we make tunnel on both the sides, the tumor can be removed. Here we can see a leiomyoma in the lower esophagus. So first we inject fluid proximal to the lesion. So we can see this expanding layer is the mucosa. Then we give a incision, selective incision on the mucosal layer. Then we make a tunnel. You can see we are going inside. So this is the mucosa which is attached to the neomyoma. And so we will dissect the mucosa from all the sides. And in the last part, we can see the tumor is attached to the muscularis propria. And with the IT knife, we can detach the tumor from the muscularis propria and whole tumor can be removed. And the initial incision can be closed with the clips and with a watertight plate. Nothing can enter and patient can be start on the diet very extra. And here we can see again patient had lesion, and this is the at the G junction along the lateral curve. It's the exophytic lesion. So again treated by stir technique. So we gave injection proximal to the lesion, then selective incision on the mucosa. Then we enter inside. Very difficult to find where is the lesion. It's the exophytic lesion. But with the careful dissection, we can see a bulge here. But most of the tumor is going outside into the mediastinum. So here we are dissecting tumor from the surrounding submucosa. Last part is created of muscle from the tumor from the muscle. Whole tumor can be removed. So this is the removed tumor which was going in outside into the mediastinum of the tumor. The other lesion is a duplication cyst. Around 2.5% of lesion they can be duplication cyst. Malignancy is uncommon in duplication cyst and they occur arise from the foregut, mostly asymptomatic. For symptomatic lesion surgery can be done and patient not willing for surgery, endotherapy can be done. And on EUS, we can see there is a homogeneous content and there is a acoustic enhancement. So this is cyst and beyond the cyst, there is a acoustic enhancement where it can be a duplication cyst. So this video I have taken from article by Dr. Chavan and Dr. Sanjay was, I think, author in this. So very interesting technique. So first, so it's very duplication cyst. First, inject fluid proximal to the lesion, then give a selective mucosal incision, then go inside. Here you can see this is the duplication cyst. So this is the duplication inside the third layer. So once you puncture the cyst, you can see the fluid is there. Fluid is coming out. So then whole cyst is the whole this is towards the mucosa. So the whole wall of the cyst is excised. Then clips are applied, touching the mucosal margin with the margin of the cyst. So that otherwise there will be reformation of cyst. So here we are clip has been attached between the mucosa and the margin of the cyst. This is after follow up. There is some cavity there, but no fluid inside. So this is by the stir technique. Other is the guide wire assisted technique. Again, very interesting technique. So here the cyst is punctured with the 19G needle and wire is placed inside. So the needle inside, then wire loop is made inside. Then over the wire, incision is given over the cyst and the mucosal layer. Then we can see it's the vertical incision. This is the inside of the cyst. So this technique called fenestration of the cyst. So this is the end of the wire. So till the end of the wire, both the cyst wall and the mucosa will be incised. And last part is again same, attaching the margin of the cyst with the mucosal margin. So this is guide wire assisted treatment of duplication cyst. Another very interesting technique again for duplication cyst. So large cyst again, patient had dysplasia. So first, so this is the cyst there with the post acoustic enhancement. The function of cyst, then place a stent inside the cyst. Make a wire loop, use cystotome, then place a stent. Now over the stent, the mucosa and the roof of the cyst can be inside. So stent will act as a guide, and you can see pressure flows there. And the whole roof and the mucosa will be cut. So this cyst will be connected with the esophageal lumen. And again, we can see attaching the clip connecting the margin with the mucosa. So three excellent techniques for treatment of duplication cyst. Another tumor is the granular tumor. It's again a rare neoplasm arise from the submucosa. It has yellowish appearance and it has a malignant potential. So it should be removed and it should be removed by endoscopic submucosal dissection. We give a incision all around, then we separate the lesion from the muscle layer. Here we can see a granular cell tumor in the figures. And first we give a incision all around the lesion, mark the lesion, then give a incision all around. Some submucosa will be dissected. This submucosa, the tumor is on the right side, the left side is the muscle layer, and submucosa is connecting muscle to the mucosal layer. With a careful dissection, the mucosal side will be, so you can see here, this is the mucosal side and that's the tumor there. And tumor will be removed. So this is called endoscopic submucosal dissection. Then for the lesion which are arising from the superficial submucosa or the mucosal layer. And the last tumor are the fibrovascular polyps. They are seen most mainly in the upper esophagus, arise in the proximal esophagus. There is some mucosal thickening, and they achieve long dimension due to peristalsis may come out from the mouth, and they can lead to laryngeal obstruction and can lead to asphyxia. On endoscopy, they have fleshy appearance, and they can be treated with the EMR, ESD, or polypectomy technique. So to summarize, the non-malignant lesion of esophagus are uncommon as compared to esophageal malignancy. Most lesions are asymptomatic, incidental, diagnosed during the endoscopy. Large lesion may have dysphagia and the bleed. Leiomyoma is a common lesion, can be treated with the surgery if large, and the smaller leiomyoma can be treated with the technique. Epithelial or the superficial submucosal lesion can be treated with the ESD technique, and duplication is large, can be treated by surgery or endoscopic penetration. Thank you very much for your patience.
So, Vikas sir, please have a seat. The question will be taken in the lab.
Now next, in the line is regarding metastatic regions, particularly in reference to therapeutic intervention centers. So I call upon Vinod Sharma.
Thank you, Indro. Thanks for the talk. So from benign to malignant to catastrophic. And usually the topic given is of ventilation. The topic is when not to do stenting. Interesting.
So the topic is metastatic esophageal carcinoma. Do all patients need stenting? Now this slide summarizes what esophageal cancer is. Patient presents for you do a barium, you see a stricture, do endoscopy, see a lesion, take biopsy, malignant cells. And then you can stage the tumor with the help of CT or the PET CT. And this is the survival statistic. As the disease progresses, the survival drastically plummets down. And once they develop metastasis, the 5-year survival is less than 5%. So what is average survival of these patients who develop metastasis due to esophageal cancer? The median survival in India study is nearly 6 months. And the prognosis is even worse in those patients who are old in age, have poor performance status, and varieties of meds that will go back, take your protection. These patients do not do. The irony is, by the time they approach us, they already have developed metastasis. And as I have 50% patients have either distant lymph nodes or metastasis at the time of presentation. So by and large, they are beyond cure, and what we can offer is a palliative treatment. This is the definition of palliation, National Cancer Institute definition. Those patients where we cannot offer a cure, we just intend to give them comfort and give them that is the very definition of palliation, and this is team. Now, what to palliate in esophagus that proves metastatic? It is the dysphagia which we need to palliate, and this is the most complicated. This data shows up that those patients who present with obstruction, and if we are able to maintain esophageal lumen patency, they do well, and their survival is better, as you see along line here, comparing to those who have persisting obstruction of esophagus. And when question of palliation of dysphagia comes, instantly the thing which comes to our mind is stent, because this is a very efficient way of palliating. So what are the advantages of stenting? It provides rapid release of dysphagia. We can immediately start nutrition. It has shown to be improving survival and offering the benefit is patient can eat and taste the food. Now, coming to question given to me, do all patients of esophageal cancer, metastatic esophageal cancer need stenting? So I would divide these patients into 3 types of patients. One who don't need stenting. The second group is stent. We can do stenting, but we need perceivable policy. And then outright contraindications for stenting. Those patients who are unfit due to their cardiovascular comorbidity, or they are terminally ill, or if there is perforation or peritonitis or distal obstruction, they are unsuitable for stenting, and these are these from the contraindication. Now coming to first 2 questions. Do all patients need stenting? The intent of stenting is to relieve dysphagia or to increase the frequency fistula. We've seen that 80% patients present with dysphagia and 40% do not have dysphagia. So obviously these 20% do not qualify for stenting. So stenting is now, among those 80% who present with dysphagia, do all of them need stenting? So if we are able to maintain nutrition by modifying diet despite dysphagia, because there are problems with the stent, stent may migrate. If there is tracheal infiltration, stent may push the tumor towards trachea into tracheal compression and airway compromise. There are problems with bleeding. In long-term tumor growth is there, bolus infection can be there, which is the stent. There can be development of places of fistula if region is high up, or if we are crossing G junction and aspiration, and sometimes during the procedure or after the procedure, there might be a complication. So these are the stent-related complications. How common? Very common. 1 out of 10 stent will migrate. 1 of 5 stent there will be need for re-intervention, or we might need stent to remove the stent because of pain. There is risk of mortality also. So stents are not without any complication. And we can divide these complications into immediate, during implantation, early within a week, and delayed after a week complications. And these complications need re-intervention. Now, timing of these intervention, as time increases, the frequency of intervention increases. And after 13.5 weeks, that's more than 3 months, the intervention rate reaches up to 26%. That is, 1 in every 4 patients will need one intervention or other. So this data suggests that those patients who are life expectancy more than 3 months, they will develop more complications and there will be more need of re-intervention. So stenting is not suitable for these patients who have life expectancy. They are not the candidates. So what do we do for them? What can we offer? There are alternative therapies available where the intervention rate requirement is low. Radiotherapy is such good modality where dysphagia relief, though it is slow, 50% in 2 weeks and 90% in 10 weeks, but once patient dysphagia is relieved, the interventions are required. So they can be offered for radiotherapy. And this is the suggested algorithm. If patient is poor performance status, they are not suitable for radiotherapy and any other therapy, stenting is option. Or if their survival is less than 3 months, then it's option. Other patients, we can offer radiotherapy and stenting. Now, second group, where we have to exercise caution when we are stenting, is these group of patients. This is the long list. Let us go one by one. So for perforation may be caused by tumor itself. It may be caused by stent, or it may be because of radiotherapy. Small perforation, the stent is very efficient in killing that, and it is the treatment of choice. But in large perforation, stenting doesn't help much. It doesn't work. Tracheal infiltration by the tumor. You can see in this CT that only a slit of trachea is left. Most of the trachea has been invaded by the tumor. And this is poisonally law. The rule suggests that as diameter decreases, the resistance to flow, it goes up drastically. Means if we reduce the diameter from 4 to 2, the flow decreases from 160 ml per second to 10 ml per second. So it goes to the tune of 4th power of R. And once tracheal infiltration is there, if we put in a stent here in esophagus, it will push tumor towards trachea and it might become complete. So stent is not a good option. If we are planning a stenting, we have to place the stent in the trachea first and then esophagus. Upper esophageal malignancy, if they are very high up, the problem is that stent may lead to risk of respiration. There will be constant foreign sensation. There will be throat pain, and we need at least 2 centimeter margin from post-record area for the stenting. So we have this. Very lower down, if tumor is there, if you have to cross T junction, then risk of aspiration is high. So we have are available, but we need to. The question of radiotherapy after stenting. Radiotherapy after stenting leads to more complications of perforation, aerodigestive fistula, and stent migration. So this is again a subset where we need to take option. And if we do radiotherapy and then we do stenting, then chest pain problem is more frequently observed. So if with stenting, if we need to go for radiotherapy, high dose radiotherapy cannot be used and we have to go for radiotherapy. And this is some of the cases, sometimes tumor invades in meningeal nerve that leads to vocal cord palsy. If we place in a metallic stent, like further nerve compression might lead to bilateral vocal cord palsy. This might be likely. So this, I would like to conclude by highlighting these points that dysphagia is a dominant symptom of esophageal cancer.
Patency of esophageal lumen is associated with survival of this patient, and gold standard is esophageal stenting. But those who have not their dysphagia, asymptomatic patient, if dysphagia is manageable with modification of diet, plus if life expectancy is increased, this is the group of the patients who need stenting. And there are situations where we need to caution while while stenting, means large perforation, tracheal infiltration, upper esophageal or lower G-junction tumor, and high dose radiotherapy, gland, and these are the group where we have to exercise caution. But obviously, we have to take care of everything. Thank you, sir.
Thank you. Thank you, sir. Please have a seat. We will take two questions. Everyone's talk seems to be very lucid and informative. So if there are no questions, we'll move to second next session.
Thank you, sir, for the interesting topic. Now we will cover the miscellaneous topics. I would like to invite our chairperson, Dr. P.R. Modi, Dr. Darshana Makwana, Dr. Kirit Kumawat, Dr. Parth Shah, Dr. Ishit Shah. Our first topic will be on the esophageal development anomalies and its management. I would like to welcome our speaker, Dr. Sandeep Pal.
Good evening, everyone. Welcome to the last session of the day. From the cancerous, non-cancerous, metastatic lesion of the esophagus. Now we are going to learn something miscellaneous about esophagus, not miscellaneous, but very important things to learn. Developmental anomalies of esophagus by Dr. Sandeep Pal. I invite you, sir, for the talk.
Good evening, everyone. Again, I would like to thank Yogesh for this opportunity. So my topic is congenital anomalies of esophagus and management. It's a very vast topic, very difficult to cover it in 10 to 15 minutes. But I will just discuss the salient features and the main management of these anomalies. So the overview of my talk, initially I will discuss a little bit about the embryology of the esophagus, followed by the congenital anomalies. So if we go back to our embryology days, we'll remember that this esophagus, this forms during the 4th week. A small diverticulum appears near the ventral wall of the pharynx. And thereafter, a tracheoesophageal septum gradually separates diverticulum from the dorsal part of the foregut. And this dorsal part of the foregut forms the esophagus, and the ventral part forms the respiratory primordium. And up to 4th week, it's very short, and then it elongates rapidly due to the descent and development of heart and lungs. And by the 7th week, it reaches its final position. Its lumen is completely or partially obliterated due to proliferation of its epithelial lining. So whenever there is some abnormality in this growth or separation of the dorsal and the ventral primordium, then these various types of congenital anomalies result. And recanalization occurs by the end of the embryonic period. If the recanalization does not occur, then we have esophageal stenosis and all these various types of anomalies result. We'll discuss that one by one. And its muscles, the muscle of the esophagus usually develops from the surrounding mesoderm. And if we divide the esophagus into 3 parts, it is striated, that the muscle is striated in the upper 1/3, it's mixed in the middle, and it's a smooth muscle in the lower 1/3. And these esophageal anomalies, the various development anomalies, they are usually associated with lot of other anomalies like cardiovascular, genitourinary, musculoskeletal, and a bacterial association. And what are the bacterial associations? These are vertebral defects, anal defects, cardiac defects, tracheoesophageal fistula, renal, and limb defects. And sometimes hydrocephalus also can be there, which then we call it bacterial age. So let's come to the first esophageal development anomaly, that is esophageal atresia. So esophageal atresia usually does not occur alone. Esophageal atresia is almost always associated with the tracheoesophageal fistula. So esophageal atresia is the failure of the esophagus to form a continuous passage from the pharynx to the stomach. And the liquid that a baby swallows cannot pass normally through the esophagus and reach the stomach. So it's usually, as I said, it's associated with tracheoesophageal fistula. We'll come to this classification later. Now let us discuss a little bit about the tracheoesophageal fistula, which is the second development anomaly, commonest. So tracheoesophageal fistula, it's an abnormal communication or connection between the esophagus and the trachea. And it is a birth defect, which is an abnormality that occurs as a fetus is forming in the mother's uterus. So as adult gastroenterologists, we see a lot of tracheoesophageal fistula that are secondary to various diseases like malignancy, tuberculosis. But what I am discussing here is the congenital abnormality. So when a baby with tracheoesophageal fistula swallows, they develop violent cough, and as they develop pneumonia, lungs infection. And this is pictorially depicting this type of distal tracheoesophageal fistula. And it's the incidence is 1 in 3,500 births with slight male predominance. And esophageal atresia with or without tracheoesophageal fistula is common in prematurity, with 30% and 34% of the cases weighing less than 3.5 grams. So most of these fetuses are premature, and approximately 50% of the neonates have other anomalies also. So this is the classification of tracheoesophageal fistula, where the most common is type C, where there is proximal atresia with distal fistula. It makes around 85% of all the anomalies. And rest isolated esophageal atresia or proximal fistula with distal atresia, the double fistula or isolated fistula, this around 1 to 5%. The etiology of this tracheoesophageal fistula or esophageal atresia, there are certain risk factors in which they develop, like there is excessive maternal alcohol and smoking, exogenous sex hormones, exposure to methimazole, prolonged mechanical ventilation, because maternal polyhydramnios, or if the mother is diabetic. And the pathophysiology is a defective separation with a deviated or incomplete septum or incomplete fusion of tracheal folds, which results in malformation of trachea and esophagus. As a clinical manifestation, as the name suggests, that the child will have or the infant will have cough and chokes, fluid returns to the nose and mouth, sinuses can occur, the infant fails to thrive, and there is excessive secretion coming out of nose and constant lower respiratory tract infections. Diagnosis usually is from the history and physical examination. Endoscopy can help, X-ray, ultrasound, CT scan, all can help. So how can you prenatally suspect that the child is going to have this tracheoesophageal fistula? The ultrasound examination of the mother, if it shows polyhydramnios, then we should think that there might be a tracheoesophageal fistula. So this antenatal screening is very important. Fetal MRI also can be done. And postnatally, of course, if the patient has this typical, infant has got this typical clinical features, then its diagnosis becomes easy, and you can do bronchoscopy can help in diagnosis. Sometimes you can try to put a NG tube, and as it will be very difficult to pass the NG tube into the stomach. So here are two test X-rays which can help us diagnose. You can see in the right-hand side, which is a pure esophageal atresia. There is no fundal gas shadow. Whereas this is the most common type, as I told, esophageal atresia, still tracheoesophageal fistula, which we call types. So management is to, of course, constitutional treatment, supportive management. You have to treat pulmonary infection and put a gastrostomy tube, acid suppression therapy, head end of the bed should be elevated, antibacterial therapy, all these are there. But the primary treatment is surgery. So that the primary, I'm not going into the details of surgery, I'm not a surgeon, but the main treatment of this is surgery. And these surgeries usually, a lot of complications can happen in these surgeries, like there are early complications and late complications, which we should know, like anastomotic leak, anastomotic stricture, there can be recurrent tracheoesophageal fistula, GERD, tracheomalacia, all these are the complications that can occur due to this surgery. Let's come to the third type of congenital anomaly, that is congenital esophageal stenosis. It's a rare anomaly which results from incomplete separation of the respiratory tract from the primitive foregut at 25th day of life. And it is again characterized by intrinsic narrowing of the esophagus, secondary to congenital malformation of esophageal wall structure. Again, the clinical manifestations are same like dysphagia, postprandial vomiting, and if the lesion is very high up, they can present with respiratory symptoms due to aspiration. Diagnosis again in history and along in esophagogram, you can do an esophagogram which will show that distal obstruction of the esophagus. This is how the esophagogram or the endoscopy looks in these patients of congenital esophageal stenosis. Again, in esophagogram, you can find a concentric aperispaltic asymmetric narrowing the upper lid of the distal esophagus with the presence of the stenosis. And that can be proximal dilatation also. Endoscopy can also help in diagnosis. Endoscopic ultrasonography can show thickening of the muscle of the esophagus. CT and MRI also can help with diagnosis. The important differentials of congenital esophageal stenosis is gastroesophageal reflux disease. Achalasia is also a differential diagnosis or foreign body or neoplastic causes. Management again depends on the degree of stenosis. The primary treatment is surgery, and sometimes you can have endoscopic dilation or excision also. The esophageal duplications is just now because as explained in his talk, he has explained about this esophageal duplications is. This also forms at around 3 to 4 weeks of gestation. Depends on the size of the duplications is. If the size is very big, the patient, the infant can usually these patients esophageal duplications they present in adulthood also, and it depends on the size of the cyst. So this is a diagram which shows the esophageal duplication. And around 80% of the cases are diagnosed during childhood. Most of them are found in the mediastinum and manifest themselves as separate masses along or in continuity with the native esophagus. Intramural esophageal cysts are considered very uncommon in adults, but we do see on and off these patients esophageal with dysphagia and diagnosis in esophageal cysts. And again, the clinical manifestations are dysphagia, respiratory distress, failure to thrive, abdominal pain. Various imaging can be done to diagnose US, and US is helpful, CT, MRI, when endoscopy can show that lesion in the esophagus. The management is surgical enucleation, also endoscopic management, because has already shown, I'm not going to know the details of that. Next, esophageal webs or rings. This is very common. Very often when you do endoscopy, you see esophageal webs or rings. These esophageal webs can be there in the proximal esophagus as well as in the distal esophagus. This is how it looks. Husky rings, Husky B ring. There are 3 types of rings, A, B, C. And usually it's found in the distal esophagus. So these are the various rings, A ring and B ring and the C ring. Diagram. The B ring marks the proximal part of the pattern. Then sometimes you can find this type of picture also in the entire esophagus. Multiple rings can be there. A ring is usually a muscular ring, which is proximal to the squamous junction. It's located around 1.5 centimeter proximal to the squamous junction. B ring very often we see this ring. Often these patients they are asymptomatic. Sometimes they might come with symptoms. Treatment is very simple. You can just dilate it. Sometimes with the passage of endoscopy also it gets dilated, especially the proximal rings. And the C ring is a rare anatomic finding of radiographic studies referring to indentation caused by diaphragmatic tuna. Is rarely symptomatic. And these rings can be congenital. It can be associated with iron deficiency. It can be developmental abnormality. Sometimes with inflammation also we can see. As I said, usually asymptomatic. Sometimes they can present with dysphagia, again, barium swallow, endoscopy. They can all help to diagnose. Management is usually you can use acid suppression therapy. Sometimes dilatation is can be required, or sometimes you can do endoscopic sterectomy also. Pediatric achalasia, I may not discuss achalasia cardia. All of us are well advanced with achalasia cardia. But if rare, like a small percentage of cases, they can develop congenitally. They manifest in the initial childhood or infancy. And this is a motility disorder which is due to the loss of ganglion cells in the esophageal nerve plexus. Again, the presentation will be dysphagia, diagnosis, variant, swallow and endoscopy, management, you can do either endoscopic dilatation, OEM, or surgery is laparoscopically applied. Then there is again, this last two slides. Again, there is echinacea of the upper esophageal sphincter, which is also known as cricopharyngeal dysfunction. It's a swallowing disorder caused by poor coordination or incomplete relaxation of the cricopharyngeal muscle. Again, the manifestations are same like dysphagia. Diagnosis is by variant swallow and esophageal manometry. Management is by dietary modification, dilatation, botulinum toxin, or cricopharyngeal myopathy. Then there are certain rarer anomalies like congenital diabetic lung of esophagus, tracheomalacia. I'm not going into the details of that. Then there is another another condition called congenital short esophagus. The manifestations are usually same. So to summarize, these developmental esophageal disorders present with specific symptoms and require a high index of suspicion for early diagnosis. Sometimes if you are going advanced with this, you can diagnose it in the antenatal period also. Multidisciplinary approaches required very often require the help of surgeons, radiologists to diagnose this and treat. And treatment advances modern techniques, including minimally invasive surgery and endoscopic procedures, have significantly improved outcomes. Thank you.
Thank you so much, Dr. Power, for that wonderful presentation. I think we'll have the questions at the end of the session. And the people, yeah. I think we must be waiting for the dinner and people sitting here like esophagus. So we're in between the food and the stomach. Then the food has to pass through the esophagus to reach the stomach. So the next speaker is Dr. Jibin Dev Sharma. He's going to speak for effective for absent esophageal peristalsis and manometry, dilemma for surgery.
Much thanks Yogesh for having us here. So we have throughout the day talked of a lot of intrinsic diseases of esophagus. We talked of malignancy, benign disorders, plasia, and today we'll talk of something which is actually an extrinsic disease creates this disease, and then there's a lot of issues that we manage it. So today I'll talk of corrosives and how corrosives will actually cause injuries to the esophagus and what are different stages. We all have seen different kind of corrosive injuries in our practice. Broadly, it can be because of the acids or alkalis. The injury itself is much higher with alkalis simply because they cause more of a refractive necrosis, whereas acids will cause more of a coagulation. Alkalis by nature are having they are kind of odorless, they are tasteless, so higher volumes are taken in. They have a different anatomical and different areas of injury. Somehow in India, acid is more common, whereas in the West, it's the alkali which causes the more predominant injury. But nowadays, we have newer agents of injury also. Can somebody tell me what these are, these colorful materials? These are one of the commonest cause of alkali injury now in India. And in the West also for that matter. So these are the pods that you actually put in the washing machines or in your utensil washers to wash your clothes or to wash the utensils. And they, if taken in, can cause a very, very bad kind of an injury. Something more new, something which is very fancy. So this was one of my patients who had taken a cocktail of liquid nitrogen and he had a gastric perforation happening which required an immediate surgery. So these are some of the newer things which you will now see as we are developing into a better economy. Indian studies has been over the years, as I said, predominantly acid is something which is common in India. I think this is across India now, north and south, mainly because acid is easily available in India as a toilet cleaner. But if you actually see the various, it's young, which is predominantly affected. Males are the commonest. In adults, obviously, it is more of a accidental or a suicidal injuries. it has high morbidity and high mortality. Recent data also confirms an acid predominance. And in COVID-19 time, we had some increase in the intentional ingestion in some of the areas. So what are the factors which define corrosive injuries before we go on to the endoscopy and surgery? We need to know what amount has been ingested, small or large amount. What has been ingested, at what concentration, what was the pH, how long it has been there. Was the food there or it was an empty stomach thing? In what form? If it's liquid, it's bound to have more injury. If it's powder, commonly it will be a local injury in the mouth. If it's very acidic, it will cause more injury in the mouth and pharynx. Alkaline, it will go down into the pipe. So there are three different phases of whatever that has been taken. You have an acute phase, there will be a subacute phase, there will be a chronic phase. Acute means life-saving. Patient might be in trouble, immediate mortality is possible. Subacute means healing. And in chronic is what we will commonly see as pictures and where we come to our best management. This is how actually it comes across. In an acute phase, it's mainly the critical care, the ICU, the physicians which have to manage these patients here in the first 48 to 72 hours. Then it's supportive care. If you have to scope it, the first question, when do I scope my patient? You scope it here. Don't go beyond 3 days. You don't want to put a scope in this area where there are maximum chances of circulation. Patient has, at this point of time, the most serious thing that can be is the perforation. This is a different will require immediate surgery. Here, there is no rule of endoscopy except for a assessment of the severity. So, in an acute phase, stabilize the ABC. Don't put a Riles tube blindly. Do a CT chest if possible, and endoscopy within first 24 hours, and emergency surgery if you have any life-threatening event. Once you decide to put the scope in, there is something called the Zerger classification where we classify that how deep the injury is. This actually has a role in predicting that how many of these patients will actually develop strictures later on. So you can tell your patients what to do. Let me show you a video. So this is one of my patients we did last month. And you will see here, this patient had taken an alkali. He was an adult, elderly male. It was an accidental intake. And you can see even the pharynx, the epiglottis, everything is actually edematous. The arytenoids also show injury. The first site of injury here is in mouth or the oropharynx system. The moment you enter the esophagus, you will see a lot of sloughing and you will see a lot of areas of necrosis. Okay. All of this area is completely, the esophagus is quite bad. And as soon as we go towards the stomach, you will see injury here also. And this patient also has a stomach injury with small bowel, this mucosa is gone. Fortunately, the small bowel was. So your patient may have injuries at multiple places and gets seen. In subacute phases, once you have seen what is the injury, then the role of surgery comes. In a patient like the one I showed you, they will not do with the oral feeding. You have to put them in FJ. So FJ becomes the life-saving to maintain their nutrition over next 6 weeks till the time to do something about it. In case the stomach is still okay, you can pass a Riles tube and feed through that. If not, an FJ is something which they might be requiring. In the chronic phase, you will have fibrosis, you will have a stricture formation. That's where our role comes. Now, the actual question of endoscopy versus surgery. Let's talk of corrosive strictures. So, endoscopic options are actually the first choice. In a corrosive induced strictures, you have to understand that they are more complex. They can be longer. If you can see this particular image, you will have much longer strictures happening in case of corrosive injuries. So these patients require multiple sessions of dilatation with a higher rate of recurrence. What are the options? You can do a boogie, that means a several deflection, or you can do a balloon. For longer strictures, it is better to use a boogie and you will follow something called the rule of three. But you can see the recurrences are much higher. As compared to non-corrosive strictures, the recurrences are the number of sessions required are higher and the recurrences are much higher. These are the kind of things we use. These are
Example of a Savory Gillard dilator is the CRE balloon that we actually use. Both are useful, broadly speaking. The only difference is that the balloon dilatation is slightly less painful to the patient. Otherwise, outcomes are equal across the globe when we do randomized trial. And symptomatic relief is same, the recurrences are same, perforation rate is same, but the pain is much less with the CI. These are the videos. In the first one, you will see, this is the picture here, around 8 weeks, I'm passing a CRE balloon. Inflate that. To the right side, you have one more picture, and we pass in a wire, and then you do a Savory dilatation using a fluoroscopy. And after that, you can put in a scope again and check. Here's the balloon being inflated. The picture is being dilated. This side, assessment of the wire down. Now, when do you plan surgery? Surgeries are for all these things. Endoscopy has failed. You have done close to 10 sessions. There's a complex anatomy, long strictures, multiple levels, non-negotiable strictures. You can't pass a wire across, nothing goes down. You had a perforation or there is a TOC. Nutritional and quality of life failure, coexisting gastric outlet obstruction, and there's a doubt of a malignancy. So all these are actually indications to when to go for surgery. Now the question comes, what surgery and when? Once you have defined a surgery indication, you can do two broad things. Either you can do a esophageectomy with reconstruction, or you can bypass the native esophagus. That's the easiest thing for the surgeons to do and something which they are very used to. So the common thing that is done is a colon interposition by leaving the native esophagus inside. Having said that, we have to understand that if you leave esophagus inside, that's prone to develop malignancy after a few years. You can also do a pull-up or a jejunal interp. This is common done in pediatric age group, but in adults, this is the commonest thing. But the problem, again, one third of surgical patients will also develop recurrence at the site of anastomosis. So if you see here, across all different kinds of surgeries, almost 27% can actually develop strictures to the tune of some around 10%. So stricture rate is still there even if you do surgery. This is an example of one of my patients who had undergone a colonic interposition. This is actually a colon, which you can see here. Unfortunately, after the pharyngocolonic anastomosis, patient still developed a stricture here. I have passed the Riles tube through that stricture to maintain its patency, and I try to keep on dilating. A patient has already gone a long history of 10 to 15 dilatations. Then a surgery, now a recurrence at the site of surgery. In terms of another stricture, we are still on Riles tube. We are still not able to feed. And these are actual patients which we see at our referral center, difficult to treat, and some of them are really like nutritionally depleted. So we can either the option is we can keep on dilating them more, every session going and forth. But what we now do for such patients is we take them on the OT, we pass the wire through the mouth into the sphincter, create an incision at the colonic sphincter position, say subcutaneous, and we do a single fitting dilatation to the level of 15. So you can do this in case in an OT in a more controlled setting, otherwise you're not able to do that. So in terms of corrosive strictures, what we really have to understand that the endoscopic therapy is still the first line. 50 to 60% will do okay, but there is a good chance some of them will fail. You will require them more. There are some more endoscopic therapy. Something like, for example, for very tight strictures, you can use steroid injections, or you can use a knife to give incisions. Rarely we also use stents for it, but that is still more difficult patients. Surgery is reserved for refractory cases, gastric pull-up or colonic interposition. In commonest ones, we still have one for recurrence rate. Anastomotic leaks during the surgery is what drives the stricture formation actually, but we require an individual conduit selection as a team effort across the board. These are some of the difficult strictures of which will be. Thank you.
Thank you, Zubin. Very informative talk. Please have a seat. We'll take questions of the.
Thank you, Dr. Trubin. It was a very then I couldn't tackle. Yes, you are right. The first relative structure accommodation. The biggest problem is when it's study. Now I invite Dr. Venkata here to give his talk on esophageal disorders by infection, medication.
Okay, so the last talk of the day, and I'm between you and your dinner. I know that, and I am so very honored to have two of my teachers in the chairing, Dr. Modi sir and Darshana. They have been, instrumental to what I am today. Uh, so this topic is a very common problem in our day-to-day OPD. So these are esophageal disorders which are caused by infections, medication, and trauma. So I bring you greetings from Bhavnagar, and this is going to be the flow of my presentation. First we'll discuss medication-induced and trauma, and then finally infection. So coming to medication-induced disorder, so the incidence is 3.9 per 1 lakh population annually. Most commonly affected people are the middle-aged women. They occur with very commonly used medication, and although middle-aged women are most common, but it can occur at any age. The most common symptom is chest pain, often pleuritic. And such patients do come to the OPD with, and they can mimic symptoms of acute coronary syndrome, pulmonary embolism, or even GERD. So very common antibiotics like doxycycline, clindamycin, penicillin, rifampin, tetracycline. These are all agents which can lead to drug-induced esophageal injury. Antiviral agents, biphosphonates, alendronate, etidronate. These can lead to chemotherapeutic drugs. NSAIDs now, it's very common for people to take over-the-counter NSAIDs, and they take pride in swallowing the tablet without water. So, these are the patients who end up having drug-induced esophageal injury. Some very common things: ascorbic acid, ferrous sulfate, even lansoprazole. So these agents can lead to drug-induced esophageal injury. Potassium chloride, quinidine, theophylline, MMF. So there are multiple mechanisms which are listed for causing this esophageal injury. One is the direct drug toxicity which occurs with tetracycline. There can be a production of caustic acid which occurs due to ferrous sulfate or an ascorbic acid. These drugs themselves are acidic. So, and similarly, biphosphonates are alkaline in nature. So that leads to an alkaline. We have already heard Rubin telling about acid and alkaline induced injury. So similar injury at a lower scale can occur in the esophagus. Also, hyperosmolar solution like potassium chloride can lead to esophageal injury. And there can be drugs which actually affect the esophageal motility or promote stresses or reflux, like calcium channel blockers that can lead to esophageal injury. So the most common differential diagnosis, I have had patients who have undergone an angiography and then come to me, and then finally, when we did an endoscopy, we found actually drug-induced esophageal injury. So uh, it can be very confusing. Sometimes patient comes with chest pain and some kind of dysphagia or adenopagia, but patient can come only with chest pain also, and that can lead to a diagnosis of and pulmonary embolism, and GERD is another differential that we need to consider. So this is a tetracycline induced esophageal burn which has happened, and that patient presented with dysphagia and adenopagia and chest pain. There are various patterns of uh, injuries described. So there can be kissing ulcers in the middle third of esophagus. There can be kissing ulcers with spontaneous bleeding. There can be coating with drug material. Okay, that has a particular name which is called esophagitis desiccans superficial. So EDS is the term which is used for such a picture which is given in the panel D.
This is one of my recent patients, young boy, who came to me with chest pain, but did not he had a ECG, it was negative, and he had a history of taking NSAID before a few days, and he took it without water and then immediately lied down because he was very tired. After he was a sportsman, but you know, after the game he was feeling very tired and having body ache. So he just took the pill and he kind of slept after that. So probably the pill might have stayed in the esophagus and caused this kind of injury for him. There are certain indications where you need to hospitalize the patients, where the patient has severe odynophagia, which prevents oral hydration, alimentation, and this may require IV therapy as well. It can complicate into having bleeding, stricture formation, perforation, or fistula formation. In this case, we need to hospitalize the patient. Now, the most important thing is how to prevent. Prevention is always better than cure. So whenever patient takes any medication, it is always imperative that we ask the patient to take any medicine, tablet, capsule in an erect posture and drinking adequate ml, at least a glass of water along after the pill. And the patient should not lie down for at least half an hour after taking the pill. For esophageal motility disorders, using a liquid form or a dispersible medication in water is advisable. And liquid form of pill or sugar coated or film coated tablets, they uh, have shorter esophageal transit time, so they can be better. Now we come to trauma induced esophageal disorder. So it is less than 1% of trauma cases, but it has a very high mortality and morbidity. Any esophageal perforation is potentially life threatening. It depends, the mortality depends on the location and the presentation. The reason for esophageal injury, trauma to cause esophageal perforation or injury is rare because of the position of the esophagus. So behind the esophagus, you have the spine and you have so many structures in front of the esophagus. So actually esophagus is one of the most shielded organ in the body. So what is the most common cause of esophageal trauma, however, is iatrogenic. Okay. So endoscopic procedures is number one in causing esophageal trauma. So upper GI endoscopy, EUS, because the EUS probe is relatively a bigger probe. ERCP scope is actually a bigger scope, and part of the procedure is blind because you are not looking at the esophagus and then entering inside. So this, and particularly some therapeutic endoscopic procedures like dilatation, ESD, POEM, these are all procedures which can lead to iatrogenic esophageal trauma. Surgeries like fundoplication, esophageal myotomy, thoracic surgery, anterior cervical discectomy, these all procedures can lead to esophageal trauma. Certain simple procedures like transesophageal echocardiography, cardiac ablation, endotracheal intubation, so common procedure done in the field, just by a less experienced person, it can lead to esophageal trauma. Nasogastric or nasojejunal tube placement done in the wrong way can lead to esophageal perforation. Trauma per se is less common, but you have two types of trauma. Penetrating trauma is very common in our part of the Gujarat, in Bhavnagar. We have a lot of sword injuries in Bhavnagar. So, but of course, these injuries are also associated with injuries to the heart, to the lung. Before it penetrates the esophagus, it penetrates the other vital organs. So, esophagus is also, and blunt trauma is generally an avulsion injury in a road traffic accident. And either sharps or gunshot wounds are responsible for penetrating trauma. So in trauma also, where sharps are more responsible for esophageal injury than blunt. Other causes are foreign body like swallowed dentures or sharp button batteries or caustic materials, bolus infection. It can lead to wall ischemia and then lead to esophageal injury, malignancy, or spontaneous esophageal trauma, barrow trauma, which we call Burhouse syndrome. When a patient retches forcefully or vomits forcefully, that can lead to spontaneous esophageal tear. The main clinical symptom is esophageal severe chest pain. Severe chest pain, it can actually mimic an aortic dissection, and patient may also have hematemesis or duodenophagia. The very typical sign is subcutaneous emphysema. In fact, there's a triad which is described, which is pathognomonic, but however, it is rare, seen in only 1 in 7 cases, which is called Mackler's triad. Presence of subcutaneous emphysema, chest pain, and vomiting. So it should lead to a high index of suspicion for esophageal trauma. There is a sign which is heard in 50% of the cases, which is called Hammond's sign. Systolic crunching or rasping sound, synchronous with the heartbeat heard over the pericardium. Screening investigation would be a chest X-ray, but investigation of choice is a CT thorax with a thin non-ionic contrast. Other modalities less commonly used are contrast study or upper GI test. There is a grading given for esophageal injury. I'm not going in the details. The basic management is first resuscitate the patient, prioritize, localize the injury, and then achieve either by surgery or by some other technique you achieve closure of the wound, or in certain cases just a drainage and allow spontaneous healing. So in operative principles, you have to achieve excellent exposure, debride the non-viable tissue, perform primary closure, two-layer buttress vascularized muscle, and wide external drainage. Cervical esophagus, you approach by the sternocleidomastoid muscle, and sometimes even small drainage, spontaneous healing can occur when it is just a minor tear. Thoracic esophagus, you have to do a thoracotomy and do a two-layer closure. GI compression and nutrition is very important. So this is the algorithm. I'm not going into the detail of it. Very importantly, we see infectious esophageal disorders. Primarily occurs in immunodeficient patients, organ transplant patients on chemotherapy, diabetes, corticosteroid use, or inhaled corticosteroids. Main complaint, duodenophagia and chest pain. And diagnosis is confirmed by upper GI endoscopy, KOH found for fungal infection, or biopsy plus or minus immunohistochemistry. Very briefly, I have just 2 slides left. So Candida esophagitis, very common. Duodenophagia is the key feature. Oral thrush is present in 2/3. Diagnosis is by endoscopy. First line treatment is fluconazole. Dose is 200 to 400 milligram orally for 14 to 21 days. IV may be used if the patient is not able to swallow the tablet. And other azoles. And in pregnancy, azoles are contraindicated. So in pregnancy, we need to use amphotericin B. Code C classification is a classification for the candidial esophagitis. I'll skip that slide. HSV and CMV esophagitis are basically reactivations. They are present in the body and they occur in at-risk patients in either HIV or post-transplant patients. The timing, however, is different, and this requires endoscopy with cytology or biopsy plus IHC for confirmation. HSV is treated with acyclovir or valacyclovir, and immunocompromised patients need a longer course or up to 21 days. Whereas CMV is treated with IV ganciclovir or oral valganciclovir for 21 days. Alternatives are foscarnet or cidofovir. So in conclusion, a high index of suspicion is required for diagnosing esophageal disorders. Management should be guided by etiology, withdraw offending medications, give supportive care for field-induced injury. Early intervention is the key in traumatic infectious cases to prevent severe outcomes, and multidisciplinary approach wherever required, particularly in esophageal trauma. Thank you very much.
Gentlemen, please be okay with me. Yes, ma'am. Any questions are welcome for this. Actually, we kept it at the last, but then this is one of the most commonest things which we encounter in everybody's life.
Subin sir, what the one slide you shown, that subcutaneous following conformation. It's a common we normally do here in the retreat. So nowadays, do they do subcutaneous following position?
Within that method that I think would be very wonderful. And practically, if I actually think it's not a bad option, it's definitely easier access. Some of these cases that we did, we did this thing in a single name. So for me, it was something very useful. Rather than again doing 10 more sessions with one time job. Very fine.
Vivi, what is the ideal time for the exam session? Active injury. What is the role of steroids? When to start? And how long to continue?
Regarding the first question regarding the FJ. So as I said, if patient has a concomitant gastric injury, otherwise stable, like they doesn't have any airway or anything, they can upfront go for an FJ. Otherwise, we can put an NJ or the stomach NG when we are doing the index endoscopy within 15 days. Ideally, first year before. Blind NG, I will not recommend any corrosive. If otherwise it is stable, you don't put into the just put an FJ upfront, that's fine. But then do endoscopy after probably 4 or 6 weeks once you are sure that. But ideally, if patient is possible, you should do one. It's not only diagnostic, it's to assess severity, it is to give prognosis. So I think it's required. Steroids, I think there is no data to say that different injectable steroids. The only way is if you have a refractory speaker, you can probably do a intravenous steroid injection. Sometimes it helps, that helps for all benign stages, not only for corrosive. But somehow, in my experience, for corrosive, the results are not great as compared to other stages like this condition. Don't give anything once we are not being sure about what's going on. No milk and no. Earlier, we should give those charcoal milk. Absolutely. We conclude this session, and before we have our dinner, there are few announcements that tomorrow morning we'll be having clinics in gastroenterology by Dr. P.S. Chandrasekhar, a very renowned gastroenterologist from our country. And it is an half an hour session with variety of cases on pancreas. So we expect all of you to attend and come here at 8:45. And before we go for dinner, we would start with our inauguration and award our community doctors who have done so well for the benefit of our society. So I hand over to Sharon. She is an administrator at our hospital. Sharon.
I, Sharon Christian, on behalf of Noble Gastro Hospital, warmly welcome you all to the 7th Advanced Gastro Summit. Now we are going towards the inauguration and awards distribution ceremony. I request our special guests to please come on stage for the ceremony. First, I would like to call Dr. Yogesh Harwani, Director of Analysis, Dr. Naresh Bhatt, Chief Gastrologist and Hepatologist, Bangalore, Dr. Nilesh Desai, Director of Tissue Space Application, Dr. Praveen Rai, Professor of Gastrology, Dr. Purushottam Harwani, Director of NIG, Mr. Ravi Bhandari, CEO of NIG, Dr. Nehal Shahil, President of APA, Dr. Harshad Patel, Secretary of APA, Dr. Dinkar Goswami, Treasurer of APA, Dr. Rahul Patel, Mr. Siraj Raghal, Dr. Harshal Patel, Dr. Varun Shukla, Dr. Partha Patel, Dr. Shivji Jani, and Dr. Sanjay Rajput, gastrologist. Please come on stage. Now we are going towards for lamp lighting. Lamp lighting is the symbolize the light of knowledge, wisdom, and new beginnings.
विनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दन दीपज्योतिः परब्रह्म.
Now I request all the dignitaries to please take the stage and Dr. Naresh Bhatt, Sri Nilesh Desai, and Dr. Praveen Rai, please remain. I request Dr. Parshoshan Bhaglani to felicitate our guest, Sri Nilesh Desai, Director of our dignitary. Why? He's a professor Department of Gastroenterology at SGPGI and Lucknow. He has published extensive, over 130 publishers in the field of gastrology and endoscopy. He is known for his work in advanced endoscopy procedures and academic and clinical gastrology, gastrology and further training. Thank you, Dr. Naresh Bhatt. He is a gastrologist. 3 decades of experience. Next picture, expertise in advanced endoscopy and extensively research, training, and patient care. Dr. Naresh Bhatt is recognized as a leading authority in gastrology in India. Now, for Sri Nilesh Desai, is the director of and space scientists contribute greatly to India's space research and scientific mission with over 39 years of service. He is a gold medalist from LD Engineering College. He has lead major research projects like research, ISAT and Chandrayaan. He has distinguished several awards, including the ISRO Excellence Award and Dr. APJ Abdul Kalam Award for his outstanding contribution to India's space project. Now, I would like to call on stage Dr. P.R. Modi. Please come on stage, sir, for the big round of applause. Dr. Krishnikant Patel, MBBS General Physician from the Ahmedabad Foundation. Dr. Ramesh I. Patel, MBBS and Senior General Physician. Now I introduce our all three awardees. Dr. P.R. Modi, he is a consultant and laparoscopic general surgeon. Dr. P.R. Modi is a legendary professor since 36 years of service, credited with personality, training over 8,000 successful surgeons, profound shaping surgical standards worldwide. His legacy rests on 2 pillars: building generation of surgical leaders and pioneering accessible healthcare. Through his impeccable career,
He is a rare force excellency as both a master educator and tireless humanity. I also like to introduce Dr. Kant Patel. He is the MBBS general physician, trustee of our Ashirwad Foundation. Ahmedabad Foundation is known for his medical center, education center, pharmacy, and community service center. Dr. Krishmakant Patel is an exceptional MBBS doctor known for his extraordinary general practice, which features unparalleled diagnostic skills and a deeply patient-centric approach to complex primary care. He founded and run the Ashirwad Foundation, channeling his medical expertise into wide-ranging public welfare, experts focus on community health access and education. Now, for Dr. Ramesh I. Patel, he is the MBBS Senior General Physician. Dr. Ramesh I. Patel is a highly esteemed senior family physician with 42 years of practice in the Paladi area. Dr. Ramesh I. Patel currently serves as Vice President of the Sanjeevani Health and Relief Community, one of the India's leading healthcare NGOs for over 2 decades, and has maintained 30 association with TRL and Canara Bank. I also like to share with you that मैं हिंदी में बताना चाहूंगी इनके लिए कि सर मोस्टली सारे विलेजेस में पुअर विलेजेस में फ्री में सर्विसेज देते हैं केयर। वो अहमदाबाद में, खेड़ा में और गांधीनगर में संडे फ्री में हेल्थ कैंप करते हैं पुअर लोगों के लिए, उनकी सर्विसेज के लिए, उनकी केयर के लिए। वो अपना टाइम एक्सपेंड करते हैं और उनकी सर्विसेज actively contributes his expertise during times of nature and communities. Thank you so much, sir, for here. All three dignitaries, Sri Nilesh Desai, sir, Dr. Praveen Rai, and Dr. Naresh Bhatt, sir. Please give the award to Dr. P.R. Modi, sir. Dr. Kant Patel, sir. Ramesh R. Patel. Now with this, complete our inauguration and award ceremony.
So this is a very, see, nothing can be reciprocated. Every doctor is doing good, but see, we have to respect our own community and keep on promoting it. So this was a small gesture from our side. And before we depart for dinner, please join us again tomorrow at 8:45. 8:45. Take your breakfast and be here. Thank you. And also who are staying here, you will receive a call at 7 o'clock in morning. So please don't get irritated. Thank you, everyone. Thank you.